यहाँ कौन बैठेगा? नाम बता दीजिए। स्मिथ।
Hello. Hello. Good morning. I'm audible. Hello. Audible or not?
Yes, sir.
Okay. So
Yes, sir.
start. Okay. Good morning, all of you. So in this session, e-paper presentation, I like to invite Dr. Devraj and just a second.
Yes, sir, I'm here, sir.
Okay. And Dr. Sangeeta. Hello. Dr. Sangeeta is there. Dr. Sangeeta, ma'am. So, Dr. Devraj,
Yeah,
start
I'm
your
here.
interview and
Good
continue
morning.
the session.
Okay, great.
Hello. Hello. Good morning.
Good morning, madam.
Good morning.
Sir, we can start.
Yeah, you
Yeah.
can start. Yeah.
The title of my paper is a comparative evaluation of patient-controlled analgesia with nurse-delivered analgesia in post-operative pain relief and their effect on pulmonary function after coronary bypass grafting surgery. The postoperative pain is known to have significant effect on the recovery of patients. Patients recovering from coronary bypass grafting procedure bear intolerable pain due to incisions over
Hello.
skin, muscle, sternotomy, chest tube incision site,
Hello,
and
good
cephalic
morning.
vein harvesting sites. This is reported to cause tachycardia, hypertension,
I'm
weakness,
audible?
thrombotic complications, fear, anxiety, nausea, vomiting, and insomnia.
Hello.
Because of the pain due to sternotomy, patient has rapid shallow breathing leading to pulmonary complications like reduction in the operational capacity of lungs,
Audible or
lack
not?
of cough, and subsequent accumulation of lung secretions, atelectasis, and pneumonia that can further worsen the clinical outcome. Therefore, management of postoperative pain becomes a priority for healthcare professionals. The scientific literature reporting the effectiveness of PCA and NDA in postoperative pain relief is present. However, the effect on pulmonary function after CVG surgery is limited. The presence fails to fill the knowledge gap and thereby contribute to the medical literature. The aim was to compare the effectiveness of PCA with NDA in postoperative pain relief in their effect on pulmonary function after CABG grafting surgery. Objectives: the primary outcome was to compare the effectiveness of PCA and NDA in the postoperative pain relief after CABG surgery. And the secondary outcome was to evaluate and compare the effectiveness of PCA and NDA on pulmonary function after CABG surgery. It was a randomized control trial conducted at Kalinga Institute of Medical Sciences, Bhubaneswar. Approval was sought from Institutional Ethics Committee and it was registered under CTRI. These are my inclusion and exclusion criteria. Now, sample size was taken as a total of 150 according to the referred article here. However, due to the ongoing pandemic of COVID-19, we could only enroll 104 participants. Simple randomization schedule was performed and randomization number was generated using randomizer.org. The intraoperative anesthetic management of the cases were done according to the departmental protocol for CABG surgery. Two groups were done, Group N and Group P. Group N received injection morphine 0.1 milligram per kg body weight IV every 4 hourly by nurse after 1 hour extubation. Group P received injection morphine administered through PCA pump at a bolus rate of 1 mg per demand with a lock-up interval of 10 minutes. Injection morphine will be administered by IV route till 48 hours of extubation in both the groups. Pain was assessed via the visual analog scale. Mean VAS scores were calculated at rest, deep breath, and at cough. Bedside pulmonary function tests were done for 60 hours post extubation with a gap of 12 hours between them. These are the mentioned bedside pulmonary function tests. And the total morphine consumption was collected from the data stored on the PCA infusion pump's memory. The number of patients under 50 years of age in NDA group at 3 and in PCA group at 16, 51 to 60 years were 19 in NDA group and 20 in PCA group, 61 to 70 years were 25 in NDA group and 9 in PCA group, and 70 years of age were 6 in both the group. The number of male patients in NDA were 38, female patients were 33, whereas in PCA group the number of male patients are 15 and female patients are 18. Comparison of pain score at rest showed that in all the duration of significance were observed NDA group at higher VAS scores than PCA group. Comparison of pain score during deep breath showed the duration where significance was observed NDA group at higher VAS scores than PCA group. Comparison of pain score during cough showed that here significance was observed NDA group had higher VAS scores than PCA group. These are the tables. In first expected time, initially at 0 or both the groups had value less than 3 seconds for all the subjects. Patients from PCA group took lesser timings than patients of NDA group to convert from less than 3 seconds to more than 3 seconds. During Sabris's breath holding test between NDA and PCA group, patients from PCA group took lesser timings than patients of NDA group to convert less than 15 seconds to more than 40 seconds. During Sabris's single breath count between NDA and PCA group, patients of NDA group took more duration to turn into normal from the abnormal count of less than 30 counts. During watch and settles of test between NDA and PCA group, patients of NDA group took more duration to turn into 4 seconds compared to PCA group. During volumetric spirometry, patients from PCA group took lesser timings, that is at around 24 hours, then patients of NDA group took 36 hours to have normal volumetric spirometric performance. These are the tables. The study reported that incidence of nausea and vomiting in NDA group to be 35.8% and that in PCA group to be 29.4%. It is also observed that side effects like urinary retention, excessive sedation, and constipation was reported by 3 patients individually in each category in the NDA group. The study, the results of the current study demonstrate that at rest and during deep breath, the VAS scores were comparable between the groups at baseline, but all other recorded time intervals NDA group had higher VAS scores than PCA group. When observed for pain intensity during cough from mean value, it is evident that at 0 or PCA group had higher VAS scores than NDA group. In rest of the duration where significance was of the NDA group had higher VAS scores than the PCA group. Similar results were reported when it was observed that PCA pump regulated pain better than nurse controlled analgesia according to Lagdizazi et al. Conducted during 2012 in Peterson et al. During 2000. The study results show that in the mentioned bedside pulmonary function test, patients were allotted in PCA group. They carried out lung function tests were more easy and earlier when compared to the patients in NDA group. Finally, it was seen that application of the PCA pump after open heart surgery could improve pain control and also help the patient improving the pulmonary function. Now, because of the beneficial effects also in regard to degree of satisfaction to the patient in using lower dosage of morphine for appropriate pain relief and bringing down the inherent side effects of morphine, PCA systems can be recommended for cardiac surgery patients as it appears to be superior than the standard nurse-based pain therapy. These are my references. Thank you.
Hello.
Hello. Hello, ma'am.
Hello.
Hello.
You are divided this into randomly divided into PCA and NDA group.
Yes, ma'am.
So, is there an education criteria for PCA group or not? Patient
Yes,
education.
ma'am. Actually, pre-operatively, ma'am, the patients of the PCA group, that was the patient control analysis group, mostly they were advised regarding how the pump is going to function and how they are going to press the button and how the pain, how the analgesia is going to be provided to the patient. So most of the patients who were like able to understand, they performed and they understood it better. But ma'am, one thing was that most of our patients were recruited, they were from the rural areas. So one issue that we faced in this study was regarding this education thing, ma'am.
Yeah, that is the main thing in PCA group.
Yes, ma'am.
Yeah. Is there any complication in PCA group then?
Ma'am, in PCA group, there were no such complications. Like since the dosage was less as compared to the NDA group, so the side effects that we thought like the pruritus and the nausea, vomiting, and constipation was recorded less, ma'am, actually.
Yeah, less in PCA group. Yes. Actually, we thought because of over enthusiasm, patient will deliver the more the doses.
Actually, ma'am, we had a lockout period of.
Yeah, you have a lockout.
Yes. Yeah. So anyway, if they even try also.
So like your conclusion, patient delivers less doses as compared to NDA.
Yes, sir. Yes. Yes.
Very good.
Thank you.
Here the patient delivered does it mean patient delivered and nurse delivered? Nurse delivery was based on the patient demand or was it a fixed protocol?
No, it was on the body weight, sir.
But when in PCA, whenever the patient needs analgesia, he will press the button. Yes, but how about in the nurse group? Was it an patient demand or a fixedly a fixed interval it was given?
Actually, sir, in the nurse delivered, we are applying it around 0.1 mg per kg body weight every 4 hours, sir.
Okay.
And like if the patient in between had any kind of breakthrough pain, like we administered tramadol, sir. And anyways, in the all the patients group, they were receiving a 1 gram paracetamol IV 8 hours.
Okay, right. So can we move on to the next
Yeah.
session? Okay.
Thank you, ma'am. Thank you, sir.
Good evening, judges. My name is Dr. Siddharth, and I am presenting a randomized controlled trial to assess the post-operative analgesic efficacy of facial iliaca block versus pericapsular nerve root block in patients undergoing hip fixation surgery. Hip fracture is a common orthopedic emergency, especially in the elderly, associated with severe mortality and morbidity. Hip fixation surgeries such as dynamic hip screw and proximal femoral nailing are the modes of management for the same. Severe pain associated while positioning the patient for spinal anesthesia as well as in the post-operative period. Therefore, various modalities of analgesia such as epidural catheter, periarticular injection, and site-specific peripheral nerve blocks are there. Peripheral nerve blocks such as femoral nerve block, facial iliaca block, 3-in-1 block, lumbar plexus block, and a newer modality known as PEG block have recently been discovered. Since the comparative studies between continuous facial iliaca block and PEG block are lacking, therefore the aim of our study is to assess the post-operative analgesia using the numerical rating scale at rest and in movement in patients with facial iliaca block and PEG block undergoing hip fixation surgery at 0, 4, 8, 12, and 24 hours. We also analyze the mean difference in NRS at positioning for spinal anesthesia and also calculate the 24 hours post-operative analgesic consumption. It was a randomized controlled trial conducted in the Department of Anesthesiology, Lady Harding Medical College. Adult patients of either sex undergoing hip fixation surgery were included in the study, while the patients of any known drug allergies or having any contraindication to the nerve blocks were excluded. The sample size was calculated by the study conducted by Shariat et al. And a total of 80 subjects were enrolled in our study, 40 in each group. Group 1 included the PEG block subjects, while Group 2 included the facial iliaca group. The study was conducted after getting approval by the Institutional Ethics Committee. A careful pre-anesthetic checkup was done and written informed voluntary consent was taken. Computer-generated randomization, allocation concealment by sealed envelope, and double blinding was ensured. Standard monitoring was started and baseline analysis of the subjects was recorded in the pre-op area. Then ultrasound guided blocks were given pre-operatively. In the PEG block, the drug was administered below the psoas tendon above the iliopubic eminence, while in the facial iliaca block, it was given underneath the facial iliaca above the iliacus muscle using 18 gauge 2H's needle. 20 ml of 0.25% bupivacaine was injected, followed by threading and advancement of 19 gauge epidural style catheter. After this, NRS was noted while positioning the patient for spinal anesthesia. Then 0.5% hyperbaric bupivacaine was given intrathecally for induction of anesthesia. Continuous infusion was started after this at the rate of 8 ml per hour using 0.125% plain bupivacaine in the nerve block catheter, and pain assessment was done post-operatively at 0, 4, 8, 12, and 24 hours, both during rest and during movement. Rescue analgesia in the form of IV tramadol 2 mg per kg was given whenever the NRS was more than equal to 4 or on demand of the patient, and any complication related to catheter and drugs were noted, and catheter was removed after completion of 48 hours. The data was collected, tabulated, and analyzed using appropriate statistical tests, and p-value of less than 0.05 was considered to be statistically significant. Preoperatively, the NRS score in both the groups was of severe intensity, which reduced significantly in both the groups post-blockade. In group 1 patients, the reduction in the NRS score was highly significant. On looking at the post-operative pain trajectory, both at rest and movement, it can be deciphered that both the blocks are providing good analgesia, but the subjects in group 1 experienced better or superior analgesia. Also, the group 1 subjects consume half the morphine as compared to the group 2 in the post-op period. The anterior capsule of the hip joint is innervated by femoral nerve, obturator nerve, accessory obturator nerve, lateral femoral cutaneous nerve, and the articular branches, while the posterior is innervated by sciatic nerve. The nociceptor density is more in the anterior hip capsule as compared to the posterior hip capsule. Therefore, a complete hip analgesia, both the anterior as well as the posterior hip, are to be included, or at least anterior hip joint is to be included. Since the comparative study between the blocks, especially the facial iliac and the peng block, are lacking, so we have to rely over the cadaveric studies to explore the anatomical basis of superior analgesic efficacy of the peng block. Ebert et al. Conducted a cadaveric study in which 20 ml of dye was given in the facial iliac plane and it accumulated within the iliac fossa and targeted femoral nerve, lateral femoral cutaneous nerve, and ilioinguinal nerve. On increasing the drug volume to 40 ml, the drug spread more caudally, more medially and superiorly, thus involving the main nociceptive nerve, which is the obturator nerve. On assessing the cadaveric study in which the peng block was instituted, it targeted femoral nerve block, obturator nerve, accessory obturator, and their articular branches. On increasing the drug volume to 30 ml, the dye spread more laterally, involving the tensor facial lata, thus targeting the lateral femoral cutaneous nerve. The dye also spread to the vastus medialis, gluteus medius, and iliopsoas muscle. On giving incremental dosage, the drug spreaded more posteriorly towards the posterior hip capsule, thus involving the sciatic nerve. Since we have used a continuous infusion of the drug in our study, it has led to a more extensive spread of the drug to anterior, medial, lateral, and posterior plane of the hip joint, and thus has acted as a high volume nerve block. In a recent study by Jadon et al. On comparison of single shot suprainguinal facial iliac block versus pericapsular nerve group block, they concluded that NRS score decreased significantly in both the groups, while the ease of positioning for spinal anesthesia was better in the peng block. Eliste et al. On comparing the two blocks concluded that lower incidence of quadriceps motor block is associated with the peng block. Thus, both facial iliac block and peng block are safe and effective techniques for post-operative analgesia, but peng has a superior analgesic profile with respect to ease of positioning for spinal anesthesia, post-operative analgesia at both rest and movement, and 24-hour opioid consumption. Thank you.
So you have given this pen relief block preoperatively before spinal anesthesia.
Yes, ma'am.
Yeah. So for positioning before giving spinal anesthesia, is there any problem with pen block? And because the patient have a pain preoperatively. So before giving spinal, you have given the block for positioning.
Yes, ma'am.
Is there any difficulty for positioning? Before spinal, it's very difficult to give the position for. Yeah.
Hello, ma'am. Ma'am, before spinal.
Before spinal.
I didn't hear the question.
Yeah. Is there a difficulty in the, for giving block as the patient needs fixation surgery? So patient must have a preoperative pain. So before
yes, patient is having the preoperative
so positioning will be a problem before giving spinal anesthesia.
Yes, ma'am. Yes, ma'am.
So
that's
why not after spinal?
Ma'am, the peng block and facial iliac block both can be given in the supine position, and the patient are usually in the supine position. So that's why I administered those blocks instead of the lumbar plexus block or any other block in which manipulation of the position of the patient is required. And the patient is usually in the supine position with the splint.
But because of, as his patient needs fixation surgery, there is a problem in supine also. Some support is required for that hip. And
sometimes such that hip is wedge is put in that hip also, but due to ultrasound guided.
My question is, why not after spinal?
Ma'am, because we also need to assess the ease of spinal positioning and the efficacy of the blocks during after blockade. So that's why we administered before blockade and inserted the.
Okay. And what drug you have given?
Ma'am, bupivacaine.
No additive. No additive.
No additive. No additive, ma'am.
No. Only 0.125% bupivacaine. Yeah, 0.25.
0.25%. For 0.25% bupivacaine was injected 20 ml initial bolus dose. Then at the catheter, 0.125% was injected for 48 hours. No additive was used, ma'am.
Okay.
So even before the spinal anesthesia, you have used 0.5%. You have mentioned that
0.25, sir.
0.25. Okay. So post-op anesthesia was continued the same thing for post-op anesthesia.
For post-operative analgesia, we continued 0.125%, 0.1% in the catheter via the catheter infusion dose.
Okay. Right. Okay.
Okay. Thank you, sir.
Okay. Thank you. Okay.
Good morning, everyone. My name is Dr. Aparna Rao. I am a postgraduate student at Bharati Vidyapit Medical College, Pune. My paper topic is comparative study to evaluate the recovery profile and cost of sevoflurane and desflurane using low-flow anesthesia in adults. So the development of modern anesthetic machines, gas analyzer monitors, precision vaporizers, and introduction of more potent volatile agents with minimal uptake encourage the use of low-flow anesthesia. Low-flow anesthesia is defined as flow rates of gases between 500 ml to 1000 ml. The advantages of low-flow anesthesia are that it is environment-friendly, conservation of heat and humidity, and it is economical. Both sevoflurane and desflurane are characterized by low blood gas solubility and therefore provides rapid induction and recovery. Lacune in existing literature is that very few studies have compared the cost of these inhalational agents. Hence, our study compares both recovery profile and cost of sevoflurane and desflurane. My aim and objectives are to evaluate the recovery profile and cost of sevoflurane and desflurane using low-flow anesthesia in adults. It is a prospective observational comparative study conducted in Bharati Vidyapit Medical College from 2019 to 2021, and study population includes patients undergoing elective surgeries under general anesthesia. Approval from Institutional Ethical Committee was taken. My inclusion criteria includes ASA 1 and 2 patients between 18 to 65 years of age and the duration of surgery between 1 to 4 hours. My exclusion criteria includes patients' refusal to participate in the study, patients with the serious systemic disorders. Sample size includes a total of 60 patients divided into 2 groups of 30 each, Group S, that is sevoflurane, and Group D, that is desflurane. And for sample size estimation, allowable error or difference was plus 15 or minus 15, and power of test was 80%, and confidence interval is 95%. Patients were induced using the standard general anesthesia protocol. During an initial phase of 5 to 10 minutes, a fresh gas flow of about 4 liters per minute was set, which was later reduced a total of 1 liter per minute. Group S and Group D were administered sevoflurane and desflurane respectively to achieve a MAC around 1. Intraoperative heart rate, non-invasive blood pressure, saturation, EtCO2, MAC and dial concentration were monitored. Variables used to compare the recovery profile were time to spontaneous movement, that includes swallowing, eye opening, and limb movements, spontaneous regular breathing, respond to verbal commands, extubation, stating name on command, and achieving the modified alternate score. Side effects like nausea and vomiting, laryngospasm, breath holding, or hesitation, if any, were recorded. Amount of agent was calculated using the Ehrenberg and Isacon formula, that is 3 into fresh gas flow into volume percentage is equal to ml liquid used per hour. Cost of the agent was calculated accordingly. The data on categorical variables is shown as n, and the data on continuous variables is presented as mean and standard deviation. The intergroup statistical comparison of distribution of categorical variables is tested using the chi-square test or Fisher's exact probability test. If more than 20% cells have expected frequency less than 5, the intergroup statistical comparison of means of continuous variables is done using the independent sample t-test. In the entire study, the p-values less than 0.05 are considered to be statistically significant. The demographic data and ASA grading were comparable between the two groups. Hemodynamic parameters like mean heart rate, systolic and diastolic blood pressure, EtCO2, and saturation were also found comparable between the two groups. Here is a table showing the recovery profile. So there are two groups, group S and group D, and here is the mean and standard deviation of all the recovery profiles, and the p-value suggests that there is a statistical significant difference in between the two groups, with group D showing the better recovery profile. And here is the line diagram depicting the same, showing that the group D is better than group S in means of recovery variable. And here is a table showing the average volume consumption per hour and average cost per hour between the two groups. And this is also statistically significant as shown by the p-values, showing that the mean volume consumption and mean cost is less in the sevoflurane group as compared to the desflurane group. Here is a table and bar graph showing the side effects observed in our study. So all the side effects are not statistically significant as shown by this table and bar graph. My study included a total of 60 patients of ASA 1 and 2 divided into two groups to compare the recovery profile and cost of sevoflurane and desflurane. Demographic details and hemodynamic parameters were comparable between both the groups. We found statistically significant difference between the recovery profiles of two groups, with desflurane showing the better recovery profile. In 2018, Churasma PA et al. Conducted a prospective study and compared similar two groups in patients undergoing the daycare surgeries and found post-operative recovery profile better in desflurane group as compared to the sevoflurane. Ganga Khedkar GA et al. Performed a double-blind study in 2019, including the 60 patients, to compare the early recovery profile using the same inhalational agents in patients undergoing laparoscopic cholecystectomy and found the similar result. In 2021, a randomized control trial published in Brazilian Journal of Anesthesiology comparing the reliability and cost effectiveness using the minimal flow anesthesia between sevoflurane and desflurane showed that the amount and cost of volatile anesthetic consumed were higher in the minimal flow desflurane group. Confounding variables in my study were the timing of the muscle relaxant, hypothermia, which could affect the recovery and emergence of the patient from anesthesia. Limitations of my study where it does not consider the specific groups of the patients like obese patients, pediatric patients, and the long duration surgeries. Considering the better recovery profile and emergence of desflurane, this can be used more in future for longer duration surgeries, morbid obese patients, and daycare surgeries. So we can conclude that considering the better recovery profile of desflurane, it is more preferable than sevoflurane, even though the volume of consumption and cost of desflurane is more than sevoflurane. Here are the references supporting my paper. Thank you.
So what was the age group that you have selected for your study?
Sir, good morning, sir. My age group was between 18 to 65 years.
Okay. So basically, as you know, the MAC itself will be varying depending upon the patient's age factor also.
Yes, sir. Yes, sir.
So as you have selected an older age group, like more than 60 or more than 50 or more than 60 years old, so probably they may be requiring less amount of inhalational agent for the maintenance. And also there again, what you have done is again you have selected, why it is a MAC of 1. So MAC of 1 is probably you do not have a good depth of anesthesia. So maybe that if you had selected MAC of 1.2, which is MAC or MAC bar, okay, 1.6. So keeping a patient at the MAC of 1, probably you kept the patient on lighter plans of anesthesia. I think would have got a similar results keeping in the MAC of 1.2, because MAC is fixed for all the anesthetic agents.
Yes,
And
sir.
another thing is, so that's what I wanted to make a mention about the
Age group and
age
max.
group and the
Mac.
MAC.
Yes, sir.
One is, of course, it's only 50% of the patients MAC.
50% of the
So yeah,
patients.
you could have taken the MAC intubation. So where patient would have been, and also other things is like other agents that you are using, maybe in nitrous oxide. So they also have a different effect on the
Effect
MAC
on the this thing, sir.
and the
Yes,
MAC.
sir.
And initially, what you have done is initially you have given them the ethylator 4 liter, that is higher flows that initially would 5 to 10 minutes.
Yes, sir. For initially during the induction, I have kept at a
Yeah,
higher flow rate, sir.
yeah,
And
higher
after
flow.
induction, yes, sir.
Duration is, yeah, varying between from 5 to 10 minutes.
Yes,
So
sir.
that itself
One,
can give a different value, like how much the anesthetic has been used,
yes,
inhalation
sir.
anesthetic used. So there again, you could have made it an fixed, like maybe 5 minutes,
Fixed
10 minutes, or
times.
you can have an objective like to achieve a MAC of 1.2 or what 1. Until then, how much time? So each drug initially could have kept it until reaching a specific MAC. That would have been, I think, more better.
Yes, sir. Okay, sir.
And considering desflurane, even though the cost and this will be, what is the main advantages of desflurane?
Ma'am, better recovery profile only, better
Yeah,
emergency
only
and
in for
recovery profile.
daycare surgery. You have
Daycare
included
surgeries,
only
ambulatory.
grade 1 and 2 patient, but it is
Yes, ma'am.
more advantageous in
In daycare
grade.
and ambulatory surgeries. Yes, ma'am.
No, it's advantageous in multiple organ failure patients, as it is blood solubility is very less.
Very low. Yes.
So even though the liver and kidney functions are disturbed, you can
Use
use
the
the
desflurane in
desflurane,
that.
and that is the main advantage. Because in ASA grade 1 and 2, the same thing can be taken with sevoflurane also with lesser cost.
Less.
So I use routinely for ASA grade 3 and 4
3 and 4.
instead of
One
grade
and
1
two.
and 2.
Okay, ma'am. Yes. Thank you, ma'am.
I think we can move on to the next one. Thank you.
Hello, I am Dr. Aisha Hafsar Sharan from Thuthukudi Medical College. My study title being a clinical study of monitoring end-tidal concentration of isoflurane for preventing awareness in patient undergoing elective surgeries under general anesthesia. Aim of the study to evaluate the incidence of intraoperative awareness using end-tidal isoflurane concentration in patient undergoing general surgical procedure under general anesthesia. Study population and patients who are scheduled for elective surgery under general anesthesia in Thuthukudi Medical College Hospital are included after the pre-anesthetic assessment in accordance with the guidelines of Institutional Ethical Committee. Study duration is 3 months. Sample size is 60 patients of both sexes of age group more than 18. Patients are divided into 2 groups. Group 1, 30 patients undergoing GA as per methodology to be followed. Routine monitoring like ECG, pulse oximetry, NIBP will be connected. In Group 2, in addition to the routine monitoring like ECG, pulse oximetry, NIBP, the sensor monitor is used for measuring the EtCO2, end-tidal concentration of carbon dioxide, and isoflurane is also connected. Inclusion criteria: ASA physical status 1 and 2, age above 18 years, modified Malambati classification grade 1 and 2, BMI less than 30. Exclusion criteria: age less than 18 years and more than 60 years, ASA 3 and 4, MPC 3 and 4, predicted difficult airway, BMI more than 30, emergency surgeries, significant cardiorespiratory or end organ damage, depression or psychiatric disorder, dementia, previous CVA, head trauma, drug or alcohol abuse, deaf and mute patient, refusal for participation in the surgery, Laparoscopic surgery, prolonged surgical procedure. Methodology. Patients were randomized by lots to receive general anesthesia in 2 groups. After getting informed written consent, an 18-gauge IV line will be started. Antiemetic prophylaxis will be given. IV fluid, preferred choice is ringer lactate, will be started in the preoperative room. Electrocardiogram, pulse oximetry, NIBP, cuff are connected inside the operation theatre and baseline values are recorded. All the patients in the study group will receive ETCO2 monitor and ETI concentration measuring sensors, which is connected to the ET tube. To all patients, 3 single-digit number will be told pre-induction, and the song will be played to both the group using a headphone intraoperatively at a point of time. In both groups, after pre-oxygenation, general anesthesia will be conducted in a usual way with propofol 2 mg per kilogram, fentanyl 2 microgram per kilogram, IV bedazolam 1 milligram, and endotracheal tube of appropriate size will be inserted after paralyzing the patient with succinylcholine 1.5 milligram per kilogram. Group 1, the administration of isoflurane and fentanyl will be adjusted according to the standard clinical practice and according to the patient's hemodynamics to provide a rapid recovery. In group 2, the anesthesiologist will adjust the administration of isoflurane at a MAC between 0.6 to 1. In both the groups, patient will ventilate and anesthesia will be maintained with oxygen, nitrous oxide, and isoflurane. Intermittent boluses of atracurium will be administered as per need. If the patient exhibits hypertension and tachycardia intraoperatively in group 1, the attending anesthesiologist has the option of increasing the inspired concentration of isoflurane and administering fentanyl 25 to 50 microgram IV or labetalol 5 to 10 milligram IV. In group 2, the mode of treatment is maintaining a MAC of 0.6 to 1 milligram, isoflurane, and labetalol 5 to 10 milligram can be given if patients show inadequate plane of anesthesia. In both the groups, isoflurane and nitrous oxide will be discontinued at the end of surgery. Patient will be reversed with injection neostigmine 0.04 milligram and glycopyrrolate 0.01 milligram after spontaneous attempt. Extubation will be done after fulfillment of extubation criteria. Parameter studies, time taken to awakening, extubation, and ready to shift from theatre to the PACU will be determined at 1 minute interval after discontinuation of isoflurane. The time to orientation, place, person, and time will be determined by assessing the patient 1 minute interval in PACU. The ALRATE score will be assessed at 15-minute interval by research assistant who is blinded to group assignment to determine the readiness for discharge from PACU. At the end of 24 and 48 hours interview, the patient were asked a series of questions related whether they can recall any intraoperative events. Demographic data like age, sex, weight, height, duration of study, duration of anesthesia are noted. Surgery, the amount of drugs used during the procedure like propofol, fentanyl, labetalol, and isoflurane are calculated. Post-operative awareness questionnaires are before you fall asleep. What is the last thing you remember? Second one is, what is the first thing you remember when you woke up? Between these 2 points, do you remember anything? Did you dream during your operation? What was the worst thing that was happened during your operation? At the 24 and 48 hours, the answers will be categorized as no, may know, don't know. Statistical analysis is done using the software IBM SPSS version 26. The level of significance between these two variables are done using chi-square test. A p-value of less than 0.05 is considered to be statistically significant. Outcome among these two groups, only one participant in the control group was aware in the study, and all other participants in the group were unaware. The difference was not statistically significant with p-value is equal to 1. There was no significant difference in awareness across both the groups at the end of the study. It is a chart showing awareness. Conclusion, even though end result of the study proved to be statistically insignificant, overall awareness among the general population is 1 in 1,000 individual and incidence being 0.1 to 0.5%. So among the studied population of 60 individual, one patient showing awareness seems to be significant. Hence, I conclude the study and my observation as using titrated MAC of isoflurane between 0.6 to 1 will prevent awareness among patients undergoing general surgical procedure under general anesthesia. These are my references. Thank you.
Okay, now the MAC was maintained between 0.6 to 1.
Yes, sir.
So
So it's again,
was there any other methods used to check the, I mean, the awareness of anesthesia was after the surgery, the patient will ask the questions.
Yes,
Was
sir.
that the way? Hello?
The question sets were asked at 24 and 48-hour interval, sir.
Okay. So intraoperatively,
Intra-
did you try to use a BIS or any other?
Yes,
yeah.
sir. With the end-tidal concentration of isoflurane, CO2, everything is monitored with the PSI monitoring, sir.
Okay. So intraoperatively, it was not checked. Only the maintenance was
Yes, sir.
only the MAC.
Yes, sir.
MAC
Yes,
was
sir.
the only
Yes, sir.
thing used.
Yes, sir.
So is there any difference in the BIS monitoring in both the groups?
Ma'am, I was blinded to BIS, ma'am. That may cause bias. So only intraoperatively, my colleagues or a senior anesthetist will perform all the procedures. I will be blinded to the group. Post-operatively, I will take charge of questioning the patients for 24 and 48 hours. With the end result, I formulated the statistics, ma'am.
No patient in your group was aware. Only
Yes,
one
ma'am.
patient in control group was aware.
Yes,
And
ma'am.
with
Yes.
0.6 to 1 MAC, no patient was aware
No patient was aware, ma'am.
in 30 patients.
Yes, ma'am.
With 0.6 MAC, how it's possible? Okay.
So if you have used the BIS along with this, you have used BIS also?
Yeah.
No, sir. Only the gas analysis connector was connected to the AD tube.
Madam, they have
Oh,
not
you
used.
have used BIS, no?
Yes, sir. Actually, BIS was not connected, sir.
So if there was a BIS, would have come to know, would have correlation could have been more better.
More better, yeah.
That study was separately done by my OPD, sir.
Okay.
Okay. Right. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you.
Hello everyone, I Dr. Jyoti Sinha and I am presenting my pre-research paper on dexmedetomidine versus dexamethasone as adjuvant to levobupivacaine in USG-guided transverse abdominis pain block for post-operative analgesia in patients undergoing total abdominal hysterectomy. Coming to the introduction, post-operative pain is normal physiological response to surgical trauma. Effective post-operative analgesia is key to acute and chronic rehabilitation of the surgical patients. Multimodal analgesia produces better pain relief and decreases the drug-related adverse effect. We adopted a technique in our study called transverse abdominis pain block, a better feasible and acceptable procedure. And for the local air infiltration, we use levobupivacaine, which has a longer duration of action, safer, and low toxic profile as compared to bupivacaine. And this is the standardized posture approach for the TAP block, which is used in MAS study. The aim of MAS study is to evaluate and compare the efficacy and safety of dexamethasone and dexmedetomidine as local adjuvant to levobupivacaine in ultrasound-guided TAP block for multi-strategic pain control in patients who underwent total abdominal hysterectomy. And the subarachnoid block in terms of duration and quality of analgesia, post-operative analgesia, consumption, and complications, if any. This is a randomized interventional trial study. Institutional ethical committee approval and written informed consent taken from the patient. CTRI registration was done. All subjects of ASA grade 1 and grade 2 between the age group of 30 to 65 years were included. Exclusion criteria include patient refusal, BMI index more than 40, coagulopathy, allergic to a drug, and ASA grade 3. The patients randomized by computer-generated table into two groups. Group 1 include levobupivacaine with dexamethasone and group 2 include levobupivacaine with dexmedetomidine. Lumbar puncture was done and 3 ml of 0.5% hyperbaric bupivacaine was given in subarachnoid space. Total abdominal hysterectomy procedure was performed after confirming the adequate level of block. TAP block was performed after the skin closure. In post-operative variable such as heart rate, blood pressure, oxygen saturation, and VASCO was measured. Tramadol PCA pump was used for the rescue analgesia, and demand dose of tramadol was 20 mg with lockout interval of 10 minutes. The primary outcome was to measure the first request of analgesia, and the secondary outcome was total opioid consumption, time of first rescue analgesia, any opioid-related side effects, and patient satisfaction using Likert scale. Sample size, a total sample size of 72, assuming a pooled standard deviation of 1.5 units. Statistical analysis was done using SPSS version 22, quantitative data expressed as mean plus standard deviation, and qualitative data expressed as range, frequency, and percentage. And ANOVA t-test and ANOVA student t-test and man-weight test was used. Coming to the results, demographic profile, it was found insignificant difference between the group for the age, hemoglobin, TLC, ANR, and duration of the subarachnoid block. For heart rate, it was observed that there was significant difference between the group 1 and group 2 with p-value of equal to 0.03. For mean blood pressure, it was observed that there was significant difference between the group 1 and group 2 for the mean blood pressure with p-value of equal to 0.025. For the VASCO, it was observed that there was significant difference between the group 1 and group 2 for the VASCO at 1, 6, 9, 12, and 24 hours. And the Likert score for the overall pain management was good in both the groups. The side effects was more in the dexmedetomidine group, which include nausea, vomiting, and sedation. The total tramadol consumption, attempt, and delivery. For the delivery, there was also a significant difference between both the groups. For discussion, the aspects of poor quality of recovery are suboptimal pain relief, delayed ambulation, and hospital discharge. Dexmedetomidine acts on the locus coeruleus to modulate the descending medullospinal noradrenergic pathway. And dexamethasone addition to the levodopa can prolong the block, improve the quality, also decreases the post-operative nausea and vomiting. Optimal pain relief, anxiolysis, early recovery of the bowel function, and ambulation with the dexmedetomidine leads to better patient satisfaction and decreased VASCO. USG guidance tab block gives us more precise and oriented result. First dose of analgesia, total tramadol consumption were low in the dexmedetomidine group compared to dexamethasone. And also dexmed leads to the prolongation of the block. Coming to the conclusion, tab block is one of the best available option for the post-operative multiple analgesia. Dexamethasone addition to levodopa decreases the post-operative nausea and vomiting, and dexmedetomidine is better than the dexamethasone as an adjuvant in our study because it provides decreased VASCO, improved the patient satisfaction, and decreased opioid requirement. And these are the references. Thank you everyone for your patience listening.
So tramadol was used as an rescue analgesia, according to your study. Rescue analgesia.
No, sir, tramadol is used in the PCA pump. Hello.
Tell me.
Sir, for rescue analgesia, I use paracetamol as the first rescue analgesia. And then the PCA pump was applied because the duration of subarachnoid block was around 3 hours, 2 to 3 hours, depends 180 minutes, was this on an average. So if the subarachnoid block effect is still there, we cannot conclude that whether it's because of the tab block analgesic effect or because of the subarachnoid. So first analgesia used was paracetamol and then PCA pump.
Okay.
What dose you have used? Dexmedetomidine?
Ma'am, 1 mcg per kg body weight. Divided in 2 equal dose for the bilateral block. Suppose it was 60 mcg, then 30 mcg on each side.
And you have included only abdominal hysterectomies?
Yes, ma'am, only abdominal hysterectomy, that also under subarachnoid block in order to monitor the hemodynamic parameters and changes and all.
And Dexine, which dose?
Dexamethasone, ma'am, 8 mg for divided in 2 equal dose. It was standardized for every patient, 8 mg only, 4 mg on each side.
Means not consider the weight of the patient.
No, ma'am. It was not according to the weight of the patient.
Okay.
Thank you, ma'am. Thank you, sir.
Thank you.
Good afternoon to my respected classes, seniors and my myself Dr. Shalini Dash, today presenting the topic two-arm observational study between intravenous phenylephrine and noradrenaline in management of spinal anesthesia-induced hypotension in elective cesarean section. The gold standard anesthesia for lower uterine cesarean section is subarachnoid block. Maternal hypotension is being the common side effect even after preloading or co-loading, which may cause decreased fetal-maternal circulation, even fetal acidosis, and maternal nausea and vomiting. The treatment is bolus vasopressors like phenylephrine, noradrenaline, epinephrine. Phenylephrine is selective alpha-1 agonist uses as first-line medication for prevention and management for maternal hypotension, which cause dose-dependent peripheral vasoconstriction, increased blood pressure, decreased cardiac output, and baroreceptor-mediated reflex bradycardia. Noradrenaline is both alpha-1 and beta-1 agonist, which cause increased blood pressure with less tendency to decrease heart rate. Because baroreceptor-mediated reflex bradycardia is counteracted by beta-1 receptor-mediated increased heart rate. So our aims of the study is to compare the effectiveness between these two drugs and if any side effect. This is a randomized prospective double-blind observational study done among 102 people in group A and group B, 51 in each group in the obstetric operation theatre of Isacon Medical College in the duration of 6 months. These are my inclusion criteria and exclusion criteria. Hypotension is being defined as the fall of systolic blood pressure more than 20% from the baseline and heart rate is less than 60 beats per minute, called bradycardia. We took institutional ethics committee approval. Our patient underwent proper history taking, detailed clinical examination, routine blood tests were checked, patient were counseling about the procedure and routine informed consent were taken. Then our patient were fasted according to the fasting guideline, aspiration prophylaxis is given, co-loading done with IV, wide bore IV cannula, monitoring done with standard ASA monitor. Anesthesia was administered according to our hospital protocol with 26G Vitacan needle with 10 mg of 0.5% bupivacaine heavy. After checking the sensory block by pinprick sensation up to T4 level and motor block by modified Bloom scale, cesarean section were allowed. Patients were administered with oxygen. If the hypotension occurred, group A patient were received 50 microgram of 1 ml phenylephrine and injection noradrenaline of 4 microgram 1 ml were received by group B patient. Data were collected and sent for statistical analysis. Sample size were calculated with AP-Info TM353, analysis done with SPSS 27 or GraphPad Prism version 5, unpaired proportion were calculated with chi-square test or features extract test, which one was appropriate, p-value less than 0.05 were statistically significant. Demographic data were comparable both the group, the systolic blood pressure, diastolic blood pressure, mean arterial pressure were comparable in both the group throughout the surgery. Baseline heart rate were also comparable, but there was incidence of bradycardia after giving phenylephrine in group A patient were occurred. These are the distribution of heart rate in both the group. The neonatal outcome in both the group were also comparable. That these are the requirements of drug in both the group. So LUCS is commonly performed under spinal anesthesia. Hypotension is a deleterious side effect. So our management was multimodal. that is crystalloid before and during the surgery, limiting the aortocaval compression, uses of smaller dose of local anesthetics, and uses of vasopressors like phenylephrine, noradrenaline. As the blood pressure were comparable in both the group, phenylephrine and noradrenaline has similar efficacy, but bradycardia occurs after giving phenylephrine, but noradrenaline does not cause bradycardia. These bradycardia may cause decreased cardiac output, which may jeopardize fetal-maternal circulation, which is deleterious in compromised fetus. Lingdon in Hessen, Warwick D. Nagan, Adam in Sarke were found in their study that noradrenaline is superior than phenylephrine due to less fluctuation of heart rate and cardiac output, which were similar in our study. So we can conclude that vasopressors like phenylephrine and noradrenaline are efficacious in management of spinal anesthesia-induced hypotension, but injection noradrenaline is a better option in preserving hemodynamics throughout the surgery with no incidence of bradycardia. These are my reference. Thank you.
Hello. If there is a
Hello.
hypotension, have you used atropine first and then these vasopressors?
No, ma'am. I never used atropine first, then vasopressors.
Immediately you have used these vasopressors
Yes, ma'am.
without giving atropine. Yeah.
Yes, madam. Yes, madam.
Even though means 20% reduction in the previous pre-op blood pressure. If there is a hypotension, you have not used atropine, directly you have used phenylephrine or vasopressin.
Yes, yes.
And the
ma'am.
groups are divided in random.
Yes, ma'am. Randomized.
So you concluded noradrenaline is a better choice.
Yes. In
And is there any
preventing
for preloading emergency and elective surgeries or preloading? How much preload? Is there any?
Actually, madam, in our hospital we did co-loading with 15 to 30 ml of ringal lactate per kg ml of per kg ringal lactate. We did co-loading during spinal anesthesia.
Oh, you included only elective surgery.
Yes, madam.
No emergency. You have mentioned that? No.
Yes, madam. In my title, I have mentioned in elective cesarean section.
Oh. And in PIH, you have not included any?
No, madam. No, madam.
What was the criteria for bradycardia in your study? You have made a mention that when phenylephrine was given, there was bradycardia. So what was the criteria below which you called as an bradycardia? Heart rate.
Actually, heart rate less than 60 we defined as bradycardia in my study.
Okay, so what did you do in case there was a bradycardia due to phenylephrine? So what did you do? Like,
sir, injection the bradycardia due to injection phenylephrine, it was transient. After some time it reaches in its normal heart rate, but if in case it is more longer time, we give injection atropine, but the incidence of giving injection atropine was very less in 1 or 2 cases in my study.
And repeated doses of required in case of phenylephrine or not? If there is a hypotension.
No, ma'am.
Because of spinal,
yes,
there is no bleeding. Actually, they're not because of surgical cause. If there is a hypotension, whether you require repeated doses of phenylephrine as compared to normal.
Yes, madam. The doses is the number of bolus doses is more required in case of noradrenaline.
Yeah, that's why I'm asking you whether repeated doses are required with phenylephrine or noradrenaline.
noradrenaline, madam.
Have you mentioned that?
Yes, ma'am. Yes, ma'am. I have mentioned one bar diagram in my study.
And Apgar, have you seen any Apgar?
Yes, ma'am. Yes, ma'am. I have seen Apgar, but in both the group, the Apgar was comparable.
Okay.
Good morning. My topic is a randomized double-blind comparison of phenylephrine and norepinephrine for management of postprandial hypertension in preeclamptic patients undergoing cesarean section. Phenylephrine, an alpha-adrenergic agonist, is a potent, rapidly acting vasopressor for management of postprandial hypertension. However, it may be associated with reflex bradycardia with fallen cardiac output. Recently, investigators are exploring the role of norepinephrine, an alpha-adrenergic agonist with weak beta agonist action, as an alternative to phenylephrine. Most studies comparing phenylephrine and norepinephrine have been conducted in elective cesarean section in healthy pregnant patients. The literature available in preeclamptic patients is very limited. Therefore, the present study was to compare bolus doses of phenylephrine and norepinephrine for treatment of hypertension in preeclamptic patients undergoing cesarean section under spinal anesthesia. The primary objective was to compare neonatal outcome in terms of umbilical artery pH. Following ethical committee approval and written informed consent were obtained, and the randomized double-blind study was conducted in 86 preeclamptic patients with singleton pregnancy undergoing cesarean section under spinal anesthesia. These patients were randomly divided into two groups of 43 each using computer-generated random number table and sequentially numbered sealed opaque envelopes. Group phenylephrine received IV phenylephrine 50 microgram and group norepinephrine received IV norepinephrine 4 microgram boluses for treatment of each hypotensive value. These are my exclusion criteria. Spinal anesthesia were provided under standard technique. The postspinal hypertension was defined as fall of systolic blood pressure more than or equal to 20% from baseline or an absolute value less than 100 millimeters of mercury. And the reactive hypertension defined as rise of more than 20% from baseline systolic blood pressure. Bradycardia defined as heart rate less than 50 beats per minute. Umbilical artery and venous blood samples were obtained. The primary outcome measures was the umbilical artery pH, and the secondary measures were Apgar score at 1 and 5 minutes, number of hypotensive episodes, number of vasopressor boluses required, incidence of tachycardia, bradycardia, arrhythmia or hypertension, or incidence of maternal complications. Final sample size of 43 patients per group were calculated, and the statistical analysis were done by unpaired t-test, Matt-Whitney U-test, Pearson's chi-square or Fisher's exact test, or mixed model analysis. Coming to results, the demographic profile and other patient characteristics were comparable in two groups. The two groups were comparable in terms of baseline hemodynamic parameters, total number of vasopressor boluses given, and episodes of bradycardia. But the number of hypotensive episodes was higher in norepinephrine group, whereas number of boluses for treatment of first hypotensive episode was higher in phenylephrine group. The umbilical artery and other venous blood gas parameters and other neonatal parameters are shown in this graph, in this table. The umbilical artery pH, the primary outcome, showed no statistical difference between two groups, and other parameters were all comparable except venous partial pressure of O2 and venous oxygen saturation were significantly higher in norepinephrine group. So heart rate and systolic blood pressure were compared up to 9 minutes after vasopressor administration. This graph shows the trend in heart rate and systolic blood pressure after vasopressor administration, taking the time of hypotension and the vasopressor administration as 0 time. Heart rate was lower in phenylephrine group, whereas systolic blood pressure was comparable in both groups at most of the time points. Only one patient in phenylephrine group developed bradycardia, and no patients in either group developed tachycardia or reactive hypertension. A subgroup analysis was done in patients with severe preeclampsia and which showed similar trends. Many studies in elective cesarean section in healthy pregnant patients have reported comparable neonatal outcome. However, we could only found one study in preeclamptic patient and found no difference in umbilical artery blood gases in the patients receiving phenylephrine or norepinephrine. In the above particular study, only an umbilical arterial samples was obtained without taking any venous sample, making the result less reliable. To confirm the accuracy of sampling, it is important to take both arterial and venous samples. In our study, venous partial pressure of O2 and venous oxygen saturation were lower in phenylephrine group. Although there can be a possibility of type 1 statistical error, but due to multiple comparisons, but phenylephrine is a pure alpha agonist that may reduce the uteroplasmal blood flow due to vasoconstriction, leading to decreased oxygen delivery. However, phenylephrine use has never been seen to result in an adverse neonatal outcome. An international consent statement has recommended prophylactic vasopressor infusion for prevention of hypertension in cesarean section following spinal anesthesia. Due to lower incidence of hypertension and greater sensitivity of preeclamptic patients to vasopressor, prophylactic infusion may not be the best option in preeclampsia. There are some limitations in our study. In our study, only 44 patients had severe preeclampsia. So further studies in severe preeclamptic patients are required to evaluate these two vasopressor in this patient group. And our study protocol was designed to treat hypertension with vasopressor boluses. These findings may not be applicable to a regime using prophylactic vasopressor infusions. And our conclusion is phenylephrine 50 microgram and norepinephrine 4 microgram when administered as IV boluses for treatment of postspinal hypertension in preeclamptic patient undergoing cesarean section are associated with similar neonatal and maternal outcome and are equally effective in treating hypertension. These are my references. Thank you.
So you use phenylephrine and noradrenaline in preeclampsia. So have you used any other method to avoid hypertension, means wedge under?
We use wedge
for each and every patient.
From each and every patient, from TO to shifting to OT, we use wedge. And also we did co-loading, ma'am, 10 ml per kg co-loading we have done.
So, and whether you have included multiple pregnancy, means twins?
No, ma'am, singleton we have
because
done.
preeclampsia is very common in twins and
we included only singleton pregnancy.
Okay. So the arterial umbilical cord arterial this is more with noradrenaline, better in noradrenaline group than the phenylephrine group. Yeah, you are not taken venous, only arterial sample.
No, ma'am. We have done in venous and arterial. We had a reference study which was done only arterial.
Only arterial.
In our study.
Okay, you have done venous and arterial.
Both.
So it is better in noradrenaline group.
No, ma'am. At the end, we got a comparable result, ma'am.
But p-value is okay. But in some patients, phenylephrine group, the concentration was less. You said, yeah.
Means venous partial pressure of O2 was less. Venous oxygen saturation was less. But overall, at
because
the end,
it is purely alpha agonist.
Purely alpha agonist, it may cause.
So what will you prefer? To give phenylephrine or noradrenaline?
At the end, we got a comparable result throughout.
Yeah, that is the comparable is with the p-value. So p-value, yeah, it's not figure. But what will you prefer?
Ma'am, norad
I think, ma'am, because phenylephrine, we had that throughout maternal heart rate was in lower side, and one patient had bradycardia, ma'am. That was not significant.
So
but one
how you
patient had
treated that
bradycardia in
bradycardia?
phenylephrine group.
How you treated that bradycardia?
Ma'am, our definition was less than 50 beats per minute, ma'am. If it is with hypotension, we gave injection glycopyrrolate, ma'am, 0.2 mg.
For bradycardia, you have given glycopyrrolate.
We managed with glycopyrrolate.
It was managed or not? With
Yes,
glycopyrrolate?
It was transient and managed. Yes, ma'am. Because immediately hypertension and both we gave so manage.
Bradycardia
only
with
one case
hypo
was
is better managed with atropine rather than
our study design. We planned for glyco.
Okay.
Thank you, ma'am.
So your study included both normal and the pre-eclamptic patients?
No, ma'am. No, sir. Only we included pre-eclamptic patients.
Only pre-eclamptic.
Sir.
Okay. Other than that, so in case if you are given, if you have got option of both the drugs are there, as madam said, noradrenaline and phenylephrine. At what stage would you like to use noradrenaline, and at what stage you would like to use phenylephrine? So you have got an option of both. You are not doing, forget about study. So if you're doing
sir, I got a comparable result. So, but heart rate, maternal heart rate was maintained in noradrenaline group, sir. So I prefer noradrenaline.
Noradrenaline. Oh, okay, right. So in case the patient is having higher heart rate, so maybe yes, patient is having heart rate of around 90, 100.
In that case, I can prefer phenylephrine.
Probably you can use phenylephrine, which is a better. The heart rate is also brought down.
Yes.
So in case the patient is having heart rate, lower heart rate with hypertension, then probably you can use noradrenaline, which increases heart rate and also the blood pressure also.
Yes, sir.
But this is the way you can use both the drugs simultaneously in the same patient.
Yes, sir. Yes, sir.
Oh.
Okay. Thank you.
Thank you. Thank you.
Thank you, sir. Thank you, ma'am.
This is Dr. Sri Lakshmi from Bharati Vidyapeeth, Pune, and I'm here to present my paper on evaluation of efficacy of aortic oxygenation during endotracheal intubation in pre-obese and obese class 1 patients undergoing elective surgery. Aortic oxygenation is the process by which oxygen moves by en masse flow through the upper airways into the alveoli in the absence of any respiratory effort, consisting of administration of oxygen during apneic period of intubation to extend the safe apnea time. It is especially beneficial in obese patients because lung volumes on intrapulmonary shunt worsen with induction of general anesthesia in all patients, and to a greater degree in obese patients, which again increases in supine position, leading to decreased time of desaturation during apnea. Repeated attempts at airway manipulation may become necessary, and there is less time to rescue in a failed airway situation due to rapid desaturation. Our study aimed to evaluate the efficacy of aortic oxygenation during endotracheal intubation in both pre-obese and obese class 1 patients, and our objectives was to assess the degree of desaturation, raise in ETCO2 trend, and to evaluate the incidence of emergency intervention when the saturation fall below 90% in the form of ventilation or intubation. Published studies so far are few in number, and most have not evaluated a prevention of desaturation episodes during intubation and routine clinical conditions, not compared degree of benefit between obese and non-obese patients, and do not provide data on a patient's ETCO2 raise during aortic oxygenation. Our study was conducted in a tertiary care center. It was a comparative study, non-randomized, non-blinded, and it was conducted over a period of 1.5 years. And it was selected among the patients who were coming to the PSC OPD after the clearance from the Institutional Ethics Committee. Inclusion criteria included patients who are undergoing elective surgery under general anesthesia, classified as pre-obese, coming under the BMI of 25 to 29.9, and obese class 1, it is BMI of 30 to 34.9, and Malapati grading of 1 and 2, ASA 1, 2, 3, age group between 18 to 65 years, and acceptance of the study. Exclusion criteria included difficult airway, bilateral nasal obstruction, chronic respiratory diseases, smokers, contraindication to succinylcholine, saturation less than 97% even after 100% oxygen via face mask, pregnant women, and any unanticipated difficult intubation. A sample size was estimated to be 100, but we did a study of 80 patients divided into 4 groups. Group A and B included pre-obese who either did or did not receive epic oxygenation, and C and D included obese class 1 patients who either did or did not receive epic oxygenation. Once the patient was shifted inside the OT, baseline saturation on the room air was noted. A nasopharyngeal catheter was put through the nose in the study. The patient was pre-oxygenated with 100% oxygen with a titrating mask of 5 minutes. Saturation EtCO2 was recorded every 15 seconds. Once adequately pre-oxygenated, standard induction procedure was performed. In control group, no apneic oxygenation was given. In study group, apneic oxygenation was started at 5 liters per minute via the nasopharyngeal catheter once the face mask was removed. If the saturation dropped below 90% at any point, intervention in the form of intubation or ventilation was performed. This is a picture showing nasopharyngeal catheter, which is made by connecting the oxygen tubing to a 10-French infant feeding tube connected by a pediatric BP cuff connector. This design helped to reduce injury to nasal mucosa during insertion and also interfered less with bag and mask ventilation if at all it became necessary. Independent sample t-test and one-way ANOVA was used for statistical significance, statistical analysis. IBM SPSS version 21 was used for statistical analysis. This shows the mean age, which is comparable between the study and control groups in both pre-obese and obese class 1 category. And there was no statistical significant difference in gender distribution among the 4 groups. My primary outcome measure was prevention of desaturation during apnea time. Higher mean SpO2 was noted in both pre-obese and obese class 1 study group than in control group in a statistically significant manner. And statistically significant prevention of desaturation episodes in both pre-obese and obese class 1 study group when compared to control group. My secondary outcome measure was EtCO2 raised during apnea time. Statistically significant increase in EtCO2 in obese class 1 and pre-obese study versus control group during apnea time. The mean raise in EtCO2 was greater in study group when compared to control. Desaturation, that is at saturation less than 90%, was observed in 4 patients, and hypercarbia was observed in 9 patients, but the EtCO2 values was less than 50 mmHg, and there was no adverse events related to nasopharyngeal catheter placement. Inferences. It's a useful clinical practice to reduce the risk of hypoxemia, and the positive effect was more pronounced in obese class 1 category. And elevation of carbon dioxide is considered as a limitation, but mild hypocapnia was present in 11% of our patients. Usage of nasopharyngeal catheter was clinically practical. Confounding variables. The variability of operator, the apnea time is dependent on the seniority and the experience of the intubating anesthesiologist, and the effect is better evaluated by minimizing atelectasis and pulmonary shunt-on induction of anesthesia, which is achieved by reverse Trendelenburg as well as pre-oxygenation of positive pressure ventilation, which we did not use in our study. For comparison with previous literature, prevention of desaturation episodes was in agreement with previously published studies. 6 studies had prolongation of safe apnea time as their primary outcome measure. Our study demonstrated the same under routine clinical conditions. Limitations was that it was a smaller sample size study and it lacked randomization or blinding, which can lead to selection bias. It did not include morbidly obese patients, and PaCO2 was not recorded. Large randomized studies with additional measures to prolong duration of safe apnea time are needed to confirm our study findings. In conclusion, apneic oxygenation is a simple, without significant adverse effects, and it has a potential to turn intubation a safer procedure in a high-risk group of obese patients. Our study adds evidence to the consideration that application of apneic oxygenation should be a standard of care in obese patients undergoing general anesthesia. These are my references. Thank you.
So you have given apneic oxygenation through nasal cannula, but it depends on the time of the time required for intubation, experienced hand, and this. So you can't compare the results. How you calculated the sample size and this? You only.
Initially, it was supposed to be calculated for 100, ma'am, but because of the COVID pandemic, I could only include 80 patients. And as you said, yes, ma'am, the experience of the anesthesiologist, like the first year's residents or the second year resident who was intubating, that made a difference in the apnea time. And also, as obese class 1 patients had more difficulty as such, as in intubation time or apnea time was increased in such patients. So all of these factors did affect as to, I mean, how much time they took and what was the in study groups as such, obese class 1 patients, even though the apnea time was increased, we found lesser people who desaturated less than 95 or even less than 90. But in control group with the same obese class 1 patients, there was much more desaturation comparatively, ma'am. Pre-obese group, there was not much difference.
What was the flow rate and this?
Ma'am, I've 5 liters per minute we started, ma'am.
You normal, yes, not HFNO. You have not connected HFNO. Okay.
So your duration of pre-oxygenation was 5 minutes.
Yes, sir. In all the patients, we pre-oxygenated for 5 minutes, sir. After that, only we started.
Okay, in all the patients, it was 5 minutes.
Yes, sir. Yes, sir.
Okay.
Good day, everyone. I'm Dr. Prerna Vasudev from University College of Medical Sciences, and I'm here to talk about my research paper with the title Comparative Evaluation of Ring Vision Video Laryngoscope, McCoy, and Macintosh laryngoscopes for tracheal intubation in patients scheduled for mucormycosis surgery in a tertiary care hospital. Mucormycosis is an angio-invasive infection mainly affecting immunocompromised patients with a rapid fulminant course. Its global prevalence varies between 0.005 to 1.7 per million population. Rhinoorbital cerebral mucormycosis is characterized by progressive fungal invasion of the heart palate, paranasal sinuses, orbit, and brain. Patients with ROCM may experience difficult mask ventilation or difficult endotracheal intubation. McCoy laryngoscope is designed to elevate the epiglottis with its hinged tip and requires less neck movement during laryngoscopy and is frequently used to facilitate tracheal intubation when the view of the glottic opening is restricted. King Vision laryngoscope is one of the latest devices that uses video and digital technology by an organic light emitting diode designed of good clarity and high resolution and requires a minimum of 18 centimeter mouth opening. However, relative efficacy of this device in comparison with Macintosh laryngoscope and McCoy laryngoscope has not been compared in mucormycosis patients posted for elective surgery. The armamentarium of the anesthesiologist has a myriad of options for difficult intubation, like direct laryngoscopy with the aid of a gum elastic bougie, AV scope, McCoy laryngoscope.
Good morning, everyone. I am Dr. Anshu.
Sir, please start the question answers.
Hello.
Hello. Hello.
Hello. Can't hear the paper.
I think we could not hear the complete paper. I
Yeah.
think disturbance in between. Okay, we can.
Hello. Can't hear the paper.
Technical team, the
Yeah.
paper was not heard, and in between there was an interruption, and nothing was.
Ma'am, the duration of the video is that much, ma'am, only.
The video was that much only. Okay, right. It was a short video.
So move on next.
I think we'll go to the next one because
Yeah.
what was there in the video.
Good morning, everyone. My topic of presentation is comparative clinical study dexmedetomidine and fentanyl and attenuating stress response during laryngoscopy and intubation. The cardiovascular response to laryngoscopy and intubation include hypertension and tachycardia. The sympathetic response is provoked by stimulation of airway stimulation, lead to the unpredictable increase in heart rate and blood pressure. This is hazardous to the patient with hypertension, myocardial insufficiency, cerebrovascular disease, which may lead to intra myocardial infarction, arrhythmia, and the increase in ICP in these exposed patients. Various pharmacological agents have been used to attenuate the stress response to endotracheal intubation. In our study, we have used the dexmedetomidine and fentanyl to compare the attenuation response during intubation and laryngoscopy. Our aims and objective of our study to compare the dexmedetomidine 0.5 microgram per kg dose and fentanyl 2 microgram per kg dose in attenuating stress response during laryngoscopy and intubation, and any complication or side effect of the study drug during the study. After obtaining approval from the Institutional Ethics Committee, the prospective double-blinded randomized controlled study was conducted in 60 patients of ASA grade 1, class 1 and class 2 undergoing general anesthesia. We have included the patient of 25 to 65 years of male and female of ASA grade 1 and 2 undergoing general anesthesia, excluded the patient with cardiovascular, hepatic, renal, neuromuscular system and uncontrolled systemic diabetes, hypertension, and patient on calcium channel blocker, beta blocker, and chronic use of opiates. We have divided the group in two groups by enclosed envelope method. Group D include the patient received the IV dexmedetomidine of 0.5 microgram per kg over a period of 10 minutes, diluted up to the 20 ml of normal saline before induction of anesthesia. Similarly, group F received the fentanyl 2 microgram per kg over a period of 10 minutes before induction of anesthesia. And we attached the all standard monitor, ECG, pulse oximeter, and non-invasive BP and ETCO to the patient. And during the period of study, hemodynamic parameter were noted at the period 1 minute after drug administration and 30 seconds after intubation, and then every 1 minute up to the period of 3 minutes. Then at 5, 7, and 10 minutes after intubation were recorded. We have induced the patient on general anesthesia after pre-oxygenation and pre-medicated with injection pentazocine 0.5 milligram per kg, and induced with both group induced with injection propofol and 2 milligram per kg, and maintained on the oxygen nitrous and isoflurane and injection ectocurium. And ETCO to maintain 35 to 45 mm Hg. Patient was completely reversed at the end of surgery with neostigmine and glycopyrrolate once extubation criteria were met. After extubation, all patients were shifted to the post-op anesthesia care unit, and where systolic, diastolic, mean blood pressure, heart rate, and SpO2 were assessed. And statistical analysis were done by the SPSS software using the unpaired t-test. In demographic profile of the two group, baseline data of both group are comparable in respect to the age, sex, and weight. In hemodynamic parameter, heart rate of the both group are comparable initially up to the period of 1 minute after drug administration, then after 30 seconds after intubation up to the end of the study. Heart rate and the diastolic and the mean blood pressure, diastolic and the systolic blood pressure were lower in the group D, dexmedetomidine group as compared to the fentanyl group. There was so significantly difference in the statistical analysis. Both dexmedetomidine and fentanyl have ability to control hemodynamic response, suppress the gag, laryngeal and cuff reflex during laryngoscopy and intubation by virtue of their central mechanism of action. Our main finding of study was suppressed, attenuate the pressure response to intubation, noxious stimulus and recovery by mean heart rate and mean blood pressure were significantly lower in the throughout the intra period during the in the dexmedetomidine group as compared to the fentanyl group. Our study was supported by the Das et al., Patel and D et al. And Jan V et al. In our study, we observed only bradycardia in 2 patients in group D, which was managed by the injection atropine 0.6 milligram IV. Finally, we concluded that dexmedetomidine and fentanyl both have safely attenuated the hemodynamic response without any side effect. Among the 2 groups, dexmedetomidine group provide effective pressure response to laryngoscopy and intubation as compared to the fentanyl. Thank you.
Hello. You have given for a pre-medication 0.5 milligram per kg of pentazocine. Yeah. Hello. Can you hear?
Yes, ma'am.
You have given in a pre-medication in the both the groups 0.5 milligram per kg of pentazocine. Yes.
Yes, ma'am.
After that, you started inducing the anesthesia and you have given for fentanyl group 2 microgram per kg.
Yes, ma'am.
So with
Yes, ma'am.
pre-medication of 30 milligram of pentazocine and again 100 microgram of fentanyl. And
yes.
I think it's a more dose for opioid. Yeah. You have given in each patient pentazocine, again fentanyl, and in patient pentazocine and again dexmed.
Yes.
Yeah.
Actually, we give a prior to 10 minutes prior to pre-oxygenation and diluted up to the 10 ml. We give the dexmedetomidine and the fentanyl.
In case, so, as madam said, so in case if you wanted to use pentazocine as an analgesia, you could have given after the intubation.
Yeah.
So maybe that would have been better because pentazocine itself has an property of increasing the heart rate. That is one. So other is once you have used fentanyl as an initially for intubation, this duration of action is only for 45 minutes. So
45 minutes.
After that, you would have used pentazocine maybe if you at half an hour following the intubation, if you had used. By the time it takes the as the fentanyl wears off, pentazocine would have taken the effect and you would have continued with the surgery. So maybe preferably, I think it would have been used after the intubation rather than before intubation.
But already you are using fentanyl for and in a sufficient dose, not in a small dose. Okay. So you said dexmed is better.
Yes, ma'am.
Have you calculated the time for intubation to compare the stress response, laryngoscopy and intubation? That depends, stress response again depends upon the time for laryngoscopy and intubation also.
Oh, ma'am, in our study, we do not calculate the time.
Yeah. So it varies in case of experienced hand and inexperienced hand. So you must mention the time for average at least to compare the stress response in both the groups. Yeah. So average time for both the groups was that much. So you can compare the stress response. Okay. And bradycardia is more with fentanyl or dexmet?
Ma'am, dexmet group, we observed 2 patients with dexmet group of bradycardia.
Morning all, my topic is a comparison of intravenous lignocaine analgesia and epidural analgesia for control of postoperative pain in patients undergoing abdominal surgeries. And my co-authors are KJ Shivakumar and Meghna Mukund. Coming to the introduction, postoperative analgesic management is an important part of anesthetic care, and hence as an anesthesiologist needs to be aware of factors involved in the better recovery of the patient. Following major abdominal surgeries, good control of postoperative pain plays an important role in the recovery and outcome of the patient. And intravenous lignocaine infusions have shown a promising result in decreasing postoperative pain and also having a benefit of reducing duration of stay in hospital, earlier bowel movements in intestinal surgeries. Hence, a study was done to compare the effectiveness of intravenous lignocaine analgesia with that of the epidural analgesia for control of postoperative pain. And coming to the aims and objectives, comparison of efficacy of IV infusion of 2% lignocaine at 1 mg per kg per hour with that of the epidural infusion of 0.125% bupivacaine at a rate of 5 ml per hour during first 24 hours of perioperative period, and heart rate systolic BP changes during 24 hours of perioperative period also observed. Materials and methods. It's a quasi-experimental study. Patients from Unified Medical College Hospital were selected during the period of November 2019 to 2020 who had undergone abdominal surgeries under GA. And sample size was calculated by a two-tailed test with alpha of 0.025 and power of 80%, and sample size calculated was 26. The 26 was divided into 13 and 13 each group, and sample size was calculation was done using a G-Power software. And coming to the inclusion criteria, AC physical status of 1 and 2 and patient age between 18 to 65 years were selected, and patients undergoing elective laparotomy or abdominal surgeries were selected. Coming to exclusion criteria, unwillingness or contraindication to epidural analgesia, allergic to local anesthetics, patients with cardiac disease, patients with INR more than 1.5, liver and renal impairment patient, parturients, pregnant women, systemic corticosteroid use patients, and chronic use of opiates patients. And coming to the methodology, after ethical committee approval, patients were selected and by closed envelope method, and thorough pre-anesthetic evaluation and routine investigations was carried out, and patients were explained regarding the study and informed consent was obtained. On the day of surgery, the patients were divided into two groups randomly, and after shifting to the OT, standard ASA monitors was connected, baseline readings were taken, IV access secured, and routine monitoring was done. And parameters like heart and BP were recorded in the data collecting sheet. And all the patients were intubated, and patients who were randomized to IV lignocaine group, a single bolus of lignocaine 1.5 mg per kg are given at the time of incision, followed by maintenance IV lignocaine infusion at 1 mg per kg per hour perioperatively, and continued 24 hours postoperatively. Patients randomized to epidural group, epidural catheter placed through 10 to 11 or 11 to 12 thoracic vertebra level, and bupivacaine of 0.125% was started at 5 ml per hour from time of incision to 24 hours postoperatively. And pain assessed by numerical rating scale at 2, 4, 8, 12, 16, 24 hours. And heart rate and blood pressure was monitored both intraoperatively and postoperatively. And if numerical pain score is 3 but less than 4, injection paracetamol 1 gram is given as rescue analgesia. If pain score is equal or more than 4 but less than 6, injection tramadol 50 mg IV was given. And statistical analysis was done by UNPAT test depending upon the normality of the study. Coming to the results, pain score was assessed statistically in terms of mean and standard deviation, and comparison between the groups was done by students UNPAT test. At the end of the 24 hours, there is no statistical significance found, even though pain score appeared to be lesser in lignocaine group as compared to bupivacaine group. And coming to the rescue analgesia, it was found that mean duration was 13.84 hours in lignocaine group, while it was 8.92 hours in bupivacaine group. Hence, rescue analgesia with PCT between both groups was significant, showing early need of rescue analgesia in bupivacaine group. And injection tramadol mean duration was 24 hours in both groups and significant, not significant statistically. And coming to postoperative heart rate, systolic blood pressure, diastolic blood pressure, mean blood pressure, all are statistically insignificant. And coming to the discussion, in my study, I observed that the pain scores in intravenous lignocaine group patients were lesser when compared to epidural bupivacaine infusion group, and pain was measured in terms of mean and standard deviation, and comparison was done by students and party test. Although pain scores were comparatively less in lignocaine group, the mean difference was not statistically significant, and mean difference between heart rate and BP intraoperative and postoperative in both groups are statistically insignificant. And this insignificance between the both group indicates no difference in analgesia provided by both intravenous lignocaine infusion and epidural infusion. Hence, time for first rescue analgesia with PCT between both groups was statistically significant, and need for early rescue analgesia was seen in epidural bupivacaine group. While with injection tramadol, mean duration was 24 hours in both the groups, and mean difference in dosage from end of surgery to 24 hours postoperatively was calculated with injection tramadol, and average dose in lignocaine group was given 50 mg, while in bupivacaine group it was 66.67 mg, and which is statistically significant. Our studies compared with the Brain R. Swenson et al. Study in 2010, where he concluded that lignocaine is ineffective as epidural analgesia, and they recommended use of intravenous lignocaine as alternative to epidural analgesia. And was compared to another study by Abdullah S. Derkavi et al. In 2016, where he showed that the IV lignocaine infusion was not inferior to epidural analgesia with respect to pain score. IV lignocaine infusion group patients have good analgesia postoperatively as equal to the bupivacaine infusion group, and time for first dose of rescue analgesia from end of surgery was found to be lesser in bupivacaine group and statistically significant too. And hence, in lignocaine infusion proves to be a better alternative for postoperative analgesia in patients undergoing abdominal surgeries. And these are my references. Thank you.
You started IV lignocaine and epidural bupivacaine intraoperatively also.
Yes, ma'am. We started lignocaine is started like before the incision. We gave 1.5 ml per kg of bolus at the time of incision for lignocaine group. Then after that, after the incision, we started infusion at a rate of 1 ml per kg for the lignocaine group. But in case of epidural bupivacaine group, we started after putting catheter, that after test dose everything, then we started on infusion of 0.125% bupivacaine at 5 ml per hour, ma'am, intraoperatively, and continue 24 hours post-operatively.
And IV infusion lignocaine you have given with a fixed rate.
Yes, ma'am. 1 ml per kg standard.
And continue for 24 hours.
Yes, ma'am. Post-operatively.
Suppose the patient is average 50 kg. How much you require?
Ma'am, 50.
Have you calculated a total dose required?
No, ma'am. It's not like according to the body weight. We kept it as like 1 mg per kg, and like if it is 50 kg means 50 ml we will take. Like that only we kept. It's not like particularly very fixed dose. We didn't keep anything like that.
Have you noticed any adverse effects because of
ma'am, only
IV
one.
lignocaine?
Yes, ma'am, only one patient, not in lignocaine group, but in bupivacaine group, only one patient developed tachycardia. Like when at start of infusion, we don't know whether because it's due to any other causes. So we discontinued that. Only one patient we discontinued from the study, ma'am. Other patients we never seen any
Why
adverse effect.
tachycardia with epidural
like,
group?
that
That must be
ma'am,
because of any other cause.
Yeah, ma'am.
It's
So
not
we
related to epidural.
to epidural, like we don't know that time. We didn't know the cause. Like we ruled out everything, pain or like a depth, inadequate depth of anesthesia, everything. But still, tachycardia was persisting. So we discontinued epidural infusion in that one particular patient. But otherwise, all patients are okay, ma'am. No other adverse effects I didn't see in my study.
How you have given lignocaine with a means with syringe pump or with
Syringe
IV
pump.
infusion? Yeah, you have
Yes,
started
ma'am.
with
That
a,
IV infusion pump,
and
ma'am.
you
Yes, ma'am.
use
15.
yeah, and you
Yes,
must mention I have used means without preservative. You and how much
yes, ma'am.
percent you have used?
2%.
2%. for 24 hours.
Yes,
Infusion.
2%. Sorry, ma'am. Diluted to 1%, and I have used.
2% is a higher dose, means it will cross
ma'am.
the
It's
adverse,
the adverse
yeah,
effect, last.
toxic dose. Yeah.
Yes, ma'am.
What is the toxic dose for?
Lignocaine is for lignocaine, it is 1.5 ml per kg body weight. If it crosses more than that, we will develop loss. That is 1 to 5 microgram per ml is the analgesic dose for lignocaine. If it is 5 to 10 micrograms per ml, patient will start developing perioral numbness and tingling sensation, tinnitus, like that and all. Then if it
Have you noticed
crosses,
any case like that?
no, ma'am. In the study, I didn't notice any patient.
So you prefer IV lignocaine over epidural sensor?
Yes, yes,
Huh?
ma'am. Because epidural, the technique and everything is little difficult compared to our lignocaine infusion.
Actually, we
So,
developed that technique, blocks and epidural and this to reduce the doses of local anesthetics.
yes, ma'am. Yeah, but
and
now
to reduce the side effects of all the local anesthetics.
last.
Yeah.
Yes,
I will prefer epidural.
I don't have any questions.
Thank you, sir. Thank you, ma'am.
I'm Dr. Prabina of Madras Medical College. I'm here to present a paper on analgesic efficacy of ultrasound-guided dual subcostal and posterior transverse abdominal plane block for open nephrectomy, a randomized clinical study. Open nephrectomy involved subcostal incision and was one of the most painful procedure which required good postoperative analgesia. We gave dual tab block, the subcostal and posterior block, and evaluated its efficacy comparing with epidural block using injection of 0.25% ropivacaine and with the injection fentanyl 1 mics per ml. There were many studies comparing the analgesic efficacy of tab block in lower abdominal surgeries, and there were no study comparing its efficacy in upper abdominal surgery, especially in nephrectomy surgery. So we selected to compare analgesic efficacy in open nephrectomy. Our aim was to compare the analgesic efficacy of ultrasound-guided dual transverse abdominal plane block, so that is subcostal and posterior, and epidural block for open nephrectomy surgeries, and to evaluate its duration of postoperative analgesia. After obtaining ethical committee approval and patient satisfying inclusion criteria, that is age 15 to 65 years, ASA physical status of 1, 2, and 3, and who are undergoing elective surgery and who are given valid informed consent were included. And after randomizing by closed envelope method, the patients were grouped into group T, who received a dual tab block under ultrasound guidance using injection of 0.25% ropivacaine with fentanyl, or a group E who received epidural block with injection 0.25% ropivacaine with fentanyl, and they were all pre-oxygenated, induced, and were intubated with endotracheal tube, and surgery was proceeded with maintenance of anesthesia. At the end of the surgery, the patients were extubated, and post-operative numerical pain score were recorded in both groups at 0, 2, 4, 6, 8, 10, 12, 14, and 18 and 24 hours post-surgery, and duration of post-op analgesia was measured. The patients were administered injection tramadol as rescue analgesia if the pain score was more than 3. All the data were first collected and entered into Microsoft Excel spreadsheet and exported into SPSS software 24.0 for analysis. Descriptive analysis was made in the form of frequencies and percentage, and the data was also pictorially represented. And the two and a man who test or chi-square test or repeated measures ANOVA test were used for comparison between the group T and group P. And we have found the following results on comparison of the group E and T in terms of age, height and weight and gender or ASA physical status and duration of surgery, we found that there was no statistically significant difference between the both groups, and hence both groups are comparable. On comparing the duration of postoperative analgesia between the dual tab block and the epidural group, we found that epidural group a slightly increased duration of analgesia of 15.1 hours compared to that of the tab block group, which is 13.9 hours. But the duration of analgesia was difference in the duration of analgesia was not statistically significant, and this is an error graph showing the comparison of duration of analgesia. And on calculating the dose of rescue analgesia which was required in both the tab block group and epidural group, we found that there was no statistically significant difference between the consumption of tramadol between both groups. And on comparing that, the postoperative numerical pain scale between the groups T and E, the results reveal that there was no statistically significant difference in the mean numerical pain score for both groups starting from 2 to 24 hours into the postoperative period. And but there was a statistically significant variation in the mean pain score starting from the 2 to 24 hours, but the variation was similar. There was in a similar fashion for both the T group and E group, and hence there was no statistically significant difference between the two groups in terms of numerical pain score. Hence, I would like to say that ultrasound glided block, which are gaining popularity due to the ease of performance and lower complications, and able to perform, and it was able to perform in patients who are also on anticoagulants. So ultrasound tab blocks are also reduce postoperative pain and postoperative opioid consumption. There were 4 approaches to tab block and under USD guidance: subcostal, posterior, oblique, subcostal, and lateral. A subcostal block provided analgesia to upper abdominal dermatomal level. Posterior tab block, the literature say that the drug local anesthetics deposited into it sweeps into the paravertebral space, providing visceral analgesia also. And hence posterior tab block provided a lower abdominal pain relief and also visceral analgesia. Since the invent of tab block, many comparisons have been clinically studied, and we prefer to study the dual tab block analgesic efficacy in open nephrectomy surgery, which was a major abdominal surgery with subcostal incision and also limiting the patient's post-operative respiratory function. It definitely needed good post-op analgesia. On the numerical pain scores at 2 to 24 hours were comparable in the group T and E, similar to the study by Osri Kandi. And in the patients requiring rescue analgesia between the two groups, it was also a similar fashion. It was also similar, and the duration was slightly, even though it was slightly more in the epidural group, there was no statistically significant difference between them. Similar to the study by Carney et al., the post-operative analgesic requirement in the tramadol consumption was also not statistically significant. So the both, hence we conclude that both groups are comparable, and the analgesic efficacy of stab block is comparable to that of epidural block. Limitations of my study are that a control group was not there, and the dermatomal distribution of pain and intensity of pain at movement and coughing were not recorded. We found that dual tab block on the side of nephrectomy provided good post-operative analgesia comparable to epidural block. So, dual tab block may be a better alternative to patients undergoing open nephrectomy who cannot be provided with epidural block. And here are my references. Thank you.
Good morning. Good morning, sir.
So what was the total volume of the the local anesthetic that was used in either of them?
So in dual tab block, it was 20 plus 20 ml, sir. We did not exceed the maximum toxic dose for that patient, sir. We used ropivacaine 0.2%, sir, along with fentanyl 1 microgram per ml. So in tab block, it was totally 40 ml, and we calculated according to the weight of the patient, and we saw to that it does not exceed the toxic limit. And in epidural, we gave an infusion pump and also we calculated the total cumulative dose for 24 hours. It also did not exceed the toxic limits.
So you have used this tab block for the patients on anticoagulant.
In my study, the patients were not on anticoagulants. I included the patients with ASAPS3, they were not on anticoagulants. It may be used further in upcoming days. It can be used in patients who are on anticoagulants also, ma'am. So in patients who are on epidural, it cannot be given epidural because of their complications who are on clopilate or some other anticoagulants on heparin infusion. We can use dual tab block now.
Okay.
Thank you. Thank you.
We'll move on to the next one in case.
I think it's over.
Okay.
12%. Yeah.
Okay. 11 o'clock.
Ma'am and sir, this is the last presentation for today, ma'am.
Okay. Thank you.
Thank you.
Thank you, ma'am and sir, for joining.
Thank you.
Thank you, ma'am. Thank you, sir.
Thank you.
Thank you.
Hello.
Dr. Rasik, please start.
So we're moving into the next session. The topic is density and anesthesia challenges. For this session, I invite Chairperson Dr. Praveen Patel, Dr. Kamal Garg, and Dr. Veena Asthana. Dr. Praveen Patel, are you there? Hello.
Yes, I am online already.
Okay.
Before
Dr.
5
Veena
minutes.
Asthana. Hello. Dr. Veena Asthana.
Chairpersons, can we start the session?
Yeah,
okay. So
we can carry on.
I request to Chairperson to introduce the speakers and continue the session.
Okay, sir. I'll display the first slide, sir. Okay. Sir, we are starting for the first session. Okay, sir?
Good morning, everyone. I am Dr. Anshu from Lady Harding Medical College. I am going to discuss about airway challenges in morbid obese patients. First of all, I would like to thank the organizers for giving me this wonderful opportunity to present at this national and international platform. Now, what is obesity? Obesity is body mass index equal to or greater than 30 kg per meter square, and it is divided into 3 categories, where category 3 is morbid obesity or extreme obesity, where BMI is greater than 40 kg per meter square. There are various problems in morbid obese patients, of which the root cause is there is excess of fatty tissue in the breast, neck, thoracic wall, and internally also in the mouth, pharynx, and abdomen. So there are various challenges which are faced during airway management due to this excess of fatty tissue. Let's have a look at one by one on all these problems. There are respiratory problems because in morbid obese patients, some amount of respiratory insufficiency is always present. Due to excess fat deposition on chest wall and the rib cage, there is decrease in chest wall compliance. Also, there is decrease in pulmonary compliance due to pulmonary compliance is increased due to the small airway collapse due to the abdominal fat, which pushes the lung, and it causes the decrease in small airway function capacity, and there is decrease in functional residual capacity. Also, there is decreased in forced vital capacity and expiratory reserve volume. Due to all these changes, there is difficulty in ventilation as the desaturation is very fast in these patients due to the decreased respiratory reserve. Also, there are changes in the respiratory drive as carbon dioxide sensitivity and respiratory drive are dependent on the partly leptin content, and there is relative leptin insensitivity. So there is decreased ventilatory response to carbon dioxide. This leads to tendency of hypoxemia even at rest, and it is further attenuated when the person is lying in the supine position and is under anesthesia. So there is furthermore tendency for rapid desaturation under the conditions of apnea. Also, these patients have obstructive sleep apnea, where there are frequent episodes of apnea or hyperapnea, which occurs due to excess of fatty tissue in the pharyngeal muscle, which leads to pharyngeal muscle collapse during sleep. So airway becomes lax, loose, and not able to maintain its proper patency. And so there are frequent episodes of apnea or hyperapnea, hypoapnea, there is snoring, daytime somnolence, and pathophysiological changes. These changes include hypoxemia, hypercapnia. All these leads to systemic and pulmonary vasoconstriction, leading to right ventricular failure. And the respiratory center, the hypoxic drive is dependent, the respiratory center is dependent on the hypoxic drive. So there is type 2 respiratory failure. So principles of airway management include anticipate and assess, identify the areas of concern. There are areas which are impossible to access and some areas are difficult to access, and make an arrangement to optimize the difficult areas. And keep in mind that keep everything optimum for any airway management and always make a plan A, B, and C. And there should be provision for oxygenation at near to normal at all possible times. So when you have to anticipate, you will take a proper history and screen the patient for sleep disorders. History of OSA should be taken. Also, do not forget to take history of use of CPAP. And if the patient is using CPAP, you have to keep it ready intraoperatively as well for the postoperative period. And you can even ask the patient to bring his or her own CPAP for the postoperative period, so that you can use it, and you can also, patient is aware of the settings which patient can manage sometimes on his or her own. For history of OSA, we use stop bank questionnaire where we look for snoring, tiredness or daytime fatigueness. We observe observe that has anyone noticed the stop in breathing during sleep. We asked about blood pressure rising changes. So we mark yes or no and count the number of yes and no. Similarly, bang is BMI more than 35 kg per meter square, age greater than 50 years old, neck circumference greater than 40 centimeter, and the gender is male or female. If there are 5 to 8 yes, then it is high risk for OSA, and if it is 3 to 4, it is intermediate risk, and 0 to 2 is low risk for OSA. So we perform the airway examination. We use the line of sight approach for airway examination, which includes we'll observe the face for any deformity, coming onto the nose, whether it is deformed or narrow, and also look for the patency of the nose, because sometimes we have to use the nasal root also. Malar region is observed for any deformity. Mouth opening less than 3 finger breadth indicates difficult bag and mask ventilation, and there may be difficulty in supraglottic intubation. Similarly, buck tooth, you have to look inside the oral cavity for buck tooth, missing teeth, or any loose teeth, and you observe for the palate, which may be normal or high arch. Then we should look for the Mallampatti scoring, modified Mallampatti scoring, and grade 3 and 4 are obviously associated with difficult laryngoscopy and intubation. Also look for subluxation. Lower jaw should be observed for the excessive fat, receding narrow mandible, and submental space is very important. Where there may be excess of fat, look for the thyromental distance. If less than 6 centimeter, it is associated with difficult airway. And very, very important factor, neck circumference. If it is greater than 40 centimeter, then obviously it's a difficult airway. And you measure the sternomental distance. This sternomental distance less than 12 centimeter indicates a difficult airway. Also look for the range of airway movements, which may be restricted in an obese patient due to excess of fat. Whenever proceeding for management of airway in obese patient, always, as you have to keep the plan B and C ready, always preoperatively look for the surgical access. You can do a preoperative laryngeal handshake where you place the thumb and the index finger on the upper part of the larynx, that is at the greater cornu, and it is, as the larynx is conical in shape, you slide the fingers downwards, coming to the lower end of larynx and the junction of trachea. So at this, you slide the fingers and you keep your thumb and index finger at the level of trachea, and you palpate with the middle finger the cricothyroid membrane. Also, using ultrasound preoperatively, we can visualize the cricothyroid membrane. Nowadays, ultrasound is easily available in most of the institutes, so you can make use of cricothyroid membrane. So now we have identified the problem areas which can be difficulty in cooperation, difficulty in bag and mask ventilation due to the excessive fatty tissue or any deformities. Similarly, if mouth opening is difficult, mouth opening is restricted, or there is Mallampatti grading, which is 3 or 4, there can be difficulty in supraglottic airway device also, or there can be difficulty in laryngoscopy and intubation. Even due to excess of surgical fat, there can be difficulty in surgical access. And remember that extubation may be even more difficult than intubation, as there are many challenges associated with extubation, like decrease in the pharyngeal muscle tone, frequent obstructions, increased sedation after anesthesia. So beware of and do not take lightly the extubation part also. First of all, OT preparation. For that, always check the anesthesia workstation and suction should be kept ready. The OT table should be the designated table which can bear the weight of the obese patients. There are special tables which can bear the weight of up to 200 to 220 kgs also. Then all the monitoring equipments should be kept ready, and there should be a difficult intubation card, as you can see in the picture, which includes all the airway devices from oropharyngeal airway to supraglottic devices, various sizes of laryngoscopes, video laryngoscope, and intubating LMA, airway exchange catheter, and bougie should be kept ready. Also, a cricothyroidotomy set should be kept ready. If not available, you can make it using a syringe and a cannula. Positioning is very, very important in obese patients. Slight head up helps in, first of all, in ventilation, as there is increase in FRC and the airway collapse is decreased. So how do you place? We can place on a rammed position where we use a ram, and the sternum and the external auditory meatus lie in the same line. So this ram can be used, or if not available, we can use blankets or stacking of pillows like this in the picture to make a ramp. This ramp position not only helps in ventilation, but it also helps in intubation, because as you can see, when the patient is lying supine, all the axes are not lying in the same line. But when we place the patient on a ramp or a pillow, stack of pillows, the oral axis, pharyngeal axis, and the laryngeal axis are aligned, and the intubation is made easy. So after adequate positioning, there is oxygenation is to be done, and we can pre-oxygenate, as we have seen that supine, instead of supine position, head up helps. So we can keep a 20 to 25 degree head up and place the patient on the ramp. Use of CPAP helps in increasing the functional residual capacity. So CPAP may be used for pre-oxygenation. Also, what we can do for para-oxygenation, that we can give high flow nasal oxygen therapy. In this, from ventilation, when the mask is placed, like you can see in this, the nasal prongs are being placed, and above that the mask is placed. So you can use nasal cannula for para-oxygenation during bag and mask ventilation, and during even intubation, as you can see in the picture. Nasal prongs give flows up to 15 liter per minute. But as nothing is, there is nothing which is not associated with side effects. So this also has side effects, like there can be mucus dryness, because it does not humidify the gases, and gases are not heated up. There can be also carbon dioxide accumulation, which can lead to hypercapnia, atelectasis, and patient discomfort. To overcome this problem, we can use Thrive, which is transnasal humidified rapid insufflation ventilatory exchange, in which we use the high flow nasal cannulas, where a heated inspiratory circuit is there, which gives the heated and humidified air. Air is heated up and humidified and provided with high flows up to as good as 70 liter per minute. This will help to some extent. This will also lead to washout of carbon dioxide, so there will not be hypoxemia and increase in CO2. So besides para-oxygenation, now how do we ventilate? As all of you must have observed, bag and mask may be very difficult in these patients. So something extra is required. You may use four-handed technique. As you can see in the picture, two people are required for this. One which holds the bag and mask, the mask for ventilation, and another person is giving the ventilation. Also, you can use ventilator with the mask if you don't have any other person to help you nearby. You can hold the mask and attach it to the ventilator, or you can use airway adjuncts like supraglottic device for ventilation. There are many times that in bariatric surgery cases or when morbid obese patient comes for other surgeries, we use supraglottic devices for intubation as well as during the extubation to make the ventilation easier in both the periods. Supraglottic airway devices used for ventilation should be maybe required maybe one size smaller than the normal, and it helps to increase the safe apnea interval and para-oxygenation also. Now, for laryngoscopy in intubation, as we have discussed the role of adequate positioning in the head up and placing a ram, also we can use a short handle blade which helps in intubation, not so that chest and thoracic cavity is not hampering the handle of the blade sometimes. And we can use video laryngoscopes, which makes intubation very much easier than a normal laryngoscope. And in some cases where they desaturate rapidly in the supine or even in the head up position, slight head up position, in these patients, we may plan for awake fiber optic intubation also, but you should keep para-oxygenation always in mind whenever performing any of these techniques. And also remember, with increasing BMI, tracheal diameter reduces slightly, so shorter diameter endotracheal tube may be required. And as I have emphasized, that extubation may be much more difficult than the intubation. So always keep airway exchange catheters ready. You can slide the tube on the airway exchange catheter and then remove the tube and look for the ventilation. Also, sometimes we use supraglottic devices where through supraglottic device we perform pass the tube, and whenever we feel that it is sufficient, we remove the supraglottic device. Also, in post-op period, CPAP should be kept ready, and sometimes patient may be requiring CPAP for many days after the surgery being performed. So thank you for my patient listening and your attention. Thanks a lot.
Chairpersons, can we start the next video?
Yes.
Sir, can we start the next video?
Yes, yes, sure.
Okay. Sir, next we invite Dr. Aparna Sinha.
Dr. Aparna Sia is a very senior anesthesiologist in Max Institute in New Delhi, and she is a very senior consultant, and she has done a lot of work in bariatric surgery particularly morbidly obese patient she has managed since last 12 to 15 years. She has also written one book for perioperative management in morbidly obese patients. So let us start with Dr. Aparna's video.
Good morning, everybody. So at the outset, I would like to thank the organizers of Isacon 2021 to having me here to deliver a lecture on this topic, and would also like to congratulate them to include such forthcoming topics in the CME. So I bring greetings from Max Institute of Laparoscopy, Endoscopy, Bariatric and Robotic Surgery, Max Arcade, New Delhi. So today I'm going to talk about ventilating the obese patient. So why, first of all, why is this a topic at all? So ventilating an obese is a special topic and definitely needs special considerations to, having this topic as a separate unit in this session. So to begin with, I have no disclosures to make whatsoever and no conflicts of interest. This lecture is based on my current evidence and personal experience. So first, let us see what does the evidence say. Now, there is this landmark paper that was published in 2018 in British Journal of Anesthesia, and there they analyzed intraoperative ventilation strategies and their association with post-op pulmonary complications. And they studied a large database of almost 10,000 patients. And what did they find? They found that, now in this group, there were more than 2,000 obese patients that were included. And they had included, consecutive patients from more than 135 centers across the world. So they found that the incidence of post-op pulmonary complications, which is popularly known as PPC, is directly related to BMI. Higher the BMI, higher is the prevalence of post-operative pulmonary complications. So what is happening? Why is it so? They also further studied 30-day morbidity and mortality in patients undergoing non-bariatric surgery for different weights. Now, here they found that the morbidity and mortality is definitely higher at extremes of BMI. So what do we mean by extremes of BMI? BMI less than 20 and BMI less than 40. So today, definitely, we are going to focus on BMI more than 40. And, the in-between group is a topic in itself, which can be discussed some other time. So I'm going to focus on patients with BMI more than 40. So they found that whenever the BMI is crossing 35-40, which means that the morbid obesity is increasing, patients are having more and more 30-day morbidity and mortality. So what is happening? Why is it happening? Now, we are aware that, an obese patient will have some different anatomy as well as physiology. Now, an obese lung is compressed from all the sides, from the fat around the chest wall as well as the fat in the abdomen, which is constantly compressing the diaphragm. So the result is that all obese patients have some degree of restrictive lung disease. So this is a basic pathophysiology. This is a basic thing that we start with, even if we do not have a pulmonary function test. If a patient is having a BMI more than 30, for example, which means if the patient is obese, and if this BMI is rising more than 30, at every step we know that adiposity is increasing, and it is causing some degree of compression of the lungs and chest and resulting in restrictive lung disease. And if we have a closer look at the lung volumes, we will see that an obese patient will have a low FRC, a low expiratory reserve volume, and a smaller airway caliber, a higher airway resistance, and a lower potential to withstand hypoxemia as a result of that. However, if we compare two patients, a large patient, which means a patient who has extreme adiposity, and a lean patient, we should understand the fact that their lungs are proportionately of the same size, which means that the lung size is directly related to the predicted body weight or the ideal body weight and not related to absolute body weight. So this is the basis behind all the morbidity and mortality that we are seeing in patients with large body habitus, patients with extreme adiposity, also known as patients with morbid obesity. So in these patients, when we are mechanically ventilating these patients, they are producing what is known as ventilator-induced lung injury. Now, ventilator-induced lung injury has become increasing. It is something that has caught the attention of researchers and practitioners alike, and it has become a distinct entity and is calling for attention because this is a completely preventable thing. So prevention, we know, is better than cure. So in an acute setting, in an intraoperative setting especially, where the focus of this lecture is on the intraoperative setting, our aim should be to prevent any ventilator induced lung injury. So just like we have therapeutic window for a pharmacological intervention, similarly, there is a therapeutic window for a mechanically ventilated patient as well. So this is something that we need to revisit, and we need to re-emphasize to ourselves and to our trainees. So going back to the same study, so what did they find? So they found that these morbidity and mortality is directly related to, the PPCs are directly related to findings in the ventilatory settings. Obese patients, they found, were receiving much higher tidal volume and lower positive end expiratory pressure, and that the PPCs were associated with higher BMI, and that in these patients were receiving recruitment maneuver using a reservoir bag. So what happens when we are performing a recruitment maneuver using an reservoir bag? We may be administering an indiscriminately high amount of tidal volume to these patients, which could be responsible for causing the ventilator associated lung injury. So Willi can be further, classified as, in happening in different segments. So what is happening with large tidal volumes and low positive end expiratory pressures is that we are causing atelect trauma, we are causing barotrauma, we might be causing volutrauma and biotrauma. So Willi is a summation of all these factors occurring together. So it has been found that the current focus of management is on prevention by protective ventilation. So we have to offer protective ventilation to all the patients, and especially the obese patients, because in many centers the BMI is not calculated, it is not readily available, and we just make an arbitrary assumption based on the patient's habitus. So we need to change the way we look at our patients. We need to change how we document the demographics of the patient, and a closer attention needs to be placed to what exactly is the BMI, how much is the exact weight, and what is the height of the patient, so that we have an idea of how much is the predicted body weight, which is also, we can say, close to the ideal body weight of the patient. So prevention by protective ventilation has caused a paradigm shift in the way we look at mechanical ventilation. So by causing for administering prevention by protective ventilation, we have to provide optimum tidal volume and optimum amount of PEEP and optimum recruitment maneuver. Now, all these three parameters need to be provided together. And it is not that, we can either choose optimum tidal volume or optimum PEEP or optimum recruitment. So all the three need to be provided together. And the focus has to be to prevent administration of large tidal volumes and large airway pressures. At the same time, we need to prevent atelectasis, which means that we need to provide ventilation in such a way that we open the collapsed alveoli. Now, what is the main objective of intraoperative mechanical ventilation? Now, the main objective is to ensure gaseous exchange, which means to maintain SpO2 and to maintain end-tidal CO2, and to minimize any risk of post-operative pulmonary complication by optimizing the ventilatory settings. So this is known as the lung protective ventilation. So what exactly is happening in the post-operative period? Now, during the post-operative period, after induction of anesthesia and after performance of surgery and all the changes that are happening, actually what is happening is that the patient in the immediate post-operative period would be having a low vital capacity, low FRC, and low tidal volume because of the effects of pain, effect of surgery itself, where the retractors must have been used, or there is some sort of increase in intra-abdominal pressure. Patient might be having cough. There is residual effect of the anesthetics. Patient may not be awake enough to perform deep breathing. There is atelectasis. There is some degree of diaphragmatic dysfunction. This, along with fluid administration that is happening, would cause some degree of hypoxemia. So our protective ventilation has to target towards prevention of post-operative hypoxemia. So protective ventilation has to avoid large tidal volume, high airway pressure, avoid airway collapse by limiting the tidal volume to 6 to 8 ml per kg of the predicted body weight, and administration of PEEP of 8 and more. So this paradigm shift needs to be incorporated into our practice. So we need to open the alveoli and keep them open. So this is what should be the aim of choosing a ventilatory strategy. This should be the aim of providing the lung protective ventilation. So how do we do that? Now, the concept of POP ventilation, that is positive per operative protective ventilation, has made its mark, and it aims to minimize lung collapse and maximize lung recruitment in the perioperative period. So how is this achieved? By providing positive pressure in different stages of anesthesia, right from the pre-op to the post-operative period. In the pre-operative period, we need to start with deep breathing exercises, CPAP or BiPAP, if the patient's physiology demands, depending upon what is our assessment. Some patients are already on some sort of non-invasive ventilation. The other patients, we find out that they need their obstructive sleep apnea to be optimized, and we administer NIV as and when required. So we have to, in the preoperative period and even in the immediate preoperative period, need to optimize the patient, and by providing positive pressure in different forms. So this will help in recruiting more and more alveoli even before the patient is taken for induction of anesthesia. Per-operatively, again, low tidal volume, high PEEP, and performance of recruitment maneuver. Whereas in the post-operative period, we have to provide preemptive non-invasive ventilation wherever possible. So what happens in the preoperative period and in the intraop period when we are planning to provide the pre-oxygenation? Now, we know that in a normal lung, we have been learning for decades, is the patient, with a normal physiology would be having a PO2 around 100. And when we pre-oxygenate, we elevate the PO2 from 100 to maybe a figure more than 400. But what is happening in a patient with morbid adiposity is that even after optimization, we may not be able to achieve a PO2 of more than 60. So we are starting with already a compromised patient. We are already starting with a compromised patient. So in this patient, if we use the same technique of pre-oxygenation, I may not be able to even reach a PO2 of 100. So why is this happening? Patient is already having atelectasis and some degree of hypoxemia. So it has been shown in enough and more studies, and it has been accepted and brought into practice of many practitioners, that when we are pre-oxygenating, we need to perform some degree of positive end expiratory pressure in the form of CPAP, or in we need to maintain a patient in a head-up position. And in centers where there is no provision, the anesthesia workstation does not have a facility to give CPAP at the time of pre-oxygenation, we can even use APL valves. Because what happens is that, even in a normal patient, there will be some degree of atelectasis after induction of anesthesia. So in an obese patient where we are already starting with an atelectatic lung, this can be further magnified. So our patient will desaturate in much earlier at the time of laryngoscopy and intubation. So we need to bring the baseline O2 to a much higher level by including positive pressure ventilation in the pre-oxygenation itself. So our pre-oxygenation approach has to be much more rational, and we need to achieve an end tidal oxygen of more than 95 with use of non-invasive positive pressure ventilation, so that we bring our a patient's threshold to a much higher level, so that the safe apnea time is prolonged and the patient can tolerate the period of laryngoscopy and intubation much better. Because as it is, we know that these patients might be having a challenge with their mask ventilation and with laryngoscopy and intubation. So we need to keep our patients in much safer zone anesthesia. So we have to optimize the role of NIV in an obese patient. So we must understand that there are multiple other factors also which are governing the success of non-invasive ventilation in the perioperative period. So we are aware, that these patients, majority of them, at least 60-70% of the obese patients surgical patients, are having some degree of sleep apnea as assessed by clinical scoring system. So these patients, even during a normal sleep, even a lean patient will have a drop in the airway tone and some degree of collapse of the airway. But in an obese patient, this collapse is of much higher degree. So at the time of induction, we must be prepared to take care of this airway collapse. Otherwise, no matter how effective our ventilatory strategy is, we will not be able to help the patient with ingress and egress of gases. So we need to understand that we have to have a multi-pronged approach. So it is not just choosing the ventilatory strategy. We have to understand how we will be able to give an effective ventilation to the patient. So the airway needs to be open. So if the airway is open, we must know how we need to keep the airways open. So it has been seen that if the patient is in a head-up position, in 25 to 30 degree propped up position, the airway is much more patent. Intubation. So pre-oxygenation with 100% oxygenation, CPAP of at least 10 centimeters of water, using ramp position, applying positive end expiratory pressure, then maintaining continuous nasal insufflation throughout the period of pre-oxygenation, and using supraglottic devices wherever possible. Now, these parameters have been re-emphasized in the current ASA airway guidelines of 2022 that have been recently released, that there is importance of continuous oxygen administration throughout the perioperative period. And of course, we do not have to hyperoxygenate. But at the crucial moments of intubation and extubation, we need to be providing continuous inflow of role of nocturnal oximetry. Even if we do not have a detailed level 1 sleep study, nocturnal oximetry is a level 4 sleep study, which is done on a home care basis. So we need to pick up the important parameters from there. And these parameters will help us in providing effective positive airway pressure titration and in prognosticating our patient. At the same time, we must, wherever possible, start noting down what is the end tidal CO2 in the post-operative period and deciding the time of non-invasive ventilation based on the end tidal CO2 rather than just SpO2. SpO2, we should not target more than what was the baseline SpO2, because if we oxygenate the patient without knowing the end tidal CO2, we may take away the drive and our patient may land up in an apnea. So we have to maintain a balance between the end tidal CO2 and the SpO2. So the role of capnometry in the post-operative period in achieving the desired non-invasive ventilation is becoming more and more important. So we have to choose between supplemental oxygen and positive airway pressure. So this is the current concept that we must imbibe and must start bringing into practice. So wherever possible, try to find out what is the end tidal CO2 of your patient in the post-operative period. The normal sleep pattern. So intraoperative ventilation strategies. Now this lecture is mostly confined to intraoperative period only, and mechanical ventilation in the post-operative in the critical care area is a topic, a separate topic itself. So here we have confined ourselves here. So improvement in oxygenation and compliance of the patient and of the system. Recruitment maneuver. Apply positive end expiratory pressure wherever possible and try to find out what is the optimum positive end expiratory pressure for your patient. Now, choosing between volume control and pressure control, both are equally effective. So though we need to maintain a high end tidal O2 in the intraoperative environment, in the post-operative period, we have to be very cautious that we do not have to hyper-oxygenate the patient. That I conclude my lecture, and the house is open for any question answers that we would like.
Thank you, ma'am, for the excellent presentation as usual, ma'am. Hello. I cannot see any questions in the box, ma'am.
Veena, I'm around.
Hello, ma'am. Good afternoon, ma'am.
Hi.
That was an excellent presentation as usual, ma'am. And I don't see any questions in the ma'am chat box.
So, yeah. So if you have any queries, I'm around.
Ma'am, I don't have it. Hello, am I audible?
Yes, I'm listening to you. Yeah.
Yeah. Ma'am, per se, what is your experience of using supraglottic devices versus the endotracheal intubation in the shorter surgical procedures, ma'am?
No, so my experience with supraglottic device is very good. Can you hear me? Can you hear me?
Yes, ma'am, I can hear you, ma'am, very well.
Maybe you can see me also because I'm in one corner of my OT. So I'm sure you can see me as well. Yeah?
Ma'am, I am also in the OT only.
So we all understand the limitations of anesthesiologists. So my personal experience, experience with supraglottic device is excellent. And for brief surgery, there is no doubt about
which supraglottic device?
I'm using Proceal.
Okay, second generations.
So my message for anybody who wants to know about it is that, so we don't choose the size according to the weight of the patient, mostly because of the larger neck and because of too much fat inside. Even a smaller supraglottic device will be well fitting. So in fact, supraglottic devices, they fit very well in these patients. There is minimal leak because the surrounding fat acts like a padding. Okay. And prevents PEEP. And then 99% of our patients will be in a head-up position, right?
Okay, ma'am.
So that allows a higher airway pressure to be, taken care of. So even if your peak airway pressure is touching 30, they will not be leaking.
Thank you, ma'am.
Yeah, thank you so much, Dr. Veena.
Thank you, ma'am. Thank you, ma'am.
Yeah,
Thank you so much for that wonderful presentation, ma'am.
Thank you. Thank you.
Thank you.
Hi, good morning. I'm thankful to organizer for giving me a chance to speak on Isacon. So my topic is the calculation of the anesthetic drugs in obese patients. So this is my patient, which I did few years back for bariatric surgery. He was a 170 kg. And if you remember, this is the gown of the highest weight of the patient in the world. He was a 500 kg patient. So what are the problems in obese patient where we should be very careful about the anesthetic drugs? There are some peculiar problems in obese patient like potential upper airway obstruction, post-operative respiratory depression, cardiorespiratory complication, pulmonary embolism, increased risk for aspiration these patients, and the airway obstruction and death is sometimes due to the airway obstruction is the most important factor we should worry about all the sedative or anesthetic drug, even with the minimum doses. How these patients are different from the normal patient and how they affect the anesthetic dosing. Like this patient have the increased adipose tissue, increased blood volume, higher cardiac output, but the total body water is decreased. They have the high weight because of the fat, but total body water is less. Altered protein binding they have the increased renal blood flow. They have the altered affinity of drug for plasma proteins, different body composition, and the regional circulation is changed. So what happened? The drugs which are highly lipophilic, they have the increased volume of distribution, whereas the less lipophilic drugs, they have the little or no change in volume of the distribution. Increased blood volume in the obese patient decreases the plasma concentration of the rapidly injecting intravenous drug. Fat is very poor blood flow, so doses calculated on actual body weight could lead to excessive plasma concentration of drug because these drugs are easily available in the plasma due to the less blood flow to the fat. Hepatic clearance is normally not affected. Renal clearance of drug is increased. The most important thing, all the anesthetic drugs or the pharmacokinetics, when they have done the trial, they normally avoid the obese individual. So whatever the drugs dosing information is available, they are per kilogram of the total body weight. Here, the actual total body weight is more due to the fat, but the blood due to the fat, the body water is less. So if you take the total body weight with the increasing obesity and fat mass, there is a increased amount of total body weight. The majority of the cardiac output is still directed to the vessel rich or lean tissue mass, and there are the less circulation of the fat. So therefore, administration of drug based on the total body weight results in the overdose. So we should take the ideal body weight of a morbid obese patient, which is less than their actual lean body weight. Therefore, administration of a drug based on the ideal body weight may result in the underdosing because the ideal body weight is less. So lean body weight is different between the total body weight and fat mass. So lean body weight increases with the increasing total body weight. This increase is not proportional. As the absolute value of the lean body weight increases, the ratio of the lean body weight and total body weight decreases. So lean body weight is significantly correlated to cardiac output, which is an important determinant in the early distribution or kinetic of drugs. So drug clearance increases proportionate with the lean body weight. So what is the ideal body weight? If you want, there is some formula which are very popular and easily available in internet, like Boca's index, where the ideal body weight is equal to height in centimeter minus x, where the x is the woman in the 105 and in men it is 100. There is one more formula, Devine 1974. This equation lacks the scientific basis, but it is easy to use and we can use at the bedside. And the extensive use for variety of medical application has made it the standard method of the estimating lean body weight. So ideal body weight in man is the 50 plus 2.3, where is the 2 in height over the 60 inches, whereas the ideal body weight in women is the 45.5 plus 2.3 into height over the 60 inches. So what is happening? The lean body mass is equal to body weight minus body weight into the body fat percent. So lean body mass is comprised of everything in your body beside the body fat, which includes the organs, blood, bones, muscles, and skin. So lean body mass increases with the total body weight. Fat tissue keeps on increasing in proportionate to total body weight. So the relative percentage of lean body mass per total body weight decreases. So to know the lean body mass, which is very, very important in obese patient, there are some, again, formulas. So lean body mass in man is equal to 1.10 into weight in kg minus 128x, where the weight per square meter or the 100 into the height per meter square. So lean body weight in women is the 1.07 into weight per kg minus 148 into weight square minus 100 into the height meter square. So lean body weight 2005 is an accurate validated method of measuring the lean body mass. So in this formula, lean body mass 2005 in man are the 9.27 into 103 into actual body weight divided by 6.68 into 103 plus 216 into BMI. Whereas in women, it is 9.27 into 103 into actual body weight divided by 8.78 into 103 plus 244 into body mass index. So adjusted body weight is very important. So adjusted body weight is equal to ideal body weight plus 0.4 into actual body weight minus ideal body weight. So now we will talk about the different anesthetic drugs, how they are affecting and what should we consider when we are administering these drugs in the obese patient. So 48% of the adverse respiratory events are secondary to opioids, associated with the obstruction of the upper airway obstruction. Abnormal breathing patterns includes the central sleep apnea, OSA, ataxic breathing, and hypoxemia. Morphine we should consider as the ideal body weight, fentanyl again ideal body weight, remifentanil ideal body weight, but sufentanil we should consider as a total body weight. Alfentanil is the prolonged elimination. Propofol is a highly lipophilic. So rapid short duration induction is the lean body weight. For continuous infusion, titrate the drip doses according to sedation goal. Cardiovascular sometimes effects are large doses of the propofol can cause hypotension and bradycardia, which normally we see daily practice. If you give the propofol, so we should give propofol slowly and seeing the response of a patient. Etomidate lean body weight. Thiopentone is the lipophilic. So induction is by 7.5 milligram per kg ideal body weight. Maintenance is the total body weight. The other sedative like midazolam for the bolus doses, we should consider total body weight. And when we take as a continuous infusion, it should be ideal body weight. Dexmedetomidine, highly selective alpha-2 agonist. It is used for the procedural sedation normally in the obese patient. And when we give the opioid-free anesthesia, the dexmedetomidine is the important drug in formulation of the opioid-free anesthesia. So the doses is the 0.2 microgram per kg per hour is recommended. Sometimes we give even the 0.1 microgram per kg per hour to avoid hypotension and bradycardia. Muscle relaxant succinylcholine is used for intubation if there is no contraindication. So we must take the or calculate the dose of the succinylcholine as the total body weight. So sometimes this obese patient, they have the pseudocholinesterase activity. So we should be very careful, but there is no compelling evidence for this. Other muscle relaxant, non-depolarizer like atracurium, it is the ideal body weight. So no change in the absolute clearance, absolute volume of distribution, and the absolute elimination half-life. So ideal body weight is always predictable, muscle strength recovery within 60 minutes. Cisatracurium, total body weight for induction. For infusion, it should be ideal body weight. Vecuronium, ideal body weight, but if the patient has the impaired hepatic clearance, so increased volume of distribution. So you can expect the delayed recovery. So doses should be considered like that. Brachyuronium, again ideal body weight. Reversal neostigmine, total body weight. Sugmadex is ideal body weight. Inhalation agents like nitrous oxide, little information. There is no such changes. But isoflurane, most lipid soluble, theoretically increase peripheral distribution of isoflurane and result in increased time to recovery. So doses of isoflurane is the 0.6 max. Sevoflurane, no differences in the fluoride concentration between obese and non-obese patient. So least lipophilic and least soluble. Blood gas partition coefficient is 0.65, more rapid uptake and elimination in obese. Desflurane, the least soluble volatile anesthetic agent with a blood gas partial coefficient is 0.45. Because of the low solubility, desflurane has a limited distribution to peripheral tissue. The time constant for equilibrium with the adipose tissue for desflurane is normally 13-50 minutes. Recovery is faster in obese patient and non-obese patient. If you see the local anesthetic agent, lidocaine, which is normally used all the obese patient and normally all the patient. So they have the increase of absolute volume of distribution, unchanged volume of distribution adjusted for the body weight. Because this obese patient has the increased epidural fat content and epidural venous engorgement. So we should be very careful when we are giving intrathecal medicines. IV dose is not very much different from the other patient, but extradural doses is 75% of the dose of the total body weight. Bupivacaine, no information. Again, when we are giving intrathecal bupivacaine, we should be careful because of the increased fat and the increased venous engorgement of the epidural system. Anticoagulants, which are normally used in the obese patient in the bariatric or non-bariatric surgery. So enoxaparin, total body weight. For prophylaxis, BTA prophylaxis, more than 40 milligram per meter square, increase doses by 30%. For the treatment, if the BMI is more than 27K, then we should avoid once daily doses. Anti-Christmas factor level monitoring is not required normally if the patient is more than 190 kg. Then we should not do if the patient's weight is less than 190 kg. Deltaparin, total body weight for the VTA prophylaxis, if BMI is more than 40, then increase doses by the 30% like the enoxaparin. For treatment, once daily dosing, 200 unit per kg is okay. Again, here also anti-XA factor is not required to monitor if the patient is less than 190 kg. Fondaparinux, for prophylaxis, use the standard dose, that is a 2.5 milligram daily. If patient's BMI is more than 40 kg, so we should always know about the anti-10A level. Heparin dose usually adjusted according to body weight. Studies have shown that using actual body weight without a dose cap is associated with a higher appetitive value. Heparin infusion should be titrated to an APTT level like every 6 to 8 hours. So what are the different drugs given by the lean body weight? To summarize, is the propofol for induction, thiopentanyl, rocuronium, atracurium, vecuronium. These are the muscle relaxant, should be given by the lean body weight. Morphine, paracetamol, bupivacaine, lidocaine. Whereas the drugs which are given by the adjusted body weight are the propofol infusion, antibiotics, low molecular weight heparin, alfentanil, neostigmine. But maximum dose of the neostigmine is the 5 milligram. To summarize, the incidence of morbid obese are increasing day by day as our TV is becoming thin and thin, but the population is becoming obese. And we are exposed to the morbid obese patient in daily practice, maybe for bariatric or non-bariatric surgery, even the obstetric practice and other practice also, even the pediatric practice. So estimating the optimal dose for obese patient is difficult and in many cases sometimes not really defined. So we should careful about consideration of the optimal doses for necessary safe and effective administration of anesthesia. Thank you so much.
Thank you, ma'am, for the wonderful presentation, ma'am. Any questions from the audience? I don't think there is any question, ma'am. Thank you, ma'am.
A very good morning to one and all. Greetings from the cleanest city of India, Indore. I'm Dr. Deepthi Saxena, Professor and Head Anesthesiology, Sri Aurobindo Medical College and PG Institute, Indore. My topic of presentation is regional anesthesia in morbidly obese patient, practical tips for success. Now, as we think of obesity, the first picture that comes to our mind is this: a person with a huge tumor and suffering from all these diseases: type 2 diabetes mellitus, hypertension, coronary artery disease, OSA, osteoarthritis, psychiatric disorders. Now, these patients are prone to develop these diseases sooner in life as compared to non-obese patients. Now, I need not discuss the advantages of regional anesthesia. This picture is enough to describe it. I would like to focus on the problems that we face in obese patients. Regional anesthesia is actually difficult to perform. There is difficulty in palpating the anatomical landmarks and positioning the patient. Requirement of special equipment is there, and it is not always available. There is increased rate of failure and complications in morbidly obese patients. And if at all regional anesthesia becomes inadequate during surgery, the necessity of induction of general anesthesia is more problematic related to the presence of ideal conditions. Now, if you ask me for the solution of all these problems in one word, I would definitely say USG. But unfortunately, in Indian scenario, we don't have USG available everywhere, and most of us are not well conversed with the use of USG. So what I would be doing is discussing peripheral nerve stimulators, positioning, every aspect of the nerve blockade, and discussing the problems that we face and the solutions. Now coming to the central neuraxial blockade, this is the intercrustal line, which is the highest line joining the two iliac crests, and it passes through the L4, L5 interspace. Just imagine this line in this patient. Can you palpate? Now this is very difficult to palpate in obese. Now this is the same patient, and the patient is draped. The landmark which were already difficult to palpate has become almost obscure. So this is my first tip. Mark your entry point before painting and draping. Paramedian approach is something which we use off and on. It is normally used when median approach fails. The use of paramedian approach in obese patient is a bit controversial. Let me tell you why. Normally, the skin to epidural space depth is less than 3 centimeters in a patient of, or in a person of a BMI less than 20 kg per meter square. But as the BMI increases to 40 kg per meter square, the depth increases to up to 9 centimeters. Now, if you're performing a paramedian approach in obese patient, as the patient weight increases and higher the puncture level, that is, if you move towards thoracic spine, deeper will be the epidural space from the body. So you will encounter actually more deeper epidural space if you go paramedian. So caution is required, and if at all you have to use this approach, use a longer needle. Experience of the practitioner is actually directly related to the success rate. Trainees who were able to perform spinal anesthesia in anatomically easy patients faced a failure rate of 52% in those patients with a difficult habitus. Consultants were able to place spinal anesthesia even in difficult patients, but in 42% of cases, 3 or more punctures were required. So definitely, the procedure in morbidly obese is difficult, even in experienced hand. So if you want to improve your success rate, you will have to practice, and more practice. Now, Lee M. et al. Found that in obese parturients, if the BMI is less than 35 kg per meter square, ultrasound guidance is not at all superior to conventional manual palpation. However, if the BMI increases above 35 kg per meter square, ultrasound guidance significantly improves the first attempt success rate, reduces the number of needle passes, and reduces all procedure-related times. How do we use USG for central neuraxial blockade? There are 2 techniques. One is ultrasound-assisted puncture, and the other is real-time US-led neuraxial punctures. Most commonly, we use ultrasound-assisted puncture as it is a bit easier. In this, what we do is we perform a pre-procedural examination, USG examination of the spine. We locate the interspinal space. We locate the interspinal space, and we anticipate and determine the depth of the epidural space, mark the entry point, and then finally the epidural or spinal puncture is performed conventionally without sonography. This is the most commonly used method. Real-time US-led neuraxial punctures are difficult to perform. Their implementation is very difficult. Why? Because with one hand we will be using the probe and with another we will be giving the block. So it has a huge learning curve and is not very popular. However, recent literature is says that it is the future technology. Positioning is very important in these patients. Sitting position definitely helps because it opens up the interspinal space. And it should be done before administering sedation, as these patients are very difficult to move. Longer needles should be used in these patients. Now, the available lengths include 8, 11, and 15 centimeters. 8 is the normal one that we use, and 11 and 15 are the longer ones. Now, if you don't have USG, how will you anticipate which needle is to be used? Now, there are few points that I would like to mention. First one is abdominal girth. If the abdominal girth is more than 100 centimeters, chances of encountering an epidural space at about 9 centimeters or more than that is actually increased by 32 times. So more is the abdominal girth or greater is the abdominal girth, more is the chances of encountering a deeper epidural space. So use a longer needle at the first puncture itself. Level of lumbar puncture is important, especially in morbidly obese patients, because as you go higher up, the amount of fat in the interspinal space decreases, hence the depth increases and ease increases. So it is advisable to perform lumbar puncture in morbidly obese patients at a bit higher level, although cautiously. Female obese patients have a higher chances of encountering greater depths because of the distribution of gluteal distribution of fat in the gluteal region. So the amount of subcutaneous tissue is actually increased and the depth of the space increases. Now we all know that there is increased failure rate of regional anesthesia or central neuraxial blockade per se in obese. A study done by L. Catherine shows that there is significant epidural catheter movement with reference to the skin in all BMI groups as patient changed position. Now, to minimize the risk of catheter displacement, what we can do, particularly in obese patients, we can use multi-orifice catheters, which should be inserted at least 4 centimeters into the epidural space. There is a huge learning curve in regional anesthesia. Lesser experience and practice of the anesthesiologist definitely increases failure rate. Now, this study was actually not performed in obese patients, but we can extrapolate the results that we find here to the obese population as well. Now, this study conducted by El Kirisella is very good study which shows that hypotension is actually frequent in morbidly obese women than non-obese control during epidural anesthesia. This was actually performed in patients in labor. That is the parturients. Most of the studies that we find for central neuraxial blockades are actually in pregnant females. Now, what they said is that morbidly obese women have a higher circulating blood volume and cardiac output of normal weight women, so they require greater volumes of intravenous fluid to achieve adequate volume preloading prior to regional anesthesia placement. So you should adequately give fluid, more volume than the non-obese population. However, it is very difficult to quantify. It will depend on patient to patient and associated comorbidities. Now, J. Cheng et al. Have found that central obesity is actually related to a more extensive spread of spinal anesthesia in female patients. Now, possible mechanisms include abdominal pressure and epidural pressure, which are already more in these patients, increase further when they are turned from lateral decubitus to sitting position in the to supine position. Greater waist circumference aggravates the increase in abdominal pressure. Now, as a result of this pressure, there is inward soft tissue movement in the intervertebral space, thereby decreasing the CSF volume. As a result of decreased CSF volume, there is extensive spinal block through diminished drug dilution, because CSF actually acts as a drug diluent to local anesthetics. What we can do, we can actually reduce the dose in obese population. This factor is also very controversial. Some people say you need not decrease the dose. Some say that you should actually decrease the dose. Now, how much is to be given will again depend on patient and associated comorbidity. Post-dural puncture headaches, it was initially believed, are lesser to occur in morbidly obese patients. However, recent studies refute so. They say that morbid obesity does not protect against post-dural puncture headaches. BMI has no influence on intensity of headache. What we can do, you can actually use finer needles, especially if you're using USG, you should use finer needles and not 22 gauge or bigger needles, which will increase the chances of PDPH. Peripheral nerve blocks in these patient population is extremely difficult, as we all know. Now, a word about peripheral nerve stimulator, which we use, which is actually still common in India. We find that no impact of BMI is there on interscalene and supraclavicular nerve block success. It can be easily used in these patients. Axillary brachial block is less successful in obese, requiring additional blocks at elbow. And here again, experience plays a role. So you can use peripheral nerve stimulator quite successfully in morbidly obese patients as well. However, with the advent of real-time USG, these blocks are regularly performed using ultrasound guidance. Visualization of superficial peripheral nerves appears to be independent of BMI. However, ease of visualization does result in increased success rate in experienced hands. There is reduced performance time, but when we compare it with non-obese population, more time is required and there is decreased success rate. So real-time USG is now recommended technique for peripheral blockade, especially superficial ones, especially deeper ones. For superficial blocks, actually peripheral nerve stimulator is also found to be good. Now coming on to deeper nerve blocks like sciatic nerve blocks. Imagine giving sciatic nerve block in this patient. There is definitely difficulty in identifying the bony landmarks. So USG is the gold standard. And it is found that for successful sciatic block, as we move distal, better view is achieved. So popliteal approach is quite common in sciatic nerve block. Lumbar plexus block is very difficult to place, as the study suggests. It is located at a depth of 7 to 8 centimeter and even deeper in patients with high BMI and consequently not easily identifiable with ultrasound. Truncal blocks. Now imagine this is your patient. It is extremely difficult to perform truncal blocks in these patients. Very small series or case reports are available on truncal blocks. One such case series report, erector spinae block in the sitting position, and it was found that ultrasound visualization of the transverse process was not clear. Although local anesthetic was administered, producing the facial plane hydrodissection, the catheter could not be introduced. Rectus sheath block is comparatively easier to perform and was successfully performed in a patient with BMI of about 89 to 90 kg per meter square. TAP blocks have conflicting results regarding effectiveness. There is difficulty in identifying the 3 different muscle layers in an obese patient, even with USG. However, laparoscopic guided TAP block is a convenient option and we have been using it regularly in our center with good success. Not much literature is present in obese patients regarding continuous nerve blocks. However, if we are using stimulating catheters, now this ability to electro-stimulate the nerves increases the success rate in catheter placement, and encouraging results have been seen with deep-seated nerve blocks like lumbar plexus block. Now, nowadays, what people recommend is dual guidance, that is using peripheral nerve stimulator along with USG. This is particularly applicable to deep nerve locations such as psoas compartment block or the proximal sciatic nerve block. So for superficial nerve blocks, you can use peripheral nerve stimulators or USG alone. However, the recommended thing is still this dual guidance. But for deep nerve locations, dual guidance is definitely required. Now, this diagram I have borrowed from Nysora. Now, the triangle which we see in the middle is the safest means of performing a block. It is surrounded by ultrasound, nerve stimulation, and injection pressure monitoring. Injection pressure monitoring actually enables us to prevent needle nerve contact, thereby reducing the chances of nerve injury. It is said that the injection pressure should be less than 15 psi. Now, various innovations have been seen in USG, which is aimed at better visualization of needle shaft or needle tip, and it includes laser-assisted needle guide electromagnetic needle navigation or needle tip tracking systems. 3D, 4D ultrasound technology is also available, tissue harmonic imaging, or a curved array low frequency probe, which provides wide field of view and deeper penetration. It improves the recognition of anatomy and improves image quality. Again, use of longer needles are required in morbidly obese patients. Various links are available. Now, I want to discuss few pertinent points of pharmacology of local anesthetics. In morbidly obese patients, there is decreased effect of local anesthetic drug, as can be seen due to increased alpha acid glycoprotein, which reduces the free fraction of local anesthetic, and increased cardiac output of obese individuals, which decreases the fraction of drug distribution to the brain and increases the rate of redistribution. So these two factors actually decrease the effect of local anesthetic drug. While at higher BMIs, perfusion of adipose tissue is also reduced. There is sequestration of drug in adipose tissue, increasing the duration of local anesthetic action. So we have decreased effect of local anesthetic drug while increased duration of action. So how should we go about? The dosing should be done by using ideal body weight, which is recommended for loading as well as maintenance. If you're using lean body weight, it can cause underdosing because ideal body weight actually uses both weight and height. Lean body weight is calculated only on the basis of weight. This is again a bit controversial, but ideal body weight is better measure for the dose of local anesthetic drug. MS Melton have studied the effect of interscaling brachial plexus block on the pulmonary function of obese patients. Now, this is a very important study. What they found is that interscaling block is actually associated with greater FVC and FEV1 reductions secondary to hemidiaphragmatic paresis in obese patients compared to normal weight participants. Now, it has already been found in various studies that the diaphragmatic paresis is almost 100% in patients receiving interscalene brachial block, especially if you are using higher volumes. Now, in this study, they found that lung parameters actually decreased 28% to 40% in obese compared to 21 to 31% in normal weight participants. Despite greater reductions in PFTs, obese participants did not experience increased breathlessness compared to normal weight participants. However, this interscalene block should be used with caution. What you can do is you can use USG for performing the block and give lesser amount of drug as small as 5 ml, or if you are using the peripheral nerve stimulator, the lesser the volume, lesser are the chances of hemidiaphragmatic paresis. Now, Bomberg et al. Found that obesity is an independent risk factor for peripheral but not neuraxial catheter-related infections. Now, what they found is that there is impaired tissue perfusion and wound healing in obese patients, so they are at an increased risk of infections. What are the methods of prevention? Avoid performing blocks in patients with sepsis. There is no evidence to support the routine use of pre-block antibiotics for single shot blocks and little to support the use of pre-insertion antibiotics in the case of continuous nerve blocks. Catheter localization in the groin, removal of the dressing, and omission of post-operative antibiotics is associated with post-operative catheter colonization. So, proper fixation, that is, initial proper fixation, should be done to avoid frequent change of dressing as it increases the risk of colonization. Meticulous use of post-operative antibiotic is again another aspect which should be looked after so as to prevent infection in these patients. Now, what if regional anesthesia fails? The first thing that should be done is anticipate, which can be done by a meticulous pre-anesthetic checkup. In this pre-anesthetic checkup, you will come to know about the comorbidities, whether you will be able to perform regional anesthesia successfully or not. And then you should plan accordingly. Once you have planned that you are going to perform regional anesthesia, execution is required, all the gadgets should be available, and you should always have a person to help you out. Call for help is required in peripheral nerve blockade as well. Now, what I would suggest is do whatever you are comfortable with, what you know, not what you want, because aim is not successful block, but successful patient management. With this, I would end my lecture. A big thank you for patient listening.
Thank you, Dr. Deepti. Very well presented the topic. And I cannot see any questions here. Hello. I just want to ask, what is your experience of using ultrasound for spinal or epidural in these obese patients? Am I audible, Dr. Deepti? Hello. Hello.
Yes, ma'am.
Hello.
Hello.
Hello. Am I
Ma'am,
audible,
Dr.
Dr.
Namrata
Deepti?
Biswas will not be presenting their talk, ma'am. So we can start the discussion.
Hello. Dr. Deepti, am I audible?
Ma'am, I think we can start the discussion with Dr. Anshu Gupta and Dr. Parna Sinha, ma'am. Hello, Chairperson. Am I audible? Dr. Praveen, Dr. Kamakshi, Dr. Veena.
Hello, Dr. Praveen here.
Sir, I think we can.
Hello, am I audible?
Anshu Gupta and Dr. Aparna Sinha.
Hello. Hello.
Hello.
Some network issue is here.
Ma'am, you are audible.
Hello. Dr. Dipti, you have presented very well, but I just want to know what is your
Ma'am, I am
experience
Dr.
of
Anshu.
using.
Ma'am, I am Dr. Anshu here. And Deepti, ma'am, I cannot hear, but you are
I
audible.
think she has left. Okay, then. Hello, Dr. Anshu.
Yes, ma'am.
I think you presented on the airway
Yes.
challenges in obese patients.
Yes, ma'am.
Yes. I just want to know what is your choice of video laryngoscope in obese patients? What is, as per your experience, what is your choice of video laryngoscope? Because we have a lot of.
Ma'am, we use
Yeah.
CMAC. Ma'am, CMAC we are using, which ma'am does not require any stilate or which does not require any. I mean, I think it is available with us and it gives a very clear view. So we are using CMAC.
Any special blades, D type
Ma'am,
or whatever?
Ma'am, D blade is required many times. And
you don't have any experience of using McGrath for obese
ma'am, even
patients?
McGrath we have used, and but we found that sometimes there is a problem with McGrath, but CMAC is always flawless.
Okay. And what about fiber optic intubation?
Ma'am, fiber optic, ma'am, we don't prefer awake fiber optic unless and until there were few cases in which there was apnea on lying down and patient could not even lie with head up without apnea. So in those cases, we have done fiber optic, and ma'am, fiber optic is not that difficult in these patients. Though the airway is a difficult airway, and extubation is more of a problem in these patients who are apneic on lying down. So we use fiber optic in such cases, and even extubation we are performing under fiber optic guidance only, ma'am. Then, or we use a Bailey's maneuver in which we pass the fiber optic through the tube, and later we insert the supraglottic airway. And
any
then
experience of using awake video laryngoscope for intubation?
No, ma'am, we have not used awake video laryngoscope in awake patients. Ma'am, then we perform, we can do that, but we are performing awake fiber optic in such patients.
Okay, thank you, Dr. Anshu. That was very well presented.
Thank
you so much.
Thank you.
Yeah.
Hello. I'm audible? Hello.
Hello, yeah, you're audible.
Okay. So we are moving forward. Welcome back to everyone. Now we start panel discussion. Controversies in anesthesia of obese patient. So I invite to Dr. Archana Jana as a moderator and Dr. Hemant Shinde. Dr. Hemant Shinde, I think not available. Hello, Dr. Hemant Shinde.
I think he's on the way.
Okay, then I request Dr. Archana Jana continue the session.
Panelists, and anyway we are live streaming this discussion, so I really hope it is of importance and adds some value to the people who listen to the discussion that we have already recorded and sent over. So I welcome you all and a very good afternoon to all of you. Good afternoon, everyone. This is Dr. Archana Jana, presenting a scaffolding of a case of bariatric surgery for discussion. Our patient is a 45-year-old male whose height is 180 centimeters, weight is 144 kgs, BMI of 45. He's a known hypertensive for last 3 years on Telma AM 80 once a day. He's diabetic for 6 years on Janumet 50 by 500 twice a day. He has a history of OSA and he's a smoker, smoking 6 to 8 cigarettes per day.
He's posted for sleeve gastrectomy.
Hey, so we have a panel here. The panel will introduce each other as the questions go to them. We are going to throw the questions at them and they will pick up the question. Anybody can come in and discuss. We have 30 minutes. We go first. So like this, the panel, all of you have heard this case. So you all are doing a fair number of bariatric, I'm told. And so this guy comes for pre-op assessment. What would you think? When actually should the pre-op assessment should be done and how will you go about it? Anybody can take it.
The preoperative assessment. Hello, everyone.
Yeah,
Dr. Access, I am from Ahmedabad, attached with Sterling Hospital. And any bariatric patients, we come across with a lot of comorbidities. So preoperative assessment for bariatric patients should start with the first visit to the hospital, I think, because the anesthetist must be involved from the beginning, because all these patients have a very high chances of post-operative complications and morbidity as well as mortality. So we can have enough time if we see the patient and morbidity as well as mortality. From we can have assess the patient from we can stabilize them. We can have enough time from explain them. Say like for we can prepare them for eras and a detailed evaluation and explanation of all the procedures to be performed should be done well ahead of the operation.
That's very, very, very true of you, that you want the association of the anesthesiologist right from the beginning. That's a very, very good take-home point, Dr. Desai, you have made. And what else? The whole panel agrees with it, or anyone has a different view about it?
I mean, I think as soon as they decide for surgery, they should meet the anesthetist first, so that this thing can be lined up as to how the whole process is going to be.
True.
He's an OSA, he already knows what kind of studies we want. Do we want to put him on a BiPAP and get him accustomed to it? So the anesthetist should be involved the minute they decide for surgery.
Yeah, right.
There are key things that we want to do.
Finish. Myself, Dr. Veereshan. Obesity imposes so many challenges for anesthetists. So in view of that, we are having so many challenges like accessing the IV and accessing the endotracheal intubation and accessing the position. And sometimes we have difficulty in monitoring also, like minimum basic monitoring like blood pressure monitoring, non-invasive. And sometimes we have a problem in administration of fluids also. And the dose requirements will be very high in loading doses. And sometimes due to position, we may have some problems with nerve injuries. And we may have some difficulty in accessing the regional. So in that view, we should have assessment in overall. And not only that, you should have what is the BMI already madam has concluded, and what is the status and everything. So those things, and in addition to BMI, what are the other difficulties in accessing it? Whatever the points I have told, we have to go in that line for overall assessment of the patient to have a very good intraoperative and at the same time post-operative recovery and post-op to avoid the problems of post-operative to the patient.
In that, for the current patient, we are discussing as a case scenario. First thing, stopping his smoking. Second is starting his incentive spirometry for him. He has OSA, as Sunita rightly said, if he needs a CPAP at night, so that we bring up his atelectasis to some extent when he comes for surgery. Third is controlling his diabetes and hypertension, which he has, assessing his coronary status since he's morbidly obese as well as has diabetes and hypertension and is a smoker for so long. Fourth thing is assessing his airway, predicting difficulty in intubation, ventilation. And the fifth point would be telling the patient if he's going to need post-op ventilation or not, which is very vital to them to know whether I can extubate, at least predicting and saying, this person, you might go on a ventilator. This person, maybe you will be extubated and in your room. So for these reasons, as rightly, in a nutshell, I'm concluding what we have said for pre-op assessment of these patients.
Ma'am,
whether we want to do a doctor.
1 point.
Wait, Archana, let Aparajita speak.
Yeah, please.
Sir, these patients also need psychological counseling because most of them are depressed. due to their look and due to
True,
obesity.
really true. Yeah, yeah.
So psychiatric consultation should be there to follow the instructions post-operatively also. So right from the beginning, both anesthesiologist and psychiatric personnel should get involved in for the process.
True. Any specific investigations anybody
Yes,
would like to
from
do?
the
That,
history,
yeah.
Dr. Hemant, from the history and say set of investigation, we would like to come to know whether patient is having, because as the patient is already having hypertension and BMI is very high, so it is all chances are there patient might have developed pulmonary hypertension. So we would like to look for left-sided heart failure sign, symptoms, and investigation, and we will rule out right heart failure right before going in for surgery. So that's a relative contraindication to the bariatric surgery also.
Yeah. Anything else? Anything else panel would like to do? Any particular investigations which
I would do an ABG on air for this patient.
Yeah. True. True.
I mean, this will also help you decide how the course of
So-
this thing is, what your CO2 levels are, whether you will extubate, you will put the patient on BiPAP prior to the surgery.
Sumita, any particular values by which you go? Any particular values by which you go when suppose this guy comes with a PCO2 of 70 and PO2 of 50? What would be your
So
management?
then you will put him on a BiPAP pre-operatively and corrected it. He cannot be taken up immediately for surgery. He'll have to be adjusted the BiPAP, get used to it, get his CO2 levels down and his oxygenation higher,
Yeah.
and optimize him to come up for surgery.
So the take-home message for the crowd who's sitting in the auditorium would be that every case surgeon sends to you did not be on the table next week or so. There are times when you have to postpone the case for a month or so to bring down the levels of PCO2, PO2, and the ABG acidosis will disappear, and then we will take the patient on.
I think we will be taking after 6 to 8 hours.
We need to correct it.
We
So
can
just
postpone the case for 8 to 10 weeks.
Yes.
So that how is his SpO2 levels are getting increased and PCO2 levels are decreasing. How is his lung status? And you plan it for some respiratory exercises and other things, so that if there is any small reduction of weight also is possible.
Yeah.
And you can also see his neck circumference and other things also, physical examination. And he roughly, when it comes under super obesity, probably obese and so morbidly obese are almost like above 40. So I think they have there is no, as per pathophysiology, there is increase of fat cells instead of enlargement of the fat cell. So they have a lot of, so size, not only the size, number of cells, fat cells are increased in this patient. So that we should take care. And this helps us to take the administration of the drugs, how much it will be depending on.
We'll come to that, sir. We'll come to that. Those drugs. Right now, we are right now on to pre-op investigation.
Lung function test also we can subject her, especially the tidal volume and FRC. FRC directly we cannot say, but respiratory reserve volume, how is it? And residual volume also we can see.
Anything else besides this, or the panel? Can we move on to the next line of questionings? Archana, you want to go in?
The second controversy always is when this patient is on table, that do I always necessarily need to give higher doses because my patient's weight is high?
Okay, so
what? The patients should receive doses according to their adjusted body weight. If the total body weight of the patient is more than 30% of the ideal body weight, then we should go according to the adjusted body weight. Then the drugs can be divided into two types, like lipophilic and hydrophilic drugs. So the dose adjustments are given according to the type of the drug which we are giving. Most of the muscle relaxants are given according to the ideal body weight, and except scoline, which is given according to the total body weight. Similarly, lipophilic drugs are mostly like benzodiazepines and barbiturates. They are given according to the ideal body weight, and with few exceptions like remifentanil and digoxin.
So by and large, we all follow the same guidelines that we generally don't. I don't think so. We will have any controversy as far as the drug dosing is concerned. But anybody else has any opinion about anything?
Inhalation, I would use DES compared to SIVO because SIVO stays in the fat cells.
Yeah, we
So
all.
I
Yeah,
think by and large everybody uses the same now.
yeah.
And probably in some cases I also start density device.
Local anesthetics, the doses are given according to the ideal body weight, and for the regional block, the dose need to be reduced by around 25% because of the
95%.
movement of the epidural veins and presence of fat in the epidural space.
Opioid or opioid-free anesthesia?
It's opioid-free anesthesia. Should not be.
So we
Regional
have to see the
anesthesia
risk
for
factor assessment.
Multimodal.
Risk factors are there with this obese patient. Assessment of the risk factors is having in addition to his age and is due to this obesity. And we can rule out with the ECG and three or more other risk factors like hypertension, diabetes, other metabolic syndromes. If he is having, we have to rule out by history and by clinical examination before planning for any type of anesthetic management in this patient. Is he can go undergo stress test, or is there any history, previous history of any cardiac catheterization, his smoking history, and in person we have to evaluate and we have to take his personal history. What are his habits? How he goes for if he gets any breathless on small exercise, little exercise. What is his tolerance? Cardiorespiratory reserve also.
Stress tolerance. Yeah, yeah.
Many times we have to do a dobutamine stress test for morbidly
EST,
obese
yeah.
patients because you cannot do a conventional stress test for these patients to find out their reserves actually. And these days we are doing anesthesia with opioids because we have shorter acting opioids. You have ramifentanil, you have a fentanyl. Even a sleeve lasts for more than 2.5 hours considering position from the time you give an induction dose of fentanyl also. So you can safely use opioids in these patients. Regional, since it's a laparoscopic sleeve gastrectomy, we avoid giving because technically it is difficult and not needed since it's a laparoscopic surgery.
And we have to do polysomnography if it
Sleep
is advanced.
studies, yeah. I said this guy is
because
OSA, so
we have to
yeah.
know any episodes of apnea and hypopnea.
Sir, but he's
index.
established. So he's established OSA, so he must have come to us
I
with.
think it will not add any further information.
Yeah. Is there any snoring history? We can take it from their family relatives. So that by that way we
He's a
can.
known OSA, sir. He's a known OSA. So he'll have snoring, he'll have stop bang more than 6, 8 or whatever.
More than 5.
Plus his studies will be done and he probably will be severely having sleep apnea index and everything would be very high. So now, okay, we've finished his optimization and okay, he has come to the theater. Say 2 months have passed, his ABG has improved, and now he is onto the table for the induction or yeah. So we are going to start this gastrectomy, and you are the anesthesiologist. So now tell me, most of these patients are thought that they will be difficult to intubate, but many a times in the practice we have seen they are not actually difficult to intubate, but they are difficult to ventilate. So what kind of positions you all do? What kind of airway preparations you make? Anybody can take this, anybody.
The first thing is we have to see the patient. How is he? What is the position he is having more difficulty? We have to see, we have to adjust the patient. Patient should be shifted inside the OT with the RAM position and keeping the pads underneath the shoulders and making the both ear lobule and the sternum, the angle should be at the same level. And these things, how is if you put the mask, simple mask, how is you ventilating? What is the saturation? You can see it. Otherwise, you can use some nasopharyngeal airways also. We can use, and we can use even insufflation techniques of oxygen therapy during the pre-oxygenation itself. And where to keep that BP apparatus? Most of them are their arm circumference will be very big.
So we need extra large
pressure monitoring. Blood pressure cuff may not be sufficient. So we can as well apply to the forearm and we can see baseline. And we can also have, because it's very difficult to secure the IV lines in this patient, so that we can go ahead with the first line itself. We can have a under ultrasound guided, we can approach central venous catheterization. So whether it is at the neck level or whether it's a peripherally central venous you can have
And
it.
how many of you are giving RAM position routinely in each and every patient?
All of us.
Hardly given it.
All of us. That is the rule.
Anyone has not given it? Because I know about a few years back I was speaking to Sunita and she said since the time video laryngoscopy has arrived, many of us have stopped giving RAM position.
I have stopped giving it completely after video laryngoscopy. Only thing is, most of these obese patients have a big fat pad at the back.
Yeah.
So I give a nice pillow so that at least the patient is, in line to sleep comfortably.
No, but then putting the patient in RAM position just before general anesthesia will help relieving, say, breathing. So patient's breathing will
Sir,
be
FRC
fine,
can be
comfortable.
improved.
Patient feels comfortable, and that is the time when patient will help us pre-oxygenate well, because these patients require pre-oxygenation for 5 to 8 minutes, probably with CPAP, continuous CPAP of 10 centimeter of water. So all these pre-oxygenation and preparation needs patients in very comfortable position.
Yeah, I'm
Taking RAM
comfortable with
position,
RAM, but I knew about Sunita not giving it. That's why I
but then
purposely.
apart from video, apart from say laryngoscopy, mass ventilation, and even for the extubation, we prefer to put the patient in
back in
RAM position. Yeah.
So the take-home message would be like Sunita does it what she feels comfortable is, but by and large most of us are giving RAM position, and you should continuously keep doing it.
Because that keeps the all three axes aligned. Absolutely. And the best chance for mass ventilation and video so visualization of larynx.
Actually, sir, putting a pillow beneath the shoulder and giving a head up also helps in the health.
That's what I do. I don't ramp them.
I do the same.
Pillow and a slight head up.
Then give a head up so that the tummy falls away. I can ventilate better and I can intubate better, and they're not uncomfortable with so many pillows beneath them.
And now with the video laryngoscopy, you don't need the axis in the same line because you're going to use the video laryngoscope anyway. I stopped using direct laryngoscopy since the video laryngoscopy.
That was my next question. How many of you are directly going on to the video laryngoscope, and that too with the D blade directly without even attempting the normal?
I do that for all patients now. I've stopped. I use the D blade for all patients.
I don't use D blade. I use blade number 3 for my female patients and 4 for my male patients, and D blade only if I cannot visualize with 3 and 4, because with D many times visualization is easy, but intubating axis becomes difficult because the camera angle is difficult with D as compared to 3 and 4 routine video laryngoscope blades. So even if visibility is there, the maneuvering is a little difficult as compared to 3 and 4. So if I can't see with 3 and 4, I go to D.
Okay, Pallavi, what do you do?
For all right from the beginning, so I'm very comfortable with the D blade.
I'm very comfortable. Pallavi, what's yours?
So we use D blade if we anticipate difficult airway, if neck circumferences.
No, directly without attempting even the normal laryngoscope, directly you will go on to D blade or not?
According to the criteria, if the patient anticipated difficult airway, we don't take chances.
Okay.
First attempt should be the best attempt. So we directly go with the video laryngoscopy.
And now with COVID times, I think everybody needs to move on to video laryngoscopy completely and take away direct laryngoscopy.
Yeah. So now with this guy in the mind, I know most of us will go for video laryngoscope, D blade, or whatever you're. Besides that, what is your plan? Suppose it fails. What are you going to keep your plan? B, C, D, E, or whatever.
Fiber optic bronchoscopy. Fiber optic.
We have to keep
before fiber optic, we need
plan
to oxygenate the patient. Until that time, I think supraglottic devices can help us.
Okay.
Ventilate the
I would
patient.
suggest more than a fiber optic, a supraglottic device to ventilate the patient.
Okay.
And again, it all depends on what you have given. You have used choline or you have used long acting.
So what do you use?
I use choline for all these anticipated difficulties.
Panel, entire panel, same?
Yes.
Yeah, most of the times we are
fine.
Go ahead,
because we are. It's almost 15 minutes over. That's why.
No, I have burnt my fingers. I've had to take out the patient after a second. I mean, that time video laryngoscopy wasn't there. I did my second attempt. I said, okay, we postpone. We do it tomorrow morning and regroup and do it. I'll call for help.
Okay.
Yeah.
I didn't awake for the patient next day morning. So I prefer choline. So you can at least rescue yourself and get out of the situation.
Very true. And what else? Otherwise, you'll keep. You have any Fujis, wands, and anything. You have it in the OT.
Everything.
Yes.
There's a whole difficult area. trolley.
difficult airway cart which you should keep ready.
Yeah, it
And
should
one
be
more
always
senior
ready.
anesthetist by the side of you to help you.
And who generally helps you in the intubation? Any other anesthesiology colleague or resident, or you are alone in the OT?
Especially
Usually
for
we
the
have
morbidly
residents.
obese patient, and we prefer to say have two anesthetists together. It is always safe for the patient because
Yes.
Private practice
yeah,
too.
So I'm
frequently you
purposely
come across
asking you
the
this
condition.
question. Yes, my line of question is because I want the take-home message that if you have a colleague who is anesthetist, who is well versed with doing these cases, please call him for these cases. Archana, you want to ask the next line? How do you ventilate these guys? What is your choice? Volume control, pressure control, anything else?
Yeah, it is always better to have a pressure control ventilation with volume guaranteed mode if it is available with your ventilation.
Yeah, if this mode is there, but a lot of us don't have the mode in all machines.
Yeah.
Yes.
Then
Sir,
you
volume control
volume
mode can
cycle-
also be used.
yeah. Then you play between volume and pressure, how the patient is settling.
Yes, yes.
You
Depending on your plateau pressure.
Generally, we've seen the resistances going up. So any kind of play you would suggest to the crowd who are doing these cases as they're new in this thing?
We can go do recruitment.
We have to do monitoring like ETO2 and
Recruitment.
ETCO2. Depending on that, we can take bag manually, and in between for 5 to 6 seconds or 7 seconds we can give with increased about 40 to 40 airway pressures we can ventilate so that the collapsed alveoli may get recruited. In between for every 3 to 5 minutes we can go for 5 to 6 seconds. In between we can go, and again we can go for pressure control. So most of the time we
can
have
do
to
a
keep the
volume
airway pressure.
control.
Can
Volume
you-
control with PEEP is always possible in majority of
PEEP
the
is also.
ventilators. So you can do
PEEP of
PEEP is
10
a
to
must
15
in
can be
between
given.
also. PEEP is
The
a must
problem
even in
arises
controlled
mainly
ventilation.
is once they inflate the stomach.
Yeah,
Once they inflate the stomach, hell breaks loose to the peak airway pressures.
true.
Because your lung, you are trying to ventilate from up, they are pushing from
They are
down.
trying to.
Higher pressures for the abdomen because he's bigger. That's
So
when
only
you start playing
savior
with your modes.
The savior is the head up position.
Yes,
No,
sir, but
besides
that's
that,
playing with the ventilation strategies then, like.
yeah. So
We can keep Riles tube is also
give-
already there. No, we have to keep Riles tube in the stomach. Whatever it is there, the gas.
You don't, madam, it's a sleeve gastrectomy. You
so
don't
this
put a
is
right.
sleeve. So we know we won't have a,
Gastrectomy we don't, but other surgeries we can plan it. Yeah,
So
yeah.
we put a
You are
gastric
right.
calibration tube directly.
Yeah.
So that's so much better.
even you can do the eye ratio changes. You can.
Sir, low tidal volume 6 to 8 ml per kg.
So what sort of tidal volumes you're going to keep for this guy?
Sir, a low tidal volume of 6 to 8 ml per kg of idle body weight can be given.
Excellent.
I prefer to keep a high FiO2, 40 to 80% FiO2.
Okay.
Our ETCO2 target should be 30 to 40, or accordingly we can adjust our ventilation strategy.
Yeah.
And intermittent recruitment of the lung can be done, and SpO2 of more than 94 is enough for this patient. 94, 95 is enough for these patients.
Okay, so we've almost and what else? Otherwise, anything else do you think of? Any ventilation strategies, PCV, VG, or anything? Any modes are available? You'll go for that. Oh, what has anybody used it?
Yes, we are using it routinely.
So, what's your routine experience with that? Are you very comfortable with it?
Yes. Because see, our goal is to keep the peak pressure below 30 centimeter of water.
Correct.
And SpO2 targets are more than 90%, and 6 to 8 ml per kg of adjusted body weight, and PCV VG mode, and the rate is adjusted according to the capnography. So this is what is the routine strategies, and after induction and putting the tube in, we routinely see the hemodynamics of the patient, and after giving the position, if the blood pressure permits, we do recruitment maneuver. And even before extubation, we do the recruitment maneuver, and after that we keep the PEEP of 10 if it is allowable.
Fair enough.
And the recruitment really helps to at extubation. Open
Yeah.
up the alveoli and they stay well.
Yes.
So now that you have come almost up to the extubation, how are you going to extubate this guy?
Again, will depend on how the patient has behaved throughout.
Yeah.
Type of
Patient has behaved pretty well. Patient has been stable all throughout. You've managed him beautifully.
So if it's a very difficult intubation and I had struggled for the intubation, then I might do an exchange with an LMA and keep him on it.
Yes.
If I haven't struggled, it's been an easier intubation, it's not been bad, and he's behaved well, I probably would give him a trial to extubate directly. So that we'll have to again play in the end and see how big he is, whether to exchange it with the Bailey's maneuver that you do you exchange it with the LMA and let
Do you do it routinely, Sunita? Do you do it routinely?
I used to do it routinely at one point till I became better at obesity, video laryngoscopes. Then I did it only for specific patients who I thought would give me trouble. Big jaws would give me trouble. I have exchanged it for the LMA and they've gotten up beautifully, taken it out and given it to me. And you move them onto the BiPAP device.
How many times you've had to go to ICU to extubate these guys?
I can count on my fingers and tell you there are 4 or 5 patients.
Okay.
Who I have put them elective ventilation. 2-3 hours later, I've woken them up because they were very big. Their pressures were too high in the chest.
Yeah.
So I have given them elective ventilation for a couple of hours.
Ashish bhai, what is your take on this? Do you ventilate them in the post-operative period?
Yes. Extubation decision depends on the preoperative and intraoperative behavior of the patient. Preoperative predictors here are if induction is smooth, intubation is not without any event, then we can take a decision of extubation on table, and we routinely keep the patient on pressure support ventilation once the spontaneous respiration comes. And once we are assured of the reversal of the muscle relaxation, and then we keep the patient and monitor the CO2, and then we can take a call. If we find higher CO2 levels, even after ventilating for say 20 to 30 minutes, we'll better extubate them into HDU rather than extubating on table.
How many of you use nasal airway when you extubate? I love using nasal airways.
I use it also, madam.
I would like
to really
so it is a very good tool.
With the obstructive component, the nasal airway really helps.
Yes. Because the pharyngeal muscle tone is not adequate just after the extubation, and there are all chances that patient may have a tongue fall, and you might encounter difficulty in mask ventilation and oxygenate the patient after the extubation immediately. So it is always better. We practice it in all the patients.
Are you using nitrous oxide in all these cases?
I use.
We avoid nitrous oxide.
No, we don't use.
We don't use nitrous oxide because it
Panel is divided on this.
risk of
I use it.
bloating of the intestines. So we don't use.
A lot of surgeons also don't like it, especially in gastric bypass. Probably sleeve you'll get away with it, but not in a gastric bypass. And so about DES and CO, both are available on your trolley, preferably DES.
Preferably DES, sir.
Because of the good recovery profile.
You need everything that will wash away from the patient.
Oh,
right.
Another thing I wanted to ask is, if this patient needs ventilation post-operatively, what all do you prefer? Do you prefer to keep the tube inside or put a BiPAP after sleeve gastrectomy?
Ma'am, should we put on a BiPAP after?
I don't at least, because I'm always worried about that stomach line which they have done. When I put a BiPAP, which causes aerophagia to a great extent.
Madam,
so I avoid.
If he needs the BiPAP, he needs the BiPAP. You have to keep him on the BiPAP then.
Or you can't
Preoperatively, we should tell the patient, we should counsel the patient that the patient may need a BiPAP, and preoperatively also we can use BiPAP.
Breathe with it preoperatively.
It's not a question of patient tolerating or being comfortable with a BiPAP. It is a question of having a sleeve done where there is a suture line. Majority of the surgeons don't even suture the suture line. They just put the staples and they get out of it.
Madam, how many leaks have you seen with the BiPAP and a sleeve?
I haven't put any of my patients on BiPAP post-operatively.
Whoever is on a BiPAP preoperatively,
what is BiPAP? I would love to know.
And no patient
my surgeon doesn't like it. My surgeon doesn't allow me to do it. So that's why I'm asking.
No, fair enough. If your surgeon is not happy about it,
I'm happy with it.
Most of these patients, when they are on BiPAP preoperatively, they will better tolerate BiPAP postoperatively. See, if the patient is not having taken BiPAP preoperatively, and you are putting the patient on BiPAP just after
then only they will have
extubation,
problem.
Yeah, then only they
then
will
there is a
swallow more
problem.
air.
Yeah. So then all these issues can occur if patient is not used to with the BiPAP. So in the patient given in a given case, patients this risk score is very high. So if the patient is not taking BiPAP preoperatively, preferably we should start BiPAP at least 1 month before the surgery and make the patient used to with that, so that we cannot encounter these
If
difficulties
required,
in
we can
post-operative
use that.
period. Yeah.
The nitrous oxide is one thing which will you should be very cautious. It can prevent during expired second gas effect. That will have a lot of problem if you are using even nitrous oxide. That's why most of the times when to avoid the expiration problems also we cannot use this nitrous
How
oxide.
many of what is the multimodal analgesia that you all use to give to these patients during and after the surgery?
So we almost extubated him. So now we are worried about post-op analgesia. So what sort of post-op analgesia would the panel would like? Yeah.
Paracetamol, and if in this case, since it is a laparoscopic surgery, then we can give port site infiltration,
local anesthesia,
and local anesthesia.
Anybody
and any block, tab block,
blocks and all those
block.
you are trying?
Yeah, tab
but
blocks
you-
we give for most of these guys and they do very well.
Yeah.
Long needles are required.
The
Longer
renal
needles.
profile is good. I also give NSAIDs.
Yeah.
So that helps that immediately. That first day is the only day that pains him.
Yeah.
The second day
they are comfortable.
How many of you are using dexmedetomidine in the right?
Yes.
Yeah, using it routinely.
We
are
use.
using it
routine.
unless there is a
use a lot of
contraction.
dexmedetomidine.
Yeah, so that is another take home I wanted to, because it brings down the requirement and these guys come on. We're
But
almost out of
analgesia,
time. We are
but-
actually out of time.
So there's one point I would like to emphasize, that is about the PONV prophylaxis. Since has undergone a sleeve gastrectomy, there's a lot of stomach happening, and these patients do have a lot of PONV in the postoperative period. So we need to go for a combination of various drugs available with us, along with, if in case scopolamine patch is available, we can go for that along with ondansetron and perinorm.
Anybody using sub-anesthetic doses of ketamine to give right to these people? Because I have
Dexmedetomidine, I have not used ketamine actually.
Yeah, because
Ketamine
many
is,
of
I
these,
wouldn't use it also.
no,
But
sub-anesthetic is only about 20-25 micrograms. I have heard Indore guys routinely give it. They do it
I wouldn't like to give ketamine or anything which causes
nemesis and
obese guy.
I think we at our center we are using say dexmedetomidine preoperatively, and if needed intraoperative also, and local infiltration at the site of ports, and we do well with say 8-hourly paracetamol and other NSAIDs.
So you have new patches available now. New patch, which is a Dynapar patch of 200. It is available and lasts for 24 hours, which is also good enough. You put it at the beginning of surgery. It takes over in 3 to 4 hours. By
Madam,
the time
also a lot of people of these have a renal profile deranged.
So you got to be a bit careful.
if they have, then anyway you won't be using it.
Yeah,
Not
so
all
that's
of
what
them.
I'm very skeptical about using. Because all of them are creates are on the borderlines with these guys. So only if they are bang normal, then I'll use.
If they're bang normal, then you can use.
Yeah.
I think
Is there any-
we have finished at 30 minutes. So
Is there any role of daycare surgery in the sleeve gastrectomy?
that you all only have
No,
to
sir.
just
I won't give.
It's not.
because he's already flashing me the message that our time is up. So I think let's thank each other for the great,
One more thing I would like to say here is using say DVT prophylaxis in all these.
About to say that.
It's must.
It's
Must,
a must.
must.
Intra-op use of compression, sequential compression device
Yes.
intraoperatively is a must because they are in lithotomy
Low
position.
molecular weight.
And they are
Preoperatively.
intraoperatively also.
Yeah.
And how do you do
for DVT
the,
prophylaxis should be given one day prior also. Started.
right.
Most of
We
the surgeons, they start
started a
one
day
day prior.
before.
Day before.
Yes,
Okay.
surgery.
Till the time
And
they move.
Till that,
and Dr. Hemant,
till that time
how
they
long do
become
you
ambulatory.
continue this
Till the
program?
time, see,
The
most of
time
the
they are
times,
mobile and they are
till the
discharged.
time. But most of the
Till the time
surgeons
they
are
are-
making these patients mobile on the same day, so it's only
Right.
the one day previous.
One day prior.
Yeah.
Right.
I think we should thank each other because 30 minutes are over and we have almost extubated the patient. So I think we are
Right.
good. Yeah. So thank you very much. All
Thank
of
you. Thank you,
Thank
sir.
you.
Sir,
Thank you very much.
Thank you very
you
much.
made bariatric anesthesia so easy. Simple.
It was not so easy. It is made because of the 30
Finished
minutes.
in
Theory,
half an
theory
hour.
has become very easy. Theory. Not
Okay.
that.
So
And as I am from Ahmedabad, I welcome you all to the conference and looking forward to you all in person.
I'll be there in person for this thing. We'll be in the hall and
Right.
Yeah.
Right.
I also
Sir,
will be there.
Welcome.
Thank you. Thank you, everybody.
Thank you very
so much,
very much.
Thank you, one and
Thank you,
all.
sir.
Hello, everyone. Important and interesting announcement. We have virtual program of song, instrumental and original languages. We have participants from all over India. There are selected contents by respected judges and with high repute. At the venue Rega Hall J, time 5 to 6:30 p.m. Today only. Enjoy. At the end, we will give you awards. Do attend and realize.
Hello. Thank you very much.
Now we start next session. The topic is technology for anesthesiologist. I would like to invite Dr. Nandan Upadhyay, Dr. Milind Paul, and Dr. J.K. Sinha. Welcome, sir. Dr. Nandan Upadhyay, are you there?
Yes, sir. Myself is there.
Dr. Nandan Upadhyay, are you there?
Yes, yes.
Yes, I'm there.
Dr. Milind Paul, are you there?
Yeah, I'm there.
Okay. Introduce speakers and continue these sessions.
So I'd like to invite my dear friend Dr. Tushar Choksi, the speaker for this session, first speaker for this session. Actually, everybody knows him because he has made all the infographics about all drugs. And being private practitioner, he is very well known for his TIVA, and he's also very well known for his artificial intelligence lectures. He's a versatile personality, and he's attached to Sterling Hospital, Uto Care Hospital, Dhanvantari ENT Hospital, Baroda Hospital as visiting consultants. And he's a visiting faculty at Parul, Vadodara and Savita, Chennai. So I invite our first speaker, Dr. Tushar Choksi. So Dr. Tushar, you can start.
Good evening, friends. Today's my topic is artificial intelligence in anesthesia, current trends and future prospectus. My lecture outline will be audience poll, introduction and definition, history and evolution of AI, stages and types of AI, how AI works and uses of AI, history of AI in healthcare, history of AI in anesthesia, current status of AI in anesthesiology, future of AI, will AI replace anesthesiologists, journal articles from AI in anesthesia, conclusion, take home message, my verdict, cartoon and thanks. there are certain questions I want to ask you. Do you know you are already using AI in your practice? How will AI affect or change clinical decision making in anesthesiology? Will AI reduce errors in anesthesia practice? Will you accept AI in anesthesia practice in future, or will AI replace anesthesiologists? Yes or no? So, which medical technology and digital health innovation can expect the brightest future in the next decade of anesthesiology? And from these technologies, 10 technologies, artificial intelligence is the king in this all the masters technology, and they will rule the next decade of the anesthesiology. So what is the artificial intelligence? Artificial intelligence is the capability of the computers to respond in a manner resembling human intelligence. My dictionary definition is artificial intelligence is the development of computer systems that are capable of performing tasks that normally require human intelligence, such as decision making, object detection, solving complex problems, and so on. And if you see that all the technologies are using artificial intelligence which are available in this world, and AI is like electricity. Without electricity, we are not thinking today's world like that. Without AI, we cannot think of this world in future also. And these two people, Marvin Minsky and John McCarthy, they have given the artificial intelligence definitions and name in 1956, and they are called as the fathers of the AI. What are the aim of AI? Mostly there are four aims of the AI. That first is decision making, solve the complex problems, increase the accuracy of the brain on computer, and perform the high level of computation. So it is an approach to make computer, robot, or products to think how smart human think, to study how human brain thinks, learns, decides, works, and when it tries to solve problems, and to improve computer function which are related to human knowledge, for example reasoning, learning, and problem solving. And ultimately goal of this is a technological singularity, the point at which technology overtakes the human. There are some terminology came in artificial intelligence. That is, first is artificial intelligence, in that you know that machine thinks without any human intervention. Second terminology came is machine learning by Arthur Samuel in 1959, and here it provides the statistical tools to explore data. So here machine learns automatically from past data without any confusion or any program. Then came a deep learning. It's a subset of the machine learning only by Russian scientist, and here human brain thinking, also called deep neural network or deep neural learning by the computer, is there. And all these three things came together and it forms a one of the specialty, and that is called a data science. It is a multidisciplinary field that uses scientific methods, process, algorithms, and system to extract knowledge, and it applies all mathematical rule. Believe me, this data science will rule all over the world in next decade. So these are the basic structures of complete artificial intelligence. So evolution of AI started with the AI, ML, DL, and data science. In 2030, we will see that from every aspect of the subjects will have artificial intelligence in their heart. So if you go to the history of AI, then even 380 various mathematicians, theologians, philosophers, professors, and authors used about mechanical techniques and calculating machines and humans. And from 1900, the people took the robot idea, and first robot was built in Japan in 1929. In 1950, the John McCarthy gave the official birth of the world AI. Then in 1960, the first industrial robot was developed to work on a General Motors assembly. In 1970s, robot, the first anthropomorphic robot was built by Japan Waseda University, and it features included movable limbs, ability to see, and ability to converse. In 1980, Mercedes-Benz built a driverless car, driverless van. And in 1990, Deep Blue, a chess playing computer developed by IBM, and it became the first system to win the chess game against a human. Then in 2000 to 2010, AI conducted its trending, like they have developed Kismet, and Honda released the Asimo robots. That is the artificial intelligent humanoid robot. So from 2010 to present day, the AI has developed tremendously. In 2010, Microsoft launched a Kinect for the Xbox. Then in 2011, Apple released a Siri. In 2014, Microsoft released a Cortana. Then again in 2014, Amazon created Amazon Alexa. That is a home assistant that developed into smart speakers. In 2015, Elon Musk, which is the richest, second richest person in the world, who has developed the autonomous weapons and car even. In 2015 to 2017, DeepMind AlphaGo developed by the Google is a computer program and it defeated the various human champions. In 2016, Google released Google Home, the smart speaker that uses AI to act as a personal assistant. In 2017, Facebook Artificial Intelligence Personal Lab introduced chatbots to communicate with one another, and we are the witness of all people with the Facebook platform. In 2018, Samsung introduced the Bixby, which is a virtual assistant in all smartphones. These are the landmark years in the history of the AI: 1950, 55, 74, 80, and 2000. And 2011, the landmark year of the artificial intelligence in the anesthesia. Since last decade, the anesthesia has developed tremendous changes in their subject. What to expect for AI in 2020 and beyond? First is natural language processing. Second is machine learning and automated machine learning. Third is autonomous vehicle and chatbots plus virtual assistant. These all four things will together, they will rule over the world in their all the aspects. There are some stages of AI. Artificial narrow intelligence, that is a weak AI. Machine has narrow defined role of work like Siri, Alexa, Sophia, self-driven car. Then there is a artificial general intelligence, that is a strong AI. Machine starts thinking just like humans, yet to create and developing all over the world. Artificial super intelligence, that is a super strong AI. Computers or machines will surpass human beings. It is not exist, only seen in science and fiction movie. And there are four types of artificial intelligence. That is a reactive machine AI, limited memory AI, theory of mind AI, and self-awareness AI. In reactive machine AI, it works on the preset data. In limited memory AI, it works on the past data. In theory of mind AI, it works on the emotional data. And self-awareness AI, it involves a machine that have human level consciousness, and pray to God it will not exist, because it is the ultimate example of the artificial intelligence in our day-to-day life. So there are some domains of AI, how it works, just like from artificial intelligence to machine learning, to deep learning, to robotics, to expert system, then physiologic and natural processing, natural language processing. And this is the way artificial intelligence whole cycle completes. So uses of AI in all the way, you name the thing, you name the subject, they will work as with the use of AI, like construction, metal industries, aeronautics, automobile, roads, highways, robotics, factories, windmill, solar energy, electricity, smartphone, computer, medicine, air condition. Everybody is using artificial intelligence in their subject. So now we'll come to artificial intelligence in our healthcare. There are some historical aspect of artificial intelligence in healthcare. In 1960s to 70, first problem solving like dental software came in the market, and most significantly, it's the early use of the artificial intelligence. In 1980 to 19 brought the proliferation of the microcomputer and no new level of network connectivity and applied to intelligent computing system in healthcare. And in 1990, AI program have developed and applied to each and every aspect of the diagnosis process, treatment protocol, personalized medicines, and patient monitoring with care. And in 2010, the role of anesthesia started in AI. AI started in anesthesia. Then various specialty in medicine have shown an increase in the research like radiology, imaging, telehealth, electronic health records, robotic surgery. And in 2019, we are witnessing 800 uses of AI, like assessing breast cancer risk from the histopathological imagery, guiding antivenom selection from snake images, and diagnosing skin lesions. So AI is used in healthcare in drug development, disease diagnostic, analysis of health plans, health monitoring, digital consultation, surgical treatment, managing medical data, personalized treatment, and medical treatment. So this is the way all the part of the surgical or medical or specialty wise we are using artificial intelligence in healthcare. But there are some pros and cons. What are the pros? There are through AI there are better data driven decision. It increases disease diagnosis efficiency. It treatment time cut in half. Integration of information, up to date information. It reduces unnecessary hospital visit. It create time saving administrative duties. But there are certain cons also. Concerns regarding privacy and security, lack of curated healthcare data, high initial capital investment, lack of interoperability, reluctant from staff to embrace AI and potential for increased unemployment. This is the biggest problem, unemployment. Now come to artificial intelligence and anesthesiology. History of AI starts like historical development. Anesthesia was the earliest subject to implement artificial intelligence, and anesthesiology was the first established the concept of pharmacokinetic pharmacodynamics clinical PKPD model, and they were developed a pharmacological robots through AI. In 1980, servo anesthesia theory started, and which was the embryonic form of the automated anesthesia and robotic anesthesia. In 1990, TCI machine was developed and it applied into clinical practice. And with the gradual improvement of the anesthesia monitoring, especially anesthesia depth EEG monitoring system, the open loop and closed loop anesthesia automatic system established. And in recent years, in 2010 to 2020, anesthetic robots, technological robots, diagnostic robots develop rapidly. Since 2011, AI is anesthesiology is developing tremendously. Like, what is the current status of AI in anesthesiology? 2011 to 2020, anesthesia robots are developed. There are two types, manual robots and pharmacological robots. Manual robots includes the catheter intubation system that designed to utilize the video laryngoscopy and robotic arm to place an endotracheal tube. The use of the Da Vinci surgical robot to perform regional anesthesia block. Then they would develop the Magellan robot to perform peripheral nerve blocks. Then again they develop the Max Sleepy robots that gives the intravenous sedation machines designed to administer propofol narcotic muscle relaxation, that is the auto anesthesia. And lastly, in Canada, the eye control RP machine was developed like for the closed loop system, and which makes the own decision regarding the IV administration of remifentanil and propofol with the parameters of the patients and surgeons. So currently, AI involved in all anesthetizing patient who requires like preoperative assessment of all past medical problems from the history, physical examination, laboratory evaluation, mask ventilation of unconscious patient, the diagnosis and treatment of any complications during or following the anesthetic, observation of all vital monitors during surgery, removal of the ET tube or even placement of the ET tube. And from 2020 onwards, anesthesia practice with AI will be like that. AI in pre-anesthesia checkup. Like Google Translate will be very useful in PSC. We will talk in the patient's language, and we can ask, like, suppose if I get a patient from the Tamilian region, then if I talk in English, then my talk will be converted into the English text, that will convert into Tamil text, and then convert into Tamil speech. So communication with patients through AI in their language will be routine and already established. In operation theater also, future anesthesiologists will command all gadgets and lights in OT by AI, which will be connected with the different AI system. Like example, if you give order to Google that increase the height of the OT light, then by voice command only the light height of that OT table will be adjusted according to surgeons and surgical field. Like if you give Alexa or Siri that brighten the adjust the OT headlight or increase the AC cooling to 20 degree, so they will do that job by AI. And in our future anesthesia workstation will be also operated by AI with just voice command with data entry. Our monitor will be controlled and self-checked by AI. Even switch on and switch off anesthesia will become a reality through AI in future. So some AI enabler and functions are already in some OT machines and monitors that we are witnessing day-to-day life. AI in tele-anesthesia. With AI, you will be virtually present with the patients and colleagues anesthesiologists to guide them in their perioperative period in all procedures. You can give anesthesia from the distant part of the OT. Even you can control all OT gadgets with your smartphone AI apps. Tele-anesthesia is not a new concept, but combined with AI, it is a very useful for teaching CMEs and conference. Like I am giving a webinar talk just now. And with combined augmented reality and AI will be change the concept of tele-anesthesia, and you will be giving virtual anesthesia to distant OT patient. And it is a reality like tele-anesthesia from Canada to Italy given by Dr. Hammerling and colleagues from the Montreal hospitals. In 2025 onwards, we will witness like smartphone anesthesia practice, tele-anesthesia in any part of the world, artificial intelligence and augmented reality, anesthesia, robotic anesthesia, nanomedicine in anesthesia, genetically targeted and medicines, that is genome anesthesia, auto anesthesia or auto TIVA. This will be a reality in 2025 and we are going to witness that part. So these are the algorithm for the AI healthcare model in future. It will be worked by only artificial intelligence on augmented reality. So if you see that like pediatric anesthesiology, neuro anesthesia, AI anesthesiology will be a subspecialty of the anesthesia. Here, anesthesiologist needs a good mix of the cognitive and dexterity based labor. So AI will primarily result in the automation of the cognitive work. It may be that our hands prevents full automation of the specialty. So you need not to worry about that. Robots comes in the anesthesia assistant, or anesthesia will be taken by robots, or artificial intelligence will be taken by the anesthesia. But our this cognitive work will be taken by, but our dexterity work will not be taken by this artificial intelligence. So AI-based automation system gains further capability, and they may be able to perform semi-autonomous anesthesia maintenance, where the AI-enabled machine takes over specified domains of the anesthesia maintenance. Anesthesia might never be fully automated because it involves dexterity based labor, I told you, and current robotic devices don't have exact dexterity required for tasks. However, AI could be used in anesthesia to develop more advanced clinical decision. So a renewed emphasis on the doctor-patient relationship will be developed by AI. So my question is, will AI reduce errors in anesthesiology? Yes, safety versus complexity. Human dexterity works will not be replaced by the AI anesthesia or robotic anesthesia. But AI can control the gadgets, monitors, but anesthesiologists will require all the times to do dexterity work, like to fill the syringes, to put chest electrodes, or to take clinical decision in odd situations. So AI will catch the stupid mistakes in our practice and optimize the patient care. But at the same time, AI will introduce new errors that human would never make. Will AI replace the anesthesiologist? It's $1 million question. There are clearly cognitive tasks that AI will eventually assume. AI is not able to deal with the many areas of decision. Like when the patient's well-being is deteriorated, the all surgeons wants an anesthesiologist to talk with them, and talking to robot or machine isn't the same as addressing the guy who has been doing anesthesia for your patients for a long time. So I don't think that AI will replace anesthesiologist anytime. We should start actively using and testing AI that is available in order to experience it and learn to incorporate in our practice. AI today will help anesthesiologists to skip the boring stuffs and hopefully make them more focused and smarter. So, however, in the future, we might see particular role being replaced. The first people to go will likely be those roles that are very task-based and lack creativity. The future of artificial intelligence in anesthesia is unpredictable. But you see, there is a 5 years from now, we might see the amazing game-changing invention as well as continuous steady progress towards more intelligent self-thinking monitors, anesthesia machine, and TCI pump. There is again super specialties coming in the anesthesia through artificial intelligence, that is called the intelligence control in anesthesia. It is nothing but it's automatic control and artificial intelligence in anesthesia. Like our closed loop system with anesthesia depth monitor is a good example of this intelligence control in anesthesia, which we are calling auto anesthesia, and it is widely applicable even today also. This is the blueprint of this intelligence control. And this is closed loop anesthesia. Here the input is drugs and output is monitor. And here the machine will decide through AI which drugs will be given to the body, and it determines the right drug with the right dose with the right time by artificial intelligence, which will be taken by this monitors data. There are some journal articles which I have gathered. The PubMed research I gone through, and more than 1,000 articles in journals are written about the artificial intelligence and anesthesiologists. But the best article I have found is Artificial Intelligence and Anesthesiology, Current Techniques, Clinical Applications and Limitation, and 6 themes they have described. That is the depth of anesthesia monitoring, control of anesthesia, event and risk prediction, ultrasound guidance, and pain management. So if you see, the artificial intelligence has the potential to impact the practice of anesthesiology in all the aspects, ranging from perioperative support to critical care delivery to patients to pain management, like novel artificial intelligence system for endotracheal intubation, machine learning models for to detect the post intubation hypoxia, then machine learning approach for preoperative anesthesia risk prediction, prediction of bispectral index during target control infusion of propofol. And here, if you see that Dr. Hammerling has first in 2012 have done first robotic tracheal intubation in humans using the Kepler intubation system. After that, he has done the first robotic ultrasound guided nerve blocks in human using the McLean system. The same people and same team. Again, after that, they started a MaxLiP automated anesthesia system. That is the first totally automated administration of the anesthesia in May 2008. and he is the father of robotic anesthesia. I consider him is also a father of artificial intelligence in anesthesiology. And he has developed a vision for the future of anesthesia. And from airway control to anesthesia control, like pharmacological robot, closed loop for hypnosis, closed loop for anesthesia, analgesia, anesthesia robots, tele-anesthesia, regional anesthesia procedure, everything will be done by robotic anesthesia through artificial intelligence. So this is the current robotic and artificial intelligence theater what we are facing now. And here this is the typical system, OT, our OT machinery, gadgets and artificial intelligence through which we are passing every day. And anesthesiology and today's time with wires and gadgets. But my vision in 2030, AI will replace this type of complex anesthesia monitoring machine into only one button anesthesia, that is closed loop anesthesia. And they have only one button to control ventilation, hypnosis, nociception, neuromuscular, hemodynamic, temperature, and metabolic control. And there will be only one unit where you have only one button that will be asleep or awake. If you want to give anesthesia, then put the patient on asleep button. If you want to awake that patient, then put the patient on awake button. And in between, if you want to relax, then you take the coffee from the same unit. So in 2030, switch on and switch off anesthesia machine will be a reality. So with AI, hours of boredom, minutes of thrill, seconds of terror will go away, and wisdom anesthesia will be accurate. So in my conclusion, application of artificial intelligence and machine learning have shown promising result in anesthesiology. It is clear that AI will find many applications in anesthesia care in delivering real-time results. The contribution of artificial intelligence to general anesthesia have got advancement in monitors, TCI machines, and closed-loop systems. The field of post-operative pain management and chronic pain also have been benefited by AI. Simulation, thereby improving education in anesthesiology. Much more work is required to understand exactly the scope that AI will play in anesthesia. But in general, AI will certainly continue enhancing the patient experience and anesthesiologist expertise. So my take-home message is artificial intelligence in anesthesia is the use of complex algorithm and software to estimate human cognition. It will never replace anesthesiologists. AI or robot will be a pilot, but we will be always there as a co-pilot. AI will definitely reduce the errors in anesthesia practice. In near future, we will all witness the changes of anesthesia practice with AI. Artificial intelligence in anesthesia uh, put zero complication rate in our practice, which we can't recognize sometimes. Ultimately, you have to accept the artificial intelligence in your practice, which you are already practicing. So my verdict is the potential of artificial intelligence in anesthesiology changing patients' lives beyond recognition is both exciting and challenging. And the anesthesiologist has to accept the use of artificial intelligence in their future practice for learning the art of modern AI-enabled anesthesia machine monitors and gadgets. So we will be in 2030, we will be a robotic anesthesiologist, and this will be a reality. We can give the anesthesia, tele-anesthesia from our home also. Even in future, artificial intelligence will be under litigation sometimes, and we are the assistant to the robot as a anesthesiologist. So finally, we have to accept the robots and AI will be our pilots and teachers in our practice. But AI means artificial intelligence, but I also consider AI means anesthetic intelligence also. Thank you.
Yeah, very informative talk, Dr. Tushar. Now this topic is open for discussion. Any questions?
Price of this, sir.
Hello.
Price of this all devices roughly. Just
What,
is
sir? I
it
couldn't
available in
understand.
India? Sir?
No, not at all.
And price, please. When we,
This is a
what do
this
you
is a
think? When we
future this is a future vision.
but then also, sorry, in world where it is used and what is price?
In my personal practice, I am using tele anesthesia and video anesthesia very much. I had a video assisted laryngoscope, and so many things are doing with our AI apps also. I have a artificial intelligence Android apps also. So in my practice, I am very much comfortable.
Okay.
Any other question? Shall we move to another topic? Thank you, Dr. Tushar, for your very much
Thank you, sir.
informative lecture. Actually, though it is a future of anesthesiologists, I think anesthesiologists should not be replaced by robots because we are the main pillar of surgery. So
That is why
I hope,
that is why I
yeah,
called.
yeah.
That
I
that
hope
is why I
that
called in my lecture that we will be
yeah.
co-pilot for them.
Yes. Thank you
Thank you,
very
sir.
much.
Thank
Thank
you.
you. Bye. So now, please introduce the next speaker, Dr. Upadhyay.
Sir?
Hello.
Yes.
Hi, this is Dr. Pandit Rao. This is my lecture. I have joined by Zoom.
Yes, sir. Yes, Dr. Mrindal Pandit Rao, Professor Head at Department of Anesthesia, Intensive Care. Yes.
Very good evening, sir. Pandit Rao, sir. You can start your lecture, sir.
Respected chairpersons, ladies and gentlemen, warm greetings from historical city of Bathinda, Punjab. At the outset, I would like to thank the organizers for giving me an opportunity to discuss with you a very unusual but on the spot topic, that is anesthesiologist friendly mobile applications. Since its inception, when in 1846, William Thomas Green Morton used first time this apparatus to deliver his lithion, what we know is diethyl ether. Anesthesiology has evolved into a technologically oriented branch of medical sciences. The initial trial and error or hit and run approach got transformed into an exact, precise, and technologically producible methodologies. With the arrival of 21st century, this can be considered as the dawn of technological supremacy, and one such advancement was our good old ring dialing landline phone getting converted into a mobile phone, which further evolved into a smart mobile phone, or simply what we call as the smartphone. By 2007 and 8, there was a very clear-cut bifurcation even in the mobile technology. Apple Industries introduced iPhone technology, and players like Nokia, Samsung introduced Android technology. And these two became the two independent pillars of mobile phone technology. And these are the symbols of these two different technologies, iOS and Android. Currently, the smartphone has evolved into an absolutely essential, all-encompassing gadget and a compulsory accompaniment of the tech-savvy millennial generation. Device of easy communicability, which was its actually introduction, smartphone has emerged as an omnipresent, never-ending source of knowledge, information, and skill building adjuvant. Such is the scope of the applications or the programs, that is what is simply called as apps. With a simple click of some keys and going on internet, treasure trove of information starts pouring out within a fraction of a second. Now, when this technological oriented specialty of anesthesiology came in contact with this futuristic technology, the amalgamation was inevitable. And that has turned out into a very useful, dependable, and an essential modality, not only for the younger generation of budding anesthesiologists, but even for their tech-oriented, mature, and senior counterparts. Mobile apps as friends of anesthesiologists. How does this concept stand? You see, anesthesiology is a constantly evolving, dynamic, and technologically based specialty. We know that. Its day-to-day utility requires a practitioner to be in the constant process of updating, constantly gaining the knowledge, whatever is coming every day. The precision and the exactitude of the specialty requires a person to have minutest knowledge and awareness about the dosages of the drugs, their rates of infusions, dose and efficacy correlation, and the dose ranges of potential toxicity by rote. In addition, the techniques of anesthetic procedures need to be learned by heart, seen being demonstrated, practiced a few times, and then mastered by the novices. Logically, there are multiples of apps available on the internet taking into consideration specific purposes and the requirements of the user. And at a click of a button, they provide concerned information in detail. The ease and the simplicity of this process is so alluring that one exposure to that and person gets literally hooked onto it. So depending upon their specific purpose or the utility, the anesthesiology apps can be broadly classified into 4 different types. That is related with their various drugs and their utilization, related with the mathematical calculations or formulae, apps based on textbooks or the reference books, and apps based on the journals or publications. Now coming to the apps related with the drugs. They deal with anything and everything pertaining to the anesthetic and other related as well as non-related drugs. That is generic brand names, clinical uses, dosages and routes of administration, their interaction with other anesthetics and other non-anesthetic drugs, and what is their current status, so on and so forth. The drugs, the apps related with the mathematical calculations or formulae, they appear to be the most commonly used apps, and they cover a wide variety of calculations, indices, scoring systems, formulae, equations, and other mathematical values. Apps related with the textbook's reference material. You see here the entire content of the textbook has been converted into e-format and specifically modified to fit the screen of the mobile. The material is in the constant state of readiness and easily available, which is periodically updated to synchronize with the current edition of the textbook. So the beauty of these apps is that the person can avoid inconvenience of carrying big bulky textbooks to the operating room for the use of the knowledge. Apps related with journals and periodicals, they give you the up-to-date knowledge about the cutting-edge research which is going on and getting published. In addition to the popular journals, the indexing bodies like PubMed and other repositories have produced their own mobile apps. In addition to these 4 major classes, there are 3 different other classes which are very useful, need to be mentioned. Simulation-based apps, basically these are interactive apps for the essential, delicate and skillful procedures like endotracheal intubations, percutaneous tracheostomy insertions, CVP insertions, CPCR to mention a few. Patient-educated related apps, that is the pre-operative preparation instructions, post-operative analgesia procedure instructions, labor analgesia related information, etc. and apps related with their societies, associations, upcoming conferences, and CMEs, giving their guidelines, giving their information, brochures, and other related material. Where and how to find them? The Android apps are available in the Windows Store or Google Play Store, while iOS related apps are available in the iTunes. But one has to be very circumspective while searching these apps using the terminologies like anesthesia, anesthesiology with the American spelling without A appearing before E, apps, mobile apps, and so on and so forth. Because at the last available count, there were more than 45,000 health related apps available on the internet, and the number is extrapolating with each passing day. Out of these, 7 to 10% are anesthesia related apps. So, sheer volume of the number available, one has to have a very careful filtration, selection, and utilization, which is of paramount importance because majority of the apps are not free and there is a certain amount of monetary encumbrance involved. So one has to be very precise in searching for these apps. These are the places where they are available: iTunes, Google Play Store, or Windows Store. Now coming to the anesthesiology apps currently available. And the first which comes in your mind is American Society of Anesthesiologists My Learning app. This app basically gives you the courses which are being provided by American Society of Anesthesiologists. It is a free app. And the beauty of this app is that you just go on the internet to download the course content and the material, go offline, do whatever you need to do, and when you are ready to submit your report and get the credits, you go again on the internet. This is another app called Hippocrates. This is again a general app with anesthesia contents in it, and it is up-to-date information, and the resources are designed to make you more informed clinical decisions. This is a book-based app, Oxford American Handbook of Anesthesiology in a PDA format. This gives all the information in the print version converted into the e-version. This is not free, this costs money. And there are, as I mentioned, multiples of apps available: pre-anesthetic assessment, journal references, pediatric anesthesia, anesthesia books, flashcards, anesthesia drug references, so on and so forth. Some of these, depending upon the user preference and the rating given by the users or the downloaders, you can have 4.5-star rated apps, 3.5-star rated apps, 5-star rated apps. There is an app called Anesthesiologist. It has been rated as 4.
Muhammad just joined us once.
Public. There is two another apps called ITIVA and ITIVA Pro. They give you all the information regarding total intravenous anesthesia. And this is another app called Capstasia app Anesthesia. At a small fees of about 78, 75, 76 rupees, your smartphone can get converted into a hemodynamic monitoring apparatus. These are two journal-based apps: Canadian Journal of Anesthesia and Anesthesia Intensive Care. And there are again these mini apps for ECG, pulse oximeter, QA self-study, smart thermo, temperature monitoring app, regional techniques. This app needs a special mention. It has been created by a chap called Matt Virgo. It is a big one app with 17 different subspecialty or sub-apps available in the anesthesiology. It gives you the information regarding the infusions. It gives you about the various different procedures related with the anesthesia, cardiac anesthesia. It gives you other interventions like bronchoscopies, drug-related information. And it is not cheap. It costs nearly $100 to buy. When we come to the iOS apps, at one site called iMedical Apps MedPage today, there are more than 29 to 30 apps available, ranging from the virtual reality into deliver room, virtual reality into operating room sedation, ABG evaluation, ICU procedures, app. Many apps are available there. Three apps need to be mentioned here specifically. Two by QXMD, one is called Read. This app is exclusively for the journal articles. The beauty of the app is that you need to just log in through your institution's library ID, your own ID through the institution's login ID, and you can access thousands of journal articles, which would cost you almost like $39, $49, $39 for each. You can download them, you can store them, you can share them, you can do anything. You can put it on Twitter, you can put it on Facebook, like that. This is another app by QSMD. This is basically for the calculations, as the name suggests. There are more than 150 calculators available, giving you A- ADO2 gradient, ABC score for massive transfusion, abnormal involuntary movement score scale. So like alphabetically A to Z, more than 150 apps are available. This is a society related app, American Society of Regional Anesthesia related app. They give you their multiple guidelines regarding the regional anesthesia, their procedures, the dosages. And in addition, now they have come up with a ASRA Reg Quag, where they give you the latest guidelines for the patients who are on anticoagulants like antiplatelet drugs, thrombolytics, and when in whom you want to do the regional anesthesia techniques. What are the latest guidelines? What are the precautions to be taken? What are the when the dosages of the drugs to be stopped, so on and so forth. And last but not the least, I would like to mention this app here. This is up to date. It is an evidence-based app, and as the name suggests, it is continuously updated. It gives you, it is not a anesthesiology related specific app. It is a general medical app, but it gives you a multiple areas of anesthesia coverage like drug infusions, drug utility, various pathophysiological processes, the surgical medical interventions, various disease processes related with as comorbidities for anesthesia. It also is not a free app. It costs money. I could go on for hours together explaining multiples of apps, but because of the paucity of time, let us come to the last couple of issues. That is the disadvantages, because every good thing, if done in excess, has detrimental effects. So even if these technological advances are used for educational or health delivery purposes or purely recreational purposes, they are not without their physical, emotional, or economical side effects if they are used in excessive use of this mobile technology. And the complaints which have been recorded are headaches, increased stress, insomnia, difficulty in concentration, easy fatigability, depression, to suicidal ideation have been described. The new nomenclature in form of two disorders have been explained. One is called nomophobia or no mobile phone phobia. It is a morbid fear of, it's a psychological condition, morbid fear of being away from mobile phone connectivity, and it manifests as anxiety, tachypnea, tremors, sweating, agitation, disorientation, tachycardia. The second disorder is anxiety. It's a phantom experience. Person hallucinates that his phone is ringing or vibrating when actuality there is nothing of that sort happening. This is a likely problem in various junior resident community, especially anesthesiology, especially when they are on call, or even in anesthesiology private practitioners or service providers. A latest study from Telangana on medical undergraduates has confirmed that there is a direct proportion between the excessive use of mobile technology or smartphone addiction and the total exposure time, and the severity of the symptoms, which I just mentioned. Last but not the least, a growing concern amongst the teachers of specialty like myself, that this overindulgence or overdependence of the PGs of the specialty on this ready-made electronic knowledge is actually dulling their reflexes, their interest. As soon as you ask them a question, reflexly their approach is just go to the mobile, start searching for the information, and that may actually lower the standards of the training. In conclusion, there are multiples upon multiples of apps on internet related with anesthesiology which are user friendly. In mobile application stores like iTunes, Google Play Store or Windows Store, but there is no specifically effective way of identifying what is suitable mobile application for you. So user needs to correctly analyze their utility, applicability and suitability for their personal requirement on an individual basis. Financial encumbrance is involved and cost effectivity is a major concern. Thank you, ladies and gentlemen.
Very nice lecture, sir. Actually, Dr. Pandit Rao sir is my teacher when I have worked with him. So now this topic is open for discussion. Any question?
Hello.
Any question?
Jai Baba.
Sir, your talk was excellent.
Thank you very much, sir.
Yeah, actually, I thank God that there were no mobiles when I was PG. So you described all the negative effects of using all these gadgets. So
Yes, sir.
thank you very much, sir. Thank you for joining me and having this great talk.
Thank
sir.
you very much, sir. Thank you.
Bye.
Thank you very much, sir.
Sir, so we'll move to our next speaker.
अरे मुझे तो इन्होंने बुलाया ही नहीं सर क्या बोले
Yeah, next speaker. Technical support, please put on the slide. Yeah, I have proud privilege to introduce our next speaker, my best friend, Dr. Meenakshi Sundaram, sir. He has been instrumental in ISA for more than 25 years, and I think very few anesthesiologists may be there who are not knowing him. He is a very renowned personality in ISA, and he is very famous for his talks because he is a very good orator, and he has a vast experience of giving lectures on different topics, academics as well as non-academic topics. So he is Dean of Government Medical College at present, and I'll also like to hear from him. So it's all yours, sir. Dr. Meenakshi Sundaram, sir.
Chairperson, sir, 1 minute. My topic is handy gadgets for anesthesiologists.
Yeah.
It is normally typed as nurse anesthetist. My topic is handy tools for anesthesiologists, handy gadgets.
Yeah, thank you, sir. Actually, in your slide, it was not projected what your topic is. But whatever topic is given to you, you go on hitting sixes and fours. So
thank you.
Yeah, we'd like to hear from you, sir. So it's up to you, sir.
They can project the recording, sir. I have already sent the recording.
Yeah, yes.
At the outset, I thank the ISA Gujarat and ISA National Headquarters for having given me this opportunity to talk on handy gadgets for anesthesiologists. When I have decided to go for handy gadgets for anesthesiologists, I checked Google. Then I discussed with Dr. Tushar Chokshi, Vadodara, Gujarat, who is called as an infographics man regarding artificial intelligence and the new year developments. What I am going to say in this 20 minutes lecture is just an eye-opener for you. I will not tell you the technical specifications of the equipments, or I don't know the price tag for each and every equipment, because I am also not having a personal usage in the handy gadgets. So far, we are using only the multi-parameter monitor. So the first is available in the price is 1,000 to 3,000. It is having the 12 hours clock function and a low battery warning also. So it can be, the oxygen saturation can be easily measured for any patient at any station. Then comes your wrist pulse oximeter. This wrist pulse oximeter comes without a probe or with a probe. So this price range is from 6,000 to 8,000. So it provides SpO2 and the pulse rate. See, it is effective in poor perfusion states. It measures at the level of the wrist. With the probe, it measures at the level of the finger. It is having a rechargeable lithium long life battery, so it can come for a long life. Then routinely, we have a problem in measuring oxygen saturation for the neonates and the newborns. So to overcome that, this neonatal wrist pulse oximeter has come. It can be worn as a wristband, and it can be used even in neonates weighing less than 3 kg. That is, even in preterm infants, it can be used. Then comes the wireless pulse oximeter. The wireless pulse oximeter acts through Bluetooth and Wi-Fi. So even your smartphone can be used as a computer to analyze the results. So it accurately measures the blood oxygen level, pulse rate, and perfusion index. So the SpO2 and the pulse rate can be measured by this also. Then the pulse oximeter with the NFC. NFC means it is near field communication. RIFD is radio frequency identification. This can be used to detect the SpO2. Normally, this RIFD is used in the hospitals in labor wards to track the movement of the mother and the baby, to prevent the child theft. So these tags are worn around the wrists of mother and the child, and they can track the movements. That is used for pulse oximeter also. It is having a memory facility, so we can retrieve the memory and the recorded readings from this. Then the finger blood pressure. The innovation in this is because of periodic inflation and the deflation of the BP cuff during anesthesia, especially in regional anesthesia, the patient finds it difficult. And again, the pressure points will be also there because of the BP cuff. And that can be eliminated by this Luminoscope finger blood pressure monitor. So just by the press of a finger, it will record the BP. Then another innovation is the wrist blood pressure monitor. It is already available in the market. Patients are using it in their homes to record the BP. So this is a watch type blood pressure measurement instrument. It is also cuffless. Then oximeter with BP, two things. But again here, to record the BP, the cuff is used. So the problems of the cuff persist here also. Then instead of BP and SpO2, it is SpO2 with capnograph. So it is having a separate sensor for capnograph. So this will be a handy tool for the anesthesiologist. Then the smartphone ECG machine. I want to tell you, in the future, the smartphone is going to be the smart and handy equipment for the anesthesiologist. we can do everything with the smartphone. So we can even record ECG, we can defibrillate, and we can even use it as a remote control for TVs also. So the smartphone ECG machine, brand name Cardio Defender, is the first machine to give a hospital quality ECG with arrhythmia analysis. So the software and algorithms are loaded in the smartphone and it can be used as a mobile ECG machine. So the price ranges from 6,000 to 10,000 for ordinary quality and 60,000 to 80,000 for hospital quality. Then the smartphone defibrillator. This will be a wonderful innovation. The smartphone is used as a defibrillator. So this is called a cell AED. This is a cellular phone with the AED facility. So the back case, if it is opened, there will be two paddles. So when these pads are pulled out of the smartphone, then the relevant country emergency service is dialed. Then once the pads are placed on the victim's chest, the emergency operator is obtaining the location details so that the ambulance can arrive by GPRS. So the cell AED advises both on the screen and also in the loud audio to keep hands free when the shock is delivered and when the CPR is to commence. So it can alternately deliver shock as well as it can advise the operator to perform CPR. Then another innovation of implantable defibrillators is a gold gadget that would let you stop heart attacks. This is advertisement. With a smartphone, this will help you to defibrillate the heart. And another advantage is these implants, the charged by transforming heartbeats into electricity with the piezoelectric technology. So they recharge by heartbeats. And obviously, when there is a cardiac arrest, they cannot get any charge. And this vital signs simulator, it simulates 8 functions: ECG arrhythmia, respiration, temperature, IBP, cardiac output, NIBP, oxygen saturation, and waveforms. So this will be a handy tool for the anesthesiologist for teaching. This is a vital sign simulator. And same way, a vital patch, this is just like a band-aid, but it maintains all vital signs. It can be applied in the infraclavicular area. Then the smartphone can be used as a spirometer also. The moment the patient blows through the mouthpiece, then the smartphone records the spirometry. It flawlessly connects to the smartphone so that we can easily share the results. Same way for the anesthesiologist, now the ultrasound guided nerve block has become the routine practice, and moving the ultrasound machine from one area to another area is cumbersome. So the handy tool, again, it is a smartphone. So this smartphone, this Mobi US, this is a trade name. It is coming with a scanner, plugs into smartphones. So they provide instant scan image. So this will be a handy tool for the anesthesiologist to perform the nerve blocks, and whether PNDT acts apply for this. Yes, it will be applied for this also. So we have to be very careful in using this. The best thing for the anesthesiologist is scared whenever a obese patient comes, mainly for epidural anesthesia, that would be very difficult. So the epidural space locator helps the anesthesiologist to assess the depth. So it has come into market. The first thing is Rivanna. Rivanna Accura is the first equipment which is marketed. And this ultrasound based system specifically locates the epidural location and depth. So we can use it for guiding epidural anesthesia as well as spinal anesthesia. Then the stethoscope, routinely we used to auscultate the patient with that listen to the heartbeat by earpiece. Now we can connect it to the smartphone and even we can record the heartbeats. So this is a smartphone enabled stethoscope. And this is stethoscope with ECG. It is an integrated equipment. These are all important handy tools for the anesthesiologist. Then the smartphone can be used as a thermometer. So as I said, the smart can be used for anything in monitoring. So this thermometer is an infrared thermometer, and the Sesame Smart Ear is available in the market, which is used to measure the temperature of the ear. In addition to this temperature, it measures hemoglobin, pulse oximeter, and pulse rate. So with various combinations, we can use the smartphone. The best advantage of this equipment is we can track fever because the fever module is incorporated in the software. So we can find out the differential diagnosis for fever, and we can pass on the information even for a teleconsultation. The same way smartphone is used for weighing scale. This is not a simple weighing machine. When the smartphone is connected, it is extra smart. So it measures and tracks 9 aspects of body composition. So the complete understanding of weight is possible. So the price range is up to 10,000. So it measures, it gives guidance about muscle mass, body mass index, body fat, visceral fat rating, and weight, lean body mass, body water, and bone mass. So the calculation of the drug dosage would be easier with this weighing machine. So really it is a smart phone weighing scale. And another handy equipment under various combinations, it measures hemoglobin, SpO2, and pulse rate. Again, the smartphone modification. By the industrial endoscope, this smartphone can be used as a video laryngoscope, and already many companies have marketed the video laryngoscopes with the smartphone. So the good innovation, simple gadgets which help the anesthesiologist is the newer type airways. One is a chin up patient support device. We have seen in monitored care, anesthesia care, and total intravenous anesthesia, sometimes falling back of the tongue, we have to make the chin up tilt. So at that time, the hands will be painful. We cannot do it continuously for the entire procedure. So this chin up used to tilt up the patient's chin and hold it in position. So the airway will kept patent. Mainly it is used in monitored anesthesia care and the total intravenous anesthesia. Another simple innovation is the anti-snore chin support strap belt. So when the patient is a snorer, this chin support strap belt will keep the airway patent. It can be used as a home therapy as well as during anesthesia when sedation is employed. Then the same thing, snore-free nose clip. So this nose clip, it comes with a case. So it gently opens up the nostrils to increase the airflow. So built-in magnets provide magnetic therapy for people who are believing magnetic therapy, but definitely it increases the airflow by opening up the nostrils. It is no drug is used. That is an advantage, inexpensive and non-invasive, and the travel case is also available so that you can keep it any station. And as far as I know, this is the smallest CPAP in the world. This CPAP will be helpful in obstructive sleep apnea as well as in sedated patients. Same way, the NasoFlow nasopharyngeal airway device. This is coming with the oxygen port. So direct oxygen delivery is possible. Humidification vents are also there. And there is an optional respiratory indicator with or without a hydrophilic filter. Then usually the laryngeal mask, they come with a subglottic suctioning port. But now the innovation is subglottic suctioning is available with the endotracheal tubes also. So the brand name is Halyard. It comes with a Murphy eye as a safety mechanism. There is a separate lumen to provide access to the subglottic space. So you can easily apply suction. Same way, by modifying the available McGill's forceps, the nasotracheal intubation has become much easier, which is the brand name is Rodinia. Then in the stylet also, the stylet, the rapid positioning intubation stylet. See, the tip can be moved by this handle. So we can flux or retroflux. So the intubation is much easier with this instrument. The best innovation would be, by using visual and alert score, we have found it difficult to assess correctly the patient's analgesia score. Now we are having an analgesia monitor. So every software app is fed into it and we can measure the analgesia level. The smart finder is a wonderful innovation. where the veins are made visible irrespective of obesity or the skin color. So it is very easy to cannulate the peripheral veins. So for central vein, ultrasound scanner may be utilized, and for peripheral veins, the smart vein finder is used. Same way, the smartphone can be used to measure the glucose level also wirelessly with a smartphone. So this will be helpful in anesthetizing diabetic patients. So sugar beet is a trademark. See, by just like a sticker, you can place the sticker, that is a tracker, over the arm or leg or the abdomen. So with the electronic sensor, every 5 minutes, the blood sugar is measured. It is with the interstitial fluid. So it is a non-invasive. This will be preferable because the patients are fed up. Mainly the diabetic ketoacidosis patients, because of continuous blood sugar monitoring the intermittent level by capillary method or intravenous sample. If it is lifted, it will be painful. This is a painless technique. So the digital plaster is not a simple plaster. By the sensors, inclusion of the sensors, it monitors blood pressure, temperature, and glucose levels. So it contains a Sensium silicon chip which can be connected to the smartphone or a central computer database. The fail-safe syringes, this is to prevent needle stick infection. Previously, IV cannulas were prepared, manufactured like that. Now the syringes have also come like that. This is a single hand operated. Passive spring aided retraction of needle by back end activation. So this action is under voluntary control. Once it is done, the needle is get locked into the plunger, and it should not be reused, and it must be disposed of as a recyclable waste. So the smartphone breath analyzer, just like a spirometer, this smartphone breath analyzer is used to detect alcohol concentration. So it connects to user smartphone by Bluetooth technology, and it gives the alcohol concentration within 5 seconds. And anesthetists are fond of ventilators. So this Rival ventilator is a handy ventilator. Even though it is expensive, as it is come as a handy tool, it can be easily carried, and it can be used in the street or even in the stretcher or in the theater, and it supports invasive, non-invasive, and transport ventilation. So ultimately, the carry home message I want to give, there are so many handy gadgets available which are going to rule the market in future. So the anesthesiologist intervention will be reduced with a smartphone. I think he can operate everything, including anesthesia machine. So you may be having a lot of doubts. What is the specification? Mainly, we are worried about the price and overall the manufacturer, where it is available. So if you have any clarification for handy gadgets, Google handy and stay updated. That is a carry home message I want to tell you. And once again, I thank Isacon Gujarat and the national headquarters for having given me this wonderful opportunity to interact with you on handy gadgets for anesthesiologists. Thank you.
Very nice lecture, sir. Actually, these gadgets are really helpful, and seeing all this now, I think the future of anesthesia is very bright, because all these gadgets are handy and they can be carried from one place to another.
Yes.
And I like the defibrillator, smart defibrillator, because in many OTs in private practice, we face that there are hardly defibrillator available. So if we ourselves have defibrillator, smart defibrillator with us, then the fear is much reduced. So now this topic is open for discussion. Any queries?
Before that, as chairperson pointed out about this defibrillator, in airport and railway station and all, if everyone is having a mobile phone with the defibrillator, then it will be really handy. We cannot run, because in airport they say it will be fixed in one place. people may not know where it is available. They will be running from pillar to post. So if a mobile phone, if it is coming in handy, so in future everything will be easy. But I don't know whether our brain will work or not, as everyone is.
That is the main fear in front of us.
It's a real problem. It's a real problem because I have seen in supermarkets, if for a 90 rupees, if you pay 100 rupees, that lady, the sales girl, they simply types 190, then only she gives 10 rupees. That simple calculations have gone.
So any queries? Any question from audience?
Answer is Google, sir. Whatever question is asked, answer is Google only. Because people will be worried about the price.
Yeah, Dr. Upadhyay?
But yes, sir has given answer where it is available. It is only available on Google, I think so.
Yeah. Another
It is not
chairperson.
still it is not easily available for everyone.
Yes.
But whenever it is very useful and very patient management, and so lecture is so nice, sir. Very nice, sir. Very informative, nice, and very happy. We know that is very informative. All the lectures are very informative and helpful. And it is just short comely in the market and helpful for all anesthetists, application, artificial intelligence, and these gadgets. Every type of patient, anesthetic, pre-operative, post-op, and management everywhere is very helpful.
So thank you, sir.
Thank you, sir.
Yeah, Meenakshi Sundaram, sir, your talk is always very refreshing. And this talk is actually much needed talk because this is a boosting of our morale in
Yes, definitely.
especially in private practice, because if
Yes,
these things
definitely,
are,
sir. It is very helpful. Reduce very stress of the anesthetists and consultant surgeon and everywhere. In even
we have seen the watches with pulse oximeter and all that, but this defibrillator and this, they were beyond imagination. So now I can say that the our horizon is expanding, and we are seeing all these things in our in between our horizon. So we can definitely go for that.
Sir, I'm
Very
sure
nice.
the next Isacon, it will be available in market, sir.
Yeah. That is very good thing, sir. So
yes, it is very. Definitely, sir. It is.
Yes. Thank you very much, sir.
Thank you. Thank you, sir.
Yeah, we'll move to our next topic. Upadhyay sir, please introduce the next speaker.
Yes, sir. Please, next speaker. Next speaker, please.
Technical support, please put the slide of next speaker. Is there anybody from technical side?
Sir, this session is over.
This session is over. Thank you very much, all of you.
One lecture is missing. One
Please
speaker.
confirm. Yeah, please confirm. I think there are 4 lectures.
One speaker is left. In between, Doctor, I think second, in the name second, Doctor, sir.
Because that session time was 4 to 5:30.
Yes, exactly, sir. After that, there is a neuro anesthesia.
Yeah. So I think there is one lecture remaining. So please find out. We are joined through mobile, so we cannot go and search.
Yes, sir. We are not physically. Yes.
Hello.
Yeah.
Sir, Dr. TV Tantri will not joining today, sir.
Okay. So this lecture is cancelled.
Yes, sir.
Yes.
Okay. Then we'll move on. Yeah. Thank you very much.
This 3 lecture is so nice. I think so. 4th lecture is also very nice. So we miss it just.
Yeah.
Very.
Actually, thank you very much.
Something.
Thank you very much, the organizing team of Isacon Ahmedabad, and it would have been a pleasure to be physically present there, but since it is available on virtual, so we chose virtual. but the lectures are very nice, and
Very
all the
nice, really,
speakers,
very
yeah,
nice.
all the speakers have gone to search all the different
Yes,
innovations, and they have put forth
yes, yes, yes.
all the information before us. So thank you very much. Thank you,
They
Upadhyay
give
sir.
so much then effort, everything they give.
Yes,
Everything.
yes, yes.
Yes, sir,
Thank you
definitely.
all the
Thank
delegates who have joined this session. So this session is over now. Thank you.
Thank you.
Thank you, sir. Now we move forward and start next session. That is our last session for today. Topic is neuroanesthesia. For this session, I invite to Dr. Kirti Patel and Sujata Prabhu as a chairperson, and I request to introduce today's speakers and continue the session.
Very good afternoon to all. I am Dr. Kirti Patel, retired professor and head of NHL Municipal Medical College, and now working at Sumandip University, Pitparia, Baroda, as professor of anesthesiology. And welcome you all to this session, the last session of today's Hall F of neuroanesthesia. I invite chairperson Dr. Anita Patel. She was also working with NHL Municipal Medical College and retired as professor of anesthesiology at Parul University, Vadodara. What about the third chairperson? Sujata Prabhu, we are waiting for you. Okay. So now let us start the session. Let us invite first speaker, Dr. Dimple Pandya. She is assistant professor in Department of Anesthesiology at SVP Hospital, attached with NL Municipal Medical College. She has worked in pediatric neuroanesthesia and pediatric anesthesia. Her topic is a comparative observational study between dexmedetomidine versus combination of midazolam and fentanyl for tympanoplasty surgery under monitored anesthesia care. That is her expertise. And there are so many papers she has published. I invite Dimple Pandya. Please start.
Hello, good morning everyone. I, Dr. Dimple Pandya, Assistant Professor in Anesthesia Department, will brief you about management of tight brain. Cranium is rigid box with fixed volume, which contains brain tissue, CSF, arterial and venous blood. When compensation is required, then CSF absorption is increased by arachnoid villi, and CSF is also displaced in subarachnoid space. And venous blood is displaced into internal jugular vein because venous sinus have no valves. But if compensation is lost, then there will be different type of hernias. Monroe-Kelly hypothesis suggests that pathological state that increase in volume of one content will necessitate to decrease in volume of another content. So to maintain normal ICP. Tight brain is referred to elevation in intracranial pressure caused by expansion in the intracranial volume beyond its ability to compensate. Graph shows volume pressure relationship of intracranial space. Plateau phase suggests that there is compensation because of translocation of CSF and venous blood. Compensation when exhausted, tiny increase in the volume of any content will increase ICP and there will be different type of herniation. So it will result in mechanical injury and ischemic injury. ICP is a total pressure exerted by three contents in the skull. And ICP is a hydrostatic pressure measured in CSF compartment. Whenever there is an increased ICP, there are internal herniation and external herniation. In external herniation, the cerebral tonsils will herniate into foramen magnum and it will lead to compression of the fourth ventricle and it will lead to decrease in cerebral perfusion pressure. There are different causes of raised ICP. They are physiological and pathological. Physiological causes includes increased abdominal and thoracic pressure, increased metabolic demand, hypervolemia, and pathological cause includes acute cause that are in IPH, traumatic hemorrhage, acute cerebral edema, infection, and benign intracranial hypertension. Chronic causes include slow growing lesion, disturbance in CSF, absorption, production, and flow. Common cause of raised ICP is cerebral edema. There are three types of cerebral edema: vasogenic, cytotoxic, and interstitial edema. As I discussed previously, we have to control four compartments for decreasing ICP: blood volume, CSF volume, cellular compartment, and fluid compartment. Highlighted area in the slide suggests that factors are under control of anesthesiologist. The ability of the brain to maintain cerebral blood flow at constant level despite change in cerebral perfusion pressure is known as autoregulation. Autoregulatory response to hypotension may not be intact throughout the brain. Below lower limit of autoregulation, there is cerebral vessels are maximally dilated and cerebral blood flow decreases. Above upper limit of autoregulation, cerebral blood vessels are maximally constricted, cerebral blood flow increases and becomes pressure dependent. And fluid may be forced across the blood vessel into blood parenchyma, which ultimately results in cerebral edema and cerebral hemorrhage. Autoregulatory curve is displaced to right in chronic hypertension. There are two views for autoregulation. One is conventional view that suggests that cerebral blood flow is maintained constant over wide range of mean arterial pressure. Above and below autoregulation plateau, cerebral blood flow is pressure dependent. While contemporary view suggests that cerebral autoregulatory curve is not fixed and not static, but it is dynamically changing, influenced by number of variables like cardiac output, arterial blood pressure, metabolic activity, PaCO2, and PaO2. Cerebral perfusion pressure is measured by mean arterial pressure minus ICP, that is around 60 to 65 millimeter of mercury. Cerebral blood flow is around 45 to 50 ml per 100 gram of brain tissue per minute. And cerebral perfusion pressure is directly proportional to cerebral blood flow, and cerebral perfusion pressure is inversely related with ICP. Cerebral metabolic rate occurs at synaptic level and in astrocytes. The increase in neural activity will lead to increased local brain metabolism, which ultimately end up with increased cerebral blood flow, that is neurovascular coupling. Recommended value for PaCO2 is near 30 to 35 millimeter of mercury. Cerebral blood flow varies directly with PaCO2. Hyperventilation decreases PaCO2 and ultimately reduces ICP. Below 25 millimeter of reduction in CBF, below 25 millimeter of mercury, reduction in cerebral blood flow is limited. So it will not be helpful in lowering ICP. Now, effect of PaCO2 and mean arterial pressure and cerebral blood flow. With hypercapnia, there will be cerebral vasodilatation and autoregulatory response to hypertension is attenuated. While with hypocapnia, greater cerebral blood flow autoregulation over a wide range of mean arterial pressure. Second graph shows cerebral vascular responsiveness to PaCO2, which is influenced by blood pressure. Whenever there is a moderate hypotension, cerebral vascular responsiveness to PaCO2 is attenuated. But when severe hypotension, the cerebral vascular responsiveness to PaCO2 is abolished. Hyperventilation is used to decrease ICP and to improve surgical field. But effect of hypocapnia on CBF is not sustained. With the onset of hyperventilation, pH of cerebral CSF and brain ECF is increased and cerebral blood flow decreased abruptly. But cerebral alkalosis is also not sustained. So after 8 to 12 hours, pH returns to normal and CSF returns to normal. PaO2 between 60 to 200 mm of mercury, there is little impact on CBF. But when PaO2 is less than 60 mm of mercury, there will be cerebral vasodilatation and increase in cerebral blood flow. Oxygen saturation and cerebral blood flow are inversely related. Both hemodilation and hypoxemic hypoxemia causes cerebral vasodilatation and it will increase cerebral blood flow. But hypoxic hypoxia is more potent variable. Cerebral oxygen delivery is better maintained in hypoxia than hemodilation. Hypothermia reduces CMR. Both compartment of CMR is reduced in hypothermia. First is neuronal electrophysiological activity and second is maintenance of cellular hemostasis. Anesthetics only reduce that electrophysiological activity of cerebral metabolism. Preoperatively, patient may have symptoms of headache, sleepiness, blurred vision, nausea, vomiting, confusion. And signs of severe raised ICP may be present like cranial nerve palsy, mostly 6 nerve, pupillary dilatation may be present. Patient may have Cushing triad like systemic hypertension, bradycardia, abnormal respiratory pattern, and wide pulse pressure. Diagnosis of raised ICP is made on basis of symptoms, radiological investigation, and by direct measurement of ICP. Treatment of raised ICP should be started pre-operatively, so we can prevent tight pain operatively. Fluid management is for restoration of intravascular volume, maintain cerebral perfusion pressure. We should avoid hyperglycemic fluid. Consider mannitol, anti-epileptic, anxiolytics, antihypertensive, and steroids pre-operatively. CSF drainage should be planned pre-operatively so we can prevent tight pain. Graphs shows different ICP waveforms. Lunderberg A wave represent arterial pulsation that are also called plateau waves and that suggest poor prognosis. Lunderberg B waves are sharp, brief spikes and that represent compliance. Lunderberg C waves, that is unknown etiology. They are rhythmic, very short duration spikes and that represent venous pulsation. To reduce ICP, we have to reduce CSF volume, blood volume, and brain parenchyma. For reduction of CSF volume, extraventricular drain is kept and maybe VA shunt and VP shunt planned preoperatively. Reduction of the blood volume, that venous blood is displaced in the internal jugular vein because venous sinuses have no valves. Evacuate hematoma urgently. For arterial blood reduction, we have to decrease CMR with the help of propofol, pentothal, benzodiazepines, and hypothermia. We should prevent hypoxia and hypercapnia. We should provide minimal P to achieve adequate oxygenation. For reduction in the volume of brain parenchyma, we use osmotherapy, surgical excision of the tumor, surgical excision of the brain abscess. We can also add antibiotics and steroids. Rapid reduction of ICP is required in some cases. In that, we should hyperventilate patient to decrease PaCO2, but it should not be less than 23 to 25 mm of mercury. CSF drainage is also planned. Diuresis, usually we use mannitol. CMR suppression with the help of barbiturate and propofol. MAP reduction. All these measures will not work, then we have to plan surgical control, that is with help of lobectomy and removal of bone flap. That is the last resource that we have to use in some emergency condition. Now we will go through CSF compartment, then venous compartment. CSF compartment, no pharmacological manipulation will be effective. Manipulation of the size by CSF drainage. Whenever there is a tight surgical field intraoperatively, we can improve by brain needle in the lateral ventricle to drain CSF or by preoperatively VA shunt, VP shunt is also helpful. Lumbar CSF drainage is reserved when surgical exposure is difficult. Venous compartment is passive compartment. Engorgement of this compartment will lead to increased ICP and poor condition of surgical field. Jugular vein is compressed by extreme flexion and rotation of head, increased intrathoracic pressure, and by kinking and partial obstruction of endotracheal tube. Head-up posture is required for good venous drainage. Anti-epileptic drug decreases CMR, decreases cerebral blood flow. It also decreases ICP and prevents seizures. Fentanyl is good analgesic that reduces CBF and CMR. Benzodiazepines also decreases CBF and CMR, but it will produce respiratory depression and hypotension. So it should be given in monitored close monitoring. Steroid, if administered 48 hours prior to elective surgery, then it will decrease edema and improve clinical condition. Lidocaine is helpful in attenuating pressure response with laryngoscopy and intubation. Glucose-containing fluids are avoided. Barbiturate decreases cerebral blood flow and CMR and decreases ICP, protection from ischemia by Robinson phenomena. It has also anticonvulsant activity. In the graph, we can see with barbiturate, we can get electrophysiological silence, but cellular hemostatic part of cerebral metabolism is remain unchanged. Propofol also decreases CMR and CBF. It decreases ICP and it also protects brain from ischemia. It has a anticonvulsant activity. Ketamine increases CMR and CBF. So best to avoid ketamine. Propofol, thiopentone and etomidate reduces CMR and thus decreases CBF. Propofol and barbiturates both are potent cerebral vasoconstrictor. Non-depolarizing muscle relaxants are preference of choice in neurosurgery, and scoline is preserved only for difficult intubation. Volatile anesthetic agent decreases CMR and decreases CBF. At 0.5 mg, it decreases CBF. At 1 mg, there is no change in cerebral blood flow. At 1.5 mg, it increases CBF due to vasodilatation. And sevoflurane has less vasodilatory effect than other inhalational agents. Nitrous oxide increases CMR and increases CBF. Mannitol acts by osmotic diuretics and it draws water from brain parenchyma. Dose is 0.25 to 0.5 gram per kg. IV slowly over 10 to 15 minutes. Maintain osmolarity above 320 milliosmol per liter. Duration is 6 hours. It may causes significant hypovolemia. So appropriate infusion of crystalloids and colloids is necessary. It will only be effective if some degree of blood-brain barrier integrity is preserved in significant portion of brain. Hypertonic saline also increases serum osmolarity. It decreases ICP. It is administered via central venous catheter. Dose is 1 to 2 ml per kg of 3% sodium chloride over 5 minutes. Target serum sodium concentration in between 145 to 155 and serum osmolarity below 320 milliosmol per liter. So serum sodium concentration, if greater than 160 milliequivalent per liter, then it may produce renal injury, pulmonary edema. So serum sodium and osmolarity should be checked at least every 6 hours. Efficacy of loop diuretics is less than mannitol and hypertonic saline, but when coexisting diseases are present, like congestive heart failure and nephrotic syndrome, it is helpful. It promotes diuresis. There will be systemic dehydration. It improves arterial oxygenation and decrease ICP. When combination of loop diuretic and mannitol is used, then there is added that neuron and glia shrinks in response to increased osmolarity in the external environment. So recovering of this volume is rapidly because the accumulation of so-called idiosyncratic osmol, that is chloride. But loop diuretic will inhibit this chloride channel and retard the normal volume restoring mechanism. Hypovolemia and electrolyte imbalance are the side effect of diuretics. Now, different vasoactive drugs are used to decrease ICP in neurosurgery. Vasodilators are used to decrease BP in anesthesia, but it produces cerebral vasodilatation. It increases cerebral blood flow and can increase ICP. But when decrease in blood pressure is slow, increased CPF will not increase ICP. Alpha 1 agonists don't increase in cerebral blood flow and no effect of beta blocker on cerebral blood flow. Dopamine at 2 microgram per kg per minute causes vasoconstriction. In between 2 to 6 microgram per kg, it causes cerebral vasodilatation. And again, higher doses cause cerebral vasoconstriction. Calcium channel blockers are used in case of acute hypertension. Angiotensin 2 are used for vasodilatory shock. Angiotensin converting enzyme inhibitors and angiotensin receptor blockers both decreases arterial blood pressure when hypertension is present. Different postures are used in neurosurgery. When supine position is used, we should provide head-up position, at least 10 to 20 degree. Head-up is required for good venous drainage. When prone position is given, firm support under chest and pelvis should be there to provide abdomen free, and we should monitor airway pressure. Sitting position have added advantage that it provides better venous drainage, decreases ICP, but chances of venous cell embolism and hypotension are more. Tight brain checklist. We should check different pressures like jugular venous pressure, airway pressure, partial pressure of carbon dioxide and oxygen, and arterial pressure. We should also check metabolic rate. And are any potential for vasodilators in use? Are there any unrecognized mass lesion? Prevention is always better than cure. Once tight brain occurs, it is very difficult to reverse. So our preventive measures should be started from pre-operative period and it should be continued to post-operative period also. We should provide smooth induction, good analgesia, deep plane of anesthesia, proper muscle paralysis, and extubation should be smooth. If elective ventilation is planned, adequate analgesia and muscle relaxation should be provided and maintain head-up position in post-op period also. Handle with care, otherwise it will blast. Thank you.
Thank you, Dr. Dimple. It was very nice presentation by you for tight brain. We'll have question answer in the last. Now I invite Dr. Ashish Bindra. Hello, Dr. Ashish Bindra.
Hello, ma'am. Good evening.
Very good evening. Good evening. Dr. Ashish Bindra is the additional professor in the Department of All India Institute of Medical Science and Associate Jai Prakash Nirman Trauma Center, New Delhi. And she has experience and clinical expertise in targeted temperature management. She is a co-investigator for the fluorescence multimodal monitoring in cerebral modalities, and she has expertise in neurotrauma and in epilepsy anesthesia. I invite Dr. Ashish Bindra, please.
Thank
Give
you.
your
Thank you, ma'am.
ideas on advanced neuromonitor.
Namaste, everyone. At the beginning, I would like to thank the organizers for giving me this opportunity. Heartiest congratulations for the organization of 68th Annual Conference of Indian Society of Anesthesiologists. Long live ISA. So the topic given to me is advanced neuromonitoring in neuroanesthesiology and critical care. I am Dr. Ashish Vindra and I work at All India Institute of Medical Sciences, New Delhi. So the presentation will consist of the following headings. Firstly, we will talk of cerebral physiology and pathophysiology, the types of monitoring available, multimodal monitoring, and the clinical relevance and conclusions. As we know that cerebral physiology is peculiar and brain tries to maintain a constant flow of oxygen in blood to itself through various autoregulatory mechanisms. And when there is a pathology like a tumor inside the brain or traumatic brain injury or ischemic or hemorrhagic strokes or some kind of seizure activity, which results in neurological insult, the brain tries to compensate it. So it tries to maintain its cerebral blood flow and the oxygen delivery to as near as possible. But when it is not able to compensate, there is a decrease in cerebral blood flow and oxygen delivery, which results in a visible physiological insult to the brain, depicted as clinical deficit. So the purpose of the monitoring is to find these changes as early as possible, and trying to treat them by restoring the physiology through different maneuvers and through various therapeutic techniques. So monitoring can be done in the intraoperative period of the critical care units. And initially the monitoring was clinical monitoring, which was classically done by GCS scoring, and later on 4 and GCS pupil was also added to the list. And to date, GCS remains the most commonly used modality of monitoring or clinical monitoring, even in the big neurocritical care or the neuro units. However, there are some disadvantages of clinical monitoring is that it is generally a reactive treatment wherein the insult has already occurred, then you try to manage it. So it's more of a reactive treatment, and your inability to judge in presence of deep sedation or muscle paralysis. And then we cannot detect the subtle changes in the intracranial physiology. For those reasons, there was evolution of neuromonitoring from the neurochecks in the form of GCS or the consciousness or the motor power of the patient to the physiological neuromonitoring. The typical example is monitoring of the ICP. However, even in the ICP monitoring, the ICP is increased wherein the insult has occurred and there is increase in intracranial pressures, then we are able to see the ICP changes. Gradually, the monitoring has moved towards a neurophysiological decision support, like looking at the metabolic or the energy patterns or knowing the subtle changes so as to prevent the secondary brain injury, which is now being followed by the multimodal monitoring, which is the integration of all the possible monitorings for a particular case. So the various monitoring subheadings which we would be talking about is the cerebral hemodynamic in the form of cerebral perfusion pressure monitoring, the intracranial pressure monitoring, the transcranial Doppler, which also studies the intracerebral flow velocities, and also the laser Doppler flowmetry and thermodilution techniques, which are the common measures to measure the cerebral blood flow, but they are not very widely popular. So we will be focusing on these three. Then we will talk about the cerebral autoregulation monitoring, then cerebral oxygenation, the commonly used monitors, the PBTO2 monitor, the JBO2 monitoring, and the near-infrared spectroscopy, and a little bit about the cerebral metabolism monitors like cerebral microdialysis. Imaging is also important, cerebral metabolic indicator, especially when you are doing a PET, SPECT or functional MRI, then it gives you some idea of cerebral metabolism and functional activity also. Then we will talk about the cerebral electrical activity, and another neuro monitoring modality is a neuroimaging, which is gaining wide popularity, but is not beyond the scope of this talk. So first, if we talk about cerebral hemodynamics, we all know this equation that cerebral perfusion pressure is mean arterial pressure minus intracranial pressure. So this cerebral perfusion pressure is the main indicator of the perfusion of the brain, and we try to maintain this perfusion pressure by all the treatment modalities. So we know that cerebral autoregulation is the maintenance of a constant cerebral blood flow over a wide range of pressure, mean arterial pressure. However, when there is a cerebral metabolic insult, the cerebral autoregulation curve shifts towards upwards or backwards, and sometimes the cerebral autoregulation still remains reactive. That is, it still changes to the mean arterial pressure, though the limits are changed, and sometimes it is the passive autoregulation, which means that it yields to the pressure changes and the cerebral blood flow increases with increase in the mean arterial pressure, and there is no autoregulation left. So how we determine the cerebral perfusion pressure? So is it the same pressure of 60 to 70 or 50 to 70 millimeter of mercury, which will ensure a proper cerebral perfusion to all the brains of all the human beings? Probably not, because it can be because of the various disease conditions wherein you may require a higher cerebral perfusion pressures, or in particular specific patient it can be individualized. So the concept was the individualization of the cerebral perfusion pressure to obtain that optimal perfusion at which the brain is optimally functioning. So for this, first is cerebral perfusion pressure. You have to calculate MEP minus ICP, but mind it, the mean arterial pressure has to be transduced at the level of the tragus to get the cerebral perfusion pressure. So how we obtain this optimal cerebral perfusion pressure? So there are multiple methods of obtaining this perfect CPP or the individualized or the optimal CPP, which can be obtained with the help of pressure reactivity index, drawing some curves from the near infrared spectrum value in cerebral oximeter reactivity index, or through TCT by checking the cerebral autoregulation and adjusting it, or looking at the metabolic parameters wherein optimal cerebral metabolism occurring, that pressure is chosen to be the best or the most optimal cerebral perfusion pressure. Just to give you an example, here a graph is plotted between the reactivity index and the cerebral perfusion pressure. This is the cerebral oximetry index, or the oxygen reactivity index, or the pressure reactivity index, obtained from different monitoring modalities. Obtained graphical record is kept beat to beat for maintaining a graph between the reactivity index and the cerebral perfusion pressure. U-shaped plot is made, and the minimum point or the negative point, most negative point of the plot, that determines the optimal cerebral perfusion pressure. Like in this patient, it would be around 62 to 72 millimeters of mercury. So this patient's individualized or the targeted cerebral perfusion pressure should be kept between this. However, this is a pretty labor-intensive job and requires special softwares and beat-to-beat monitoring of the patient, and therefore it is difficult to get these plots, and these are right now not very popular but rapidly gaining popularity. So we tried, one of my colleagues, he had his software purchased for the for the CO2 cerebral oximetry index, and we try to calculate the optimal autoregulation index range. This is a costly affair and it is not widely available, and one of the major other limitations of plotting the optimum CPP through pressure reactivity index or some other reactivity index indicates that it's a global autoregulatory capacity which is shown in these graphs, and the heterogeneous nature of injury may go unaccounted in these cases also. So first we have defined the cerebral perfusion pressure. Now we talk about the intracranial pressure. The intracranial pressure is the other very commonly monitored modality in patients with traumatic brain injury, especially. It is less commonly done for other kind of cerebral pathologies, but yes, where you expect an increased ICP, you may go for a ICP monitoring. So we know there are invasive or non-invasive methods of measuring the ICP, wherein ICP, it can be intraventricular, intraparenchymal, or subdural volt. And after putting these electrodes, catheters, we get a recording, which has a typical waveform which can be analyzed. And the non-invasive methods are there, which are optic nerve sheath diameter, which has become very popular, transcranial Doppler, which gives us a fair estimate of the intracranial pressure. Even the NIRS has been used, and tympanic membrane displacement. Let us see the intraparenchymal ICP monitoring. Why I have chosen intraparenchymal ICP? This is more commonly done because it is challenging to put the ICP inside the ventricles, and though ventricular method is the gold standard method, but intraparenchymal is less challenging. So we get a number and a waveform. There are specific indications for ICP monitoring in TBI. So now here I want to emphasize that we generally try to treat the numbers, and the numbers are given in algorithms for treatment. But along with the numbers, we also need to see the waveforms. So typically the ICP waveforms are in P1, P2, 3 corresponding to the arterial pressure waveforms. So it's P1, P2 and P3. Normally P1 is the tallest one, but when P2 is gaining height and it is taller than P1, it indicates a compromised compliance and indicates a compromised cerebral perfusion status, and increases in ICP is likely to occur. So grossly going, what are the trends of the ICP monitoring? It is like now we are going for the individualized interpretation of ICP with other neuromonitoring variables, particularly the PBTO2 monitoring, even the cerebral microdialysis monitoring. We are going towards the interpretation of the ICP waveforms. And what we are doing is calculating the overall burden of ICP rather than one individual sharp rise in ICP. These early warning of the deterioration it can give by interpretation of the waveforms, and we can prognosticate. So this is one beautiful study wherein they have color coded depending on the insult duration and the insult intensity of the ICP, and giving a visual information wherein the darker color, red color, depicts the higher insults and which are more likely to result in poor outcome as compared to the blue ones, which indicates a lower insult in terms of duration and intensity. One very common ICP monitor is the non-invasive monitoring is the optic nerve sheath diameter, which is very easy to do by putting a probe transorbital and measuring the optic nerve sheath diameter. Now we come to the next monitor, that is cerebral hemodynamic monitor. Is a transcranial Doppler which is used for measuring the blood flow intensities inside the cranium, and it is generally done with a probe which can be put through various windows like transorbital, transtemporal, suboccipital, vertebral windows. And it can be done inside the ICU by intermittent recordings, or there can be a headgear kind of stuff where you can fix your probes and go for a continuous intraoperative monitoring to obtain these waveforms which are variably manifested. The TCD has been used for prediction of vasospasm, as you all know, in the aneurysm management in the postoperative period. It has also been used for autoregulation testing in cases of intracranial pathologies, for the CO2 reactivity, for non-invasive estimation of the ICP. It is used for detection of the microemboli, especially during the carotid surgeries, and it can be used for monitoring of the therapeutic interventions and prognostications. Now, this is our study by our resident has done in pediatric TBI, wherein he has tried to correlate ICP, ONST, and pulsatility index, wherein we have found that this one really works. The ONST and the pulsatility index determined by the TCD is good for assessing the ICP non-invasively, even in pediatric patients. Now we move towards the monitors of cerebral oxygenation. These three are the most commonly used monitor. This is the PBTO2, NIRS. These are the regional determinants of the cerebral oxygenation. This is the jugular oximetry, which is the global determination of the global or the hemispheric determination. So PBTO2 is quite rampant, popular, and though I don't think any center in India has this PBTO2 sensors, this has to be put intraparenchymally and preferably within ICP monitor. Average range is described, and this has been by the Brain Trauma Foundation guidelines. PBO2 less than 15 has been found to be indicator of hypoxia, and less than 10 millimeter is associated with worse outcome. So this is a nice study with this BOOST 2 trial, which it has tried to see the difference between management by ICP only and ICP and PB2 do directed therapy in patients with traumatic brain injuries. So they had their defined protocols wherein when intervention is required, they have defined ICP more than 20 and PBTO2 less than 20. The various interventions they have defined wherein PbTO2 is particularly interesting, wherein they have asked to increase the PO2 by 50% and add EEG monitoring and anti-epileptics, and further increasing their 502 to 100, adjusting PEEP to maintain an optimal PbTO2. And the PROS2 trial found that management, which was based on PbTO2 and ICP monitoring, reduced the total time of brain tissue hypoxia. ICP control was similar in both the patients, and they have also tested the feasibility and safety of tiered treatment protocol. And also the 6-month outcome for the BOOST trial in group which was managed by PbTO2 ICP was better than the one which was just managed by ICP. However, the literature has mixed results till now to show that how this is going to benefit the patient's clinical care, and maybe more studies like BOOST are required, and BOOST 3 is on its way, confirming the clinical outcome of the patients with the management. Next is the NIRS. NIRS is a non-invasive SpO2-like 2 patches which have to be put on the outside on the forehead, and which measures the cerebral oxygenation. And NIRS otherwise is a very non-invasive and popular modality, but its utility in neurocritical care is still to be confirmed. More commonly, it has been used in cardiac surgeries, and it has been used as a screening tool for determination of intracranial hematomas, and it can define the cerebral desaturation, CPP, and the cerebral blood flow. And we have a newer device which is ultrasound typed NIRS, which has is a wider scope of application. Next is the jugular venous oximetry. We all know that is a fiber optic catheter which can be placed in the IJV, and normal values are from 50 to 70, and guidelines recommend putting it greater than 50% in TPI, and there are specific protocols defined how to treat and manage these values if they go haywire, less than 50 or more than 80. However, regional ischemia cannot be detected. There are placement challenges, and clinical use is limited till now. This is the study from the PGI Chandigarh, where they have used JVO2 catheters for comparison of two anesthesia modalities, and they have found the utility of JVO2 monitoring. There is the monitor of cerebral metabolism, which is the cerebral microdialysis catheter. So cerebral microdialysis catheter is another upcoming. In our institute, we have 2 cerebral microdialysis machines wherein a probe-like catheter is placed inside. It is a very thin catheter which has a semi-permeable membrane put in the brain, and we get a waveform analysis. Various variables or the metabolites which can be studied are these. The commonly done are the glucose, lactate, and pyruvate, but these markers of inflammation and cytokines can also be studied by cerebral microdialysis. There are proposed indications for cerebral microdialysis, like for secondary insults, for low glucose, and monitoring decompressive cranectomy. This is the data from our institute, wherein we have seen that mitochondrial dysfunction and ischemia rampant after traumatic brain injury. And this is another study from the institute wherein cerebral glucose has been shown to be very low as compared to the systemic glucose. And this one is the one which is an intervention small case series, where the cerebral perfusion pressure augmentation has been attempted with the use of cerebral microdialysis. However, we saw that CPP was not affected. Increase in CPP did not improve the microdialysis variables. Another are the biomarkers for neuromonitoring, which are used for prognostications, categorization of injury into mild, moderate, severe, and prediction of post-traumatic epilepsy. So this is another study from our institute wherein UCHL1 has been used for diagnosing the severity of brain injury. There are then EEG-based monitors. I won't go into detail, but would like to tell about the ECOG or the electrocorticography, which is the intraoperative monitoring. We're putting the EEG strip electrodes over the brain parenchyma, monitoring for the seizure activity. Mind it, when we are doing the ECOG monitoring, anesthetic technique needs to be modified, but muscle relaxant can be given because it is not monitoring the skeletal muscle activity. Then we all know about the evoked potential monitoring and the indications, various type of evoked potential monitorings. These are common, popular, and these have shown utility for managing the patients with with intraoperatively and also in the ICUs for determination of coma and for determination of the cerebral death. And however, all the monitoring modalities have some limitations. So we come to the multimodal monitoring. Now we have so many parameters like clinical evaluation, BP, ICT, CPP, microdialysis. Now, how to get information from it? So multimodal monitoring is the integration, data display and analysis, and maintaining a therapeutic plan. However, multimodal monitoring seems to be a very lucrative option, and people have the advantage of time synchronized formats and continuous values. However, there is data explosion. There's doing a multimodal monitoring, that is the integration of all the monitors together. They have some implications of its own. And right now it's pretty expensive and not much algorithms have been developed for the multimodal monitoring right now. So the pitfall of monitoring are that for advanced neuromonitoring, these are the few established treatment protocols for the various monitoring variables. However, the treatment variations are between the centers, even in the multicentric trials. The brain injury itself is heterogeneous and inherent risk of devices besides the cost of the advanced monitoring is there. However, the take-home message is that evolving literature regarding the monitoring in neuroanesthesia and neurocritical care, there are some established monitors like doing an ICP monitoring, like doing intraoperative evoked potential monitoring. These are the standard of care now. But for cerebral microdialysis, for NIRS, for measuring of the cerebral perfusion pressure, the data is still evolving. However, TCD has emerged to be an excellent tool in critical care settings for monitoring of the cerebral hemodynamics. So right now, the treatment thresholds for few of the monitors are defined and are being exploited, but for few, there are some shortcomings, and probably we need to have some more studies and more research and publications, especially from the Indian and national centers, looking at the cost effectiveness and the feasibility of these treatment protocols in neuroanesthesia and neurocritical care settings. Thank you very much.
Thank you, Dr. Ashish Bindra. Now I am inviting Dr. Kiran Nangaria. Sees your introduction.
Yes,
She is Associate Professor, Postgraduate Institute of Medical Education and Research, Neuroanesthesia, Neurocritical Care, Acute Neurocare, and Brain-Heart Interaction. She is academically medal for excellence, 66 national and international, and 14 book chapters. And her subject is brain-heart interrelation in anesthesia, neuroanesthesia. Now I am inviting Dr. Kiran. Please.
I would like to thank the organizers for providing me the opportunity to be present on this platform. Greetings from PGI Chandigarh. I have nothing to disclose. We all know brain and heart, these are the two organs which work in close association with each other. Heart provides the perfusion to the brain for proper functioning, while brain controls the autonomic nervous system by which it controls the activity of the heart. Both of these organs are friends of each other till the time they are healthy. But the moment some insult occurs to one organ, it is not going to spare the another organ, and they may behave like enemies. For example, if there is acute MI or thrombus in the heart, it is going to compromise the cerebral perfusion by reducing the perfusion pressure of the brain or by creating an emboli, which may cause acute ischemic stroke to the patient. Similarly, acute intracranial insults such as stroke, TBI, vasospasm, epilepsy, stress, they may affect the myocardial function, and sometimes it may be severe enough to cause severe myocardial dysfunction known as a neurogenic stunned myocardium or neurogenic stressed myocardium. We have also observed certain cardiac manifestation during the intracranial procedures while handling of the sensory branches of the trigeminal nerve, or maybe by direct handling of the cardiovascular centers in the brainstem. These reflexes may cause mild bradycardia or even asystole, and usually these are transient and disappear while removal of the stimulus without causing any deficit to the patient. But the stress myocardium is an entirely different entity. Here, the heart muscle is structurally or functionally abnormal in the presence of any cardiovascular risk factors such as coronary artery disease, hypertension, valvular heart disease, congenital heart disease. But there is always organic or functional injury to the brain. So here in this lecture, I will be discussing about the autonomic control of the heart, pathophysiology of neurogenic stent myocardium, how do these patients present to us, and what kind of monitoring should we do to recognize it, and what treatment modalities are available nowadays, and what should be the timing of surgery if the patient is having neurogenic stent myocardium. So to understand pathophysiology, we must understand the autonomic control of the heart. The afferents from the heart, they are carried by a 9th and 10th cranial nerve through the baroreceptor and the chemoreceptor. They reach the medullary center, and the outflow is either from the parasympathetic system, traversed by the vagal nerve, or through the sympathetic system via stellate ganglion or the middle cervical ganglion. These two systems alters the heart rate, contractility, and the stroke volume of the heart. In any acute, extreme stressful condition, hypothalamo-pituitary adrenal axis plays an important role, and it controls the contraction of the heart by releasing systemic catecholamines. So just to recap about the central cardiovascular nuclei. So these nuclei are located in the medulla, and the most common nuclei are the nucleus ambiguus and the dorsal vagal nucleus, which controls the parasympathetic system, while codoventrolateral medulla, it controls the sympathetic system of the heart. Nucleus tractus solitariae, it actually integrates the various information which travels to brain via baroreceptor, chemoreceptor, or from the other higher centers like insula, hippocampus, cingulate, amygdala. They traverse via hypothalamus and the parabrachial nuclei of pons to the nucleus tractus solitariae, and then they manipulate the sympathetic and parasympathetic outflow depending upon the site of the lesion. So under the normal circumstances, these sympathetic and parasympathetic outflow are tightly controlled. Moment there is injury on one side of the brain, then this imbalance, there is an imbalance in these forces, and that results in the myocardial dysfunction. Besides this, heart has its own intrinsic plexus, just like we have learned that the gut has its own ganglion. Similarly, a well-organized ganglionic network is also present in the epicardium, near the major vessels of the heart. These neurons usually respond to the mechanical distortion or changes in the chemical milieu of the myocardial interstitium, and they are also modulated by the efferent stimuli from the brain. This myocardial plexus plays an important role in neurogenic stent myocardium, as proven by a few studies, which states that the catecholamine level was higher in the interstitium of the myocardium than the plasma level. So that means these catecholamines are locally secreted, and they can cause the myocardial injuries in the patients with the acute intracranial inserts. So how this insert occurs was actually hypothesized by a few hypotheses in the literature. These include transient multivessel coronary artery spasm, microvascular dysfunction, aborted myocardial infarction with spontaneous coronary thrombolysis, or increased level of the catecholamines. The first three theories, like coronary artery spasm, microvascular disorders, they are actually not proven in experimental studies. And the most widely accepted theory is increased level of the catecholamine, which occurs because of the imbalance between the sympathetic and parasympathetic system outflow. There is some laterality hypothesis also, which states that both the hemisphere of the brain, they controls the different center. One controls the parasympathetic and another controls the sympathetic. Like insula is a major autonomic control center. The right insula controls the sympathetic one, and the left insula has the parasympathetic supply. Similarly, the left hemisphere is known to change the outflow with the positive emotions, while the left hemisphere of the brain, it changes the outflow to the negative emotions. Similarly, right vagus controls the SA node, while the left vagus controls the AV node, and they can affect the they have the different defects like bradycardia, or some patient may have a conduction defect depending upon the site of injury in the brain. However, these hypotheses has to be still proven by further researches. So how do these patient presents? Whenever there is intracranial insert, the patient may have mild changes, mild ECG changes like arrhythmias. It may range from the sinus brady or sinus trachy to the more malignant ones like ventricular tachycardia or ventricular fibrillation or atrial fibrillation. There may be conduction defects which range from bundle branch block to the complete AV dissociation. There can be prolonged QT interval which may lead to the torsade de Pontes, or there may be STT wave changes or U wave which may make the myocardial infarction, as we have seen in this patient. This patient is showing ST depression and T wave inversion globally in almost all the leads with the QT prolongation of around 482. There is another patient which is showing a global deep T wave inversion. These T wave inversions are even deeper than the S waves, and it is present in almost all the leads diffusely in the ECG. These are also known as the canyon T wave. The another is like U wave, you can see, or any kind of arrhythmias, whatever we can think of, we may find during in these patients after the intracranial inserts. So regarding echocardiographic changes, there are mainly two kind of echocardiographic changes. One is global hypokinesia, another one is a regional wall motion abnormality. Regional wall motion abnormality actually do not follow any vascular territory as we find in the ischemic heart disease. They may be segmental, like mid-basal, it may be mid-ventricle or apical. There may be apical sparing, that means mid-ventricle and basal segment is moving, but apex is not moving, or there may be apical ballooning. So any of these changes can occur. So here are a few examples. This is parasternal short axis view of the patient, which is showing a global hypokinesia with EF around 15 to 20%. And the same patient we saw at the discharge was completely reversed. The another patient of the global hypokinesia, this is a case of severe ICA vasospasm. And here, this is parasternal short axis view. And here is a apical 4-chamber view. Here you can see the shape of the left ventricle is totally distorted and it is like globular in shape. So here is another case. This case is having acute SAH presented with pulmonary edema. Patient has a severely depressed myocardial function along with the regional wall motion abnormality here in anterior septal segment. And this change actually reversed over the period of 3 days after the coiling. So here is another example. The typical finding of apical ballooning. This is also known as a Takasubo cardiomyopathy. Here, I apologize for the poor quality video, but if you can appreciate the basal segment and the mid-ventricular segment are contracting very well, but there is a ballooning of or expansion of the apex, which is coming out of the view actually. So actually, it looks like this, this shape in the systole. So here is the post photograph of this echocardiogram. Here you can see the apex is ballooned out while the mid-ventricle and the basal segment is contracting, and it resembles a port known as a Takasubo, which is used to capture the octopus. And this is the diagram in the diastole where the entire segment is dilated. So what should be the consequence when the patient is having neurogenic stun myocardium? These arrhythmias, as we discussed, may be mild, but they may be life-threatening, which can cause sudden cardiac death, or they can cause cardiogenic shock and even pulmonary edema. Maybe they may cause severe hypotension that can compromise the cerebral perfusion pressure, and most of the time it is associated with a poor neurological outcome. There are many studies in the literature which states that neurogenic stun myocardium is associated with a poor outcome. For this one study I highlight is in SAH patient, and they have said that long-term mortality and the stroke rate were higher, even increased risk of death and heart failure in the patient with the SAH. And this another study in traumatic brain injury has also found the same thing with the increase in hospital mortality. So how do we monitor? How to see if the patient is having neurogenic stun myocardium or not? First of all, we have to take a very thorough clinical history to rule out any cardiac risk factor, because if there is any cardiac risk factor, that may be because of the cardiogenic in origin. Second, we have to see the 12-lead ECG very precisely. If there is even subtle signs like QTC prolongation, that may indicate the patient is having stun myocardium. X-ray film has to be looked at because it may show cardiomegaly or pulmonedema. Cardiac enzyme profile, actually, these are increased, but they are not increased to the level as we see in MI. The lipid profile indicates cardiac injury, cardiac risk factor of the patient. More importantly, to highlight here are the electrolyte panel, because most of the changes in ECG after head trauma or after any intracranial insert, the most common cause is dyslipidemia. So once we rule out dyslipidemia, we can say that it may be neurogenic in origin. So what should be the natural course of the disease? As we see in the myocardial infarction, when heart muscle is also already dead, the contractile function may not come back to normal. But in stun myocardium, when there is no complete necrosis, we may find certain bands of necrosis, which is contraction band necrosis, because of extreme contraction of the heart. We may find it, but the myocardial cells, they are not exactly dead. So the function recovers within days to weeks in these patients. So what are the treatment modalities available in the literature? As we have discussed, it is usually transient and it is reversible with the reversibility of the change in the physiology of the brain. So elite treatment is supportive. And the goals of the treatment are to maintain hemodynamics and to stop the sympathetic surge and its effect. To maintain hemodynamics, we have various drugs like milinondobutamin, which can increase the cardiac output, or we can use the NOR-ADR or other vasopressors. But we have to be careful while giving epinephrine, as it may worsen the myocardial damage, being a catecholamine. Nowadays, we have a newer drug called levosimendan. This drug is a calcium channel sensitizer. It is a non-catecholamine, and it increases the myocardial systolic performance along with the improvement in coronary perfusion and has anti-apoptotic and anti-stunning effects. In some postmenopausal females with SAH presenting to us with this neurogenic stun myocardium, we can also use estradiol. That has also proven to improve the myocardial function in neurogenic stun myocardium. If despite all these pharmacological measures, the hemodynamics are still not maintained, we can go for more invasive modalities like intra-aortic balloon pump or ventricle assist devices. So another treatment, sometimes we can try to stop the sympathetic surge, is by the use of beta blockers, which can control the sympathetic effect on the myocardium. But it is controversial because beta blockers can decrease the blood pressure and can compromise the cerebral perfusion. Another drug is dexmedetomidine, which is a central sympathetic inhibitor, may be beneficial in this patient, but again has the similar side effects of bradycardia and hypertension, which may be deleterious for the patient with a compromised brain. And a few words about the potential organ donor. Sometimes because the patient is brain dead, they may also have this high sympathetic surge and neurogenic stun myocardium. There we should be more aggressive in treatment, and we should replace all the hormones which are deficit, and we should wait for the sympathetic surge to settle. So what should be the timing of the surgery? There are two schools of thought. One says that we have to wait till the sympathetic surge is over. Once sympathetic surge is over, you can proceed safely. But during this time, this waiting time, if the patient develops vasospasm and patient is having intact aneurysms, then the situation is very difficult to manage. There is another school of thought which state that whenever there is a neurogenic stun myocardium with the patient's stable physiology, like patient is not compromised hemodynamically and saturation is normal, then you may proceed for the definitive surgery of the patient. So nowadays, studies are trying to prove that improvement in neurological pathology leads to a rapid improvement in the cardiac function. So we should go for the definitive treatment of the patient, provided a physiological status of the patient permits us. This is a study conducted in our institute where we compare the ECG and echo changes in the patient with SAH before and after clipping. And what we found was in most of the patient, the ECG and echo changes were recovered in the post of day 1. A few patients took a longer time, but yes, definitely, we found that there was a little fastening of the recovery. Another study conducted in our institute was in TBI, and we also found here the significant regression of both ECG and echo changes in this patient post decompression. However, these two studies, they are prospective observational study. There is still a need of large multicentric control trial, especially in the patient who has a neurogenic myocardium, to see, yes, definitely, if we do a definitive intracranial procedure, then they improve. So we still need more research on this. So the take-home message is we have to recognize and treat the stent myocardium as soon as possible to maintain a constant supply of the brain. So, so that both these organs can again work together. Thank you for the kind attention.
Thank you, Dr. Asif. Thank you, Dr. Kiran. Now I am inviting Dr. Hemangi. And also speaker slide. She is Professor of Anesthesiology, LTM Medical College and Hospital, Sion, Mumbai. 37 years in anesthesia practice, neuroanesthesia, neurocritical care, trauma anesthesia, monitoring. Hargovind Foundation Medical Fellowship, visiting professor at Stanford University Hospital, Palo Alto, USA in 2000. Over 40 publications in journals and book chapters, editor, A Practical Approach to Anesthesia for Emergency Surgery, JP, published 2011. Her subject is recent trends in intracranial aneurysm surgery. Please, Dr. Hemangi.
Good evening, all. Coming to recent trends in intracranial aneurysm surgery. As we all know, intracranial aneurysm occurs in about 3% of general population, and it accounts for more than 80% of non-traumatic subarachnoid hemorrhage. Unfortunately, it carries very high mortality. The risk factors for this are genetic factors, smoking, hypertension, connective tissue disorders, alcohol abuse, and there is some female preponderance. The rupture of aneurysm occurs due to hemodynamic stress on the weak arterial wall, mainly hypertension, and it can lead to subarachnoid hemorrhage, intracranial or intraventricular hematoma. There can be multiple issues because of this. There can be mass effect, increased ICP, decreased autoregulation, loss of CO2 vasoreactivity, and there can be several complications also occurring secondary to rupture, like rebleeding, vasospasm, hydrocephalus, cardiopulmonary effects, and so on. The patient typically presents as a sudden onset headache. Loss of consciousness may occur. Hypertension, nausea, vomiting, seizures, focal neurological deficits, some of this might be present, and the diagnosis will be done with the CT scan and subsequent angiography. Assessment of the severity of the subarachnoid hemorrhage is based upon the Hunt and Hess grading, and WFNS grading is used, and the CT scan scale can be used using the Fisher scale. Higher the severity, higher the score, the severe is the disease, and there is a poor outcome. In addition, presence of large hematoma, posterior circulation aneurysm, and complications in advanced age are also predictors of poor outcome. So in this lecture, I will be touching upon recent trends in the diagnosis, current strategies for preventing complications, current trends in anesthesia techniques, as well as the surgical procedures. Typically, the diagnosis is done by the non-contrast CT scan, which is very highly sensitive for the subarachnoid hemorrhage, and once it is noted, then CT angiography will confirm the presence of aneurysm. But current trend is to use, in addition, digital subtraction angiography for diagnosis, and here the all anatomical features of the aneurysm can be seen even in the 3D presentation. So that is being done. Once diagnosed, the early management is for maintenance of the oxygenation and ventilation, control of intracranial hypertension, especially if the patient has got large hematomas. Mannitol or hypertonic saline may be given, and if the ventricles are dilated, external ventricular drain may be inserted. But a word of caution, sudden loss of CSF may reduce the ICP and it can lead to rebleeding. Rebleeding is also a greatest risk within the first 24 hours and carries very high mortality rate. The mainstay for management is controlling the hypertension, and for this the systolic BP should be kept below 180 according to the European guidelines and below 160 according to ASA guidelines. The maps are to be maintained between 90 to 110 millimeters of mercury. The definitive treatment, early securing of the ruptured aneurysm, is the mainstay. However, for some reason, if it cannot be done, then antifibrinolytics would be helpful. Vasospasm is another problem, complication which occurs in about 60 to 70% of the patients 3 to 14 days post-ictus, and mainly it occurs because of the vasoactive agents being released by the lysing clot lysis, and the nearest vessel is the most likely to get affected. It is also a major contributor for morbidity and mortality, and it should be prevented by starting oral nimodipine 60 mg 4 hourly at the earliest. It is a class 1 recommendation. If vasospasm has already occurred, then triple H therapy would be instituted traditionally. It involved hypertension, hypervolemia, and hemodilation. But this was associated with higher risk of complications. So the recent trend is to use only single H, that is the hypertension. Systolic BP is kept around 140-150 in unclipped aneurysm, and it can be raised further after surgery using the IV fluids and vasopressors. Euvolemia is maintained and hemodilution is not to be used. Higher grade aneurysms are also associated with cardiac and pulmonary effects. There can be pulmonary edema, ECG abnormalities, myocardial dysfunction, and these are usually the reversible but can be dangerous at times. Aspiration pneumonitis, ARDS can also occur. The mainly management is supportive and continue the management of underlying neurological insult. Other supportive care includes avoid hypotension, stop anticoagulants, analgesia, anticonvulsants, and cardiorespiratory support as and when required. Once the aneurysm is diagnosed, then the biggest question is what should be done about it, whether it should be surgically clipped or endovascularly coiled. There is enough evidence in favor of endovascular coiling nowadays. It reduces the complication rate and shorter length of stay is required. The current recommendations are secure it within 72 hours using whichever method is available. If both options are there, then coiling is recommended. Traditionally, surgical clipping was preferred in good Huntington's grade wide neck aneurysms of anterior circulation in good patients, younger patients, and patients with larger hematomas, whereas endovascular coiling was used for poor grade patients and very high risk patients. However, with the advanced technologies of endovascular coiling and all, even all types of aneurysms are more or less can be managed with the endovascular method. If the patient is coming for surgery, then there are multiple preoperative concerns, mainly neurological, like elevated ICP, impaired autoregulation, reactivity, vasospasm, arrhythmias, electrolytes, and so on. Unfortunately, because of the early surgery, there is less time for optimization. So the preoperative assessment has to be very thorough, and currently we do use methods like 2D echo, USG, ONST for assessment. Correct fluid and electrolyte status, anticonvulsants should be given, and have proper discussion with the surgical team for about surgical position as well as need for spatial monitoring. The goals of anesthesia include facilitating timely intervention, adequate anesthesia, optimizing systemic physiology, prevention of rebleeding while maintaining the perfusion, facilitating surgery, providing cerebral protection, and timely smooth emergence. The monitoring includes standard non-invasive monitoring. In addition, neuromuscular block and MAC monitoring should be used. Continuous intra-arterial pressure should be instituted, preferably prior to the induction. Central venous catheter. If EVD is already inserted, then intracranial pressure can be measured. And for cardiac compromised patients, invasive or now more trend is towards the non-invasive cardiac output method should be used. PPV, SVV will help in the fluid therapy, and BIS and cerebral oximetry are being more commonly used. Anesthesia techniques or drugs have not significantly changed much. Sedative premedication is avoided. IV induction is usually with the titrated dose of thiopental or propofol, or if the patient is cardiac patient, then etomidate. Minimize hyperdynamic response to the laryngoscopy and intubation, and for that ensure adequate depth of anesthesia and paralysis by MAC monitoring and NMT monitoring. Maintenance can be either inhalational or propofol infusion with or without nitrous oxide. The current trend is towards using propofol and no nitrous oxide. Shorter acting drugs are preferred and maintain normocarbia. Scalp now block is really taking place nowadays because it provides the complete analgesia and some sort of modified ERAS protocols in some way. Most of the institutes are using, like goal directed fluid therapy and so on. Propofol based TIVA have been found to be associated with better cerebral oxygenation and neurological profile as compared to the sevoflurane based inhalational anesthesia. So that is the recent trend. The surgeons nowadays are preferring to do the surgery without using the retractor, as it is associated with the retraction injury and regional ischemia. But to be able to do so, we need to give some basic measures for brain relaxation, and it can be done using the mannitol, furosemide, EVD, lumbar CSF drain inserted immediately after the induction, but opened only at the dural opening, TIVA or hyperventilation. Intraoperative BP management is extremely important, and we have to balance between the preventing rupture of the aneurysm versus avoiding ischemia. Avoid rise in BP during induction, maintain normovolemia. About 10 to 15% reduction in the MAPS at craniotomy is usually done as the ICP reduces. Propofol and isoflurane are useful in BP manipulation, and further decrease in BP at vascular dissection is the common norm for giving induced hypotension. But suddenly, if the BP goes down, phenylephrine small boluses may be needed. But not all patients can tolerate the induced hypotension. If the patient is normotensive and good grade SH, then the patient is likely to tolerate the hypotension well, and here reduction of MAPS by 20 to 25% below the baseline would be appropriate. But if the patient is having poor clinical grade, that patient is prone to ischemia, and therefore the CPP must be maintained above 70 millimeters of mercury. Temporary clipping of feeding artery is another alternative to be used instead of the induced hypotension. However, this is also associated with the risk of regional ischemia. So try to maintain the temporary clipping time as short as possible. Hypertension instead of hypotension should be used to improve the collateral supply, reduce the cerebral metabolic oxygen demand, and monitor for ischemia. If the clip is required for a longer time, then cerebral protective measures may be required, like mannitol, Sendai cocktail, passive hypothermia until clipping, and for prolonged clipping, even thiopental or propofol burst suppression dose may be needed. Other modalities include ischemic preconditioning, isoflurane, calcium channel blocker, lignocaine. Some of this may be used, but avoid hypoxia, hyperthermia, seizures, and hyperglycemia. Another technique during aneurysm clipping which is coming up is adenosine-induced temporary cardiac arrest. Here, before instituting the cardiac arrest, transcutaneous pacing pads must be applied, propofol burst suppression must be given, and the adenosine 0.3 to 0.4 milligram per kg may be used to transiently cause the circulatory arrest while the surgeon is doing the quick clipping, dissection and clipping. Avoid this procedure in the coronary disease patient or conduction abnormalities, and whether this is better or temporary clipping is better is yet to be studied. However, a word of caution, there are instances of need for CPR, patients going into atrial fibrillation, and need for temporary pacing with this technique, so one has to be careful. Another alternative is rapid ventricular pacing. So instead of causing cardiac arrest, the BP is drastically reduced with this technique using the electrodes placed in the right ventricle through the IJV. External defibrillating pads are used and the pacing is started at 180 beats per minute. This allows the better control of the pressures as well as the start time and the length of the pacing as compared to the adenosine. However, the duration should be minimized. Both these techniques require extensive preoperative cardiological workup and experienced team is needed. Hence, it is reserved only for selective cases in highly specialized centers. Most of these techniques are associated with the ischemia. So, the intraoperative neurophysiological monitoring would be useful. The different modalities that have been used are electroencephalogram to identify ischemia. Somatosensory evoked potential will monitor the somatosensory cortex, whereas for posterior circulation aneurysms, the auditory evoked potentials would be useful. But one of the commonly upcoming technique is the transcranial motor evoked potentials. It not only monitors the motor cortex, but also subcortex. Subcortical pathways are supplied by the lenticular striate arteries, which are likely to be compromised during the clipping. So that also can be monitored with this. However, there are certain limitations, like the patient movement may occur and there are some difficulties in interpreting the MEP amplitude, especially in the multiple complicated patients like extremes of age or diabetes. Depending upon the location of the aneurysm, the recording sites for both SSAP as well as MEP may change. Anesthesia dramatically influences the neurophysiological monitoring, and therefore, because of this, there can be erroneous interpretation. So, typical anesthesia should be propofol infusion with fentanyl infusion rather than boluses. And inhalationals, if they are to be used, then we should restrict it to 0.5 max only. Ensure recovery from the neuromuscular blockade. And if burst suppression is to be used, then the new baseline MEPs must be monitored and then only the clipping should be used. Surgical methods also have seen certain recent trends for the vascular perfusion. The aim of the surgeon is to have complete obliteration of the aneurysm while preserving all the vessels. So for this, indocyanine green video angiography is one of the commonly used one. Within seconds of injection, the vessels can be highlighted and one can see that the aneurysm is not being filled while all vessels are intact. If the clip is not appropriate, it can be repositioned immediately before the ischemia develops. Even though this is a relatively safe compound, anaphylaxis have been observed, so one has to be careful. It usually does not change the hemodynamics, but it can cause a decrease in the SpO2 transiently, and it increases the cerebral oximetry for some time. So our interpretation needs to be done accordingly. Fluorescein sodium is another dye used for the similar purposes safely. And one upcoming technique in the neurosurgical practice is the laser speckle contrast imaging. It is a promising tool. It provides the real-time full field blood flow mapping non-invasively and without using the dye. So it can be used for several time duration and it will help the surgeon in identifying the perfusion as well as aneurysm adequacy, blocking adequacy. Doppler has been used for checking the flow in the distal vessels after the clipping, but now it can be quantitatively measured. So as compared to the previous, if it is reduced after the clipping, then immediately the clip can be repositioned and ischemia can be prevented. Intraoperative DSA will definitely tell about the adequacy of the clipping properly. However, it is very challenging to implement and requires very prolonged time frame, including shift of patient. So the current tendency is to use the combination of intraoperative ICG and postoperative DSA. Aneurysm can rupture intraoperatively, especially during the dissection and near the clipping time. So one should always be ready for this, always have the large bore IV access available, cross-match blood readily available and all. And if it occurs, then the anesthesiologist must manage the blood loss, giving the IV fluids, maintain the normovolemia. Hypothermia here might be useful and neuroprotection may be required, while the surgeon would be applying either the permanent clip or a temporary clip might be used. If they are using the temporary clipping, then induced hypotension should not be used. Therefore, good communication with the surgeon is essential. Not all aneurysms are amenable to simple clipping. Some of the complex aneurysms may require the trapping of the parent vessel or vascular reconstruction as shown in the figures. So in these cases, always expect prolonged temporary clipping, large blood loss, and need for cerebral protection. Emergence should be controlled but swift. Continue control of the MAPS and ICP, adequate analgesia, antiemetic should be given, and evaluate neurological status at the earliest, and continue the monitoring in the ICU for post-op problems. A few words about endovascular coiling. Most of the anesthesia principles are same as the surgery, but here the brain relaxation and neurophysiological monitoring is rarely used. In addition, there are several issues like remote location anesthesia, limited patient access, need for anticoagulation, contrast media, radiation hazard, and there are the risks of thromboembolic events as well as the bleeding. So one has to be careful about this. Post-operatively, vasospasm should be detected at the earliest. Typically, CT angiography or DSA can be done, but these are a one-time or maybe two-times investigations. Every day, transcranial Doppler may be used in the ICU sequentially to early identification of the vasospasm. Similarly, delayed cerebral ischemia is also a devastating complication, and that also can be detected early by using the cerebral oximetry or cerebral microdialysis biomarkers if available. So that appropriate treatment can be started at the earliest in the form of nimodipine, single-agent therapy, statins if the patient are already taking. Interestingly, ketamine sedation has been found to reduce the DCI-related infarctions, and hyperbaric oxygen also has been useful. Future strategies include pure endoscopic clipping of the aneurysm, use of exoscopes, quantitative MR angiography, and sutureless vascular anastomosis. So that may come up shortly. So to conclude, intracranial aneurysm causing subarachnoid hemorrhage is acute neurological emergency. Perioperative management should focus on optimizing the systemic physiology. One should be aware of the recent trends in the surgery and anesthesia, and the anesthesia technique and monitoring should be individualized based on the patient's medical condition, proposed intervention using the current technologies. Thank you. Thank you, ISA, and thank you, organizers of Isacon 2021.
Thank you, Dr. Hemangi. We have a wonderful session starting from tight brain to brain margin correction, recent advances in neuro monitoring, and lastly, the recent trends in intracranial aneurysmal surgeries. Now, the session is open for question, answer, and discussion. Any questions? ક્વેશ્ચન્સ કરું કોઈને કરવું હોય તો અનમ્યુટ કરવું પડશે તમારે. હા, ઓડિયન્સ ઓડિયન્સ હા કરી શકશે. ઓકે.
Any question?
Any questions? Anybody? I don't think they can ask. I have one question for Dimple. Hello?
Yes, madam.
Yes. Dimple, you have narrated so many prevention and usually in traumatic brain cases.
Yes, madam.
Yeah. Please.
Please pardon, madam. I cannot hear.
Hello?
Madam. Yes, madam.
Yes. I welcome Dr. Santosh Prabhu. Sir?
It's Sujata Prabhu actually. I'm using my husband's
Okay.
laptop.
Okay. Dimple?
Yes, madam.
Yes. What is the usual?
Hello.
Hello, there is volume problem.
Prevent tight syndrome.
Hello, madam. I cannot hear properly whole sentence.
Okay. Any question from the audience?
Please repeat, madam.
इंटरनेट बंद कर दी तुझे तो मेरा तो मोबाइल डेटा चालू है Hello, Dimple? Can you hear me?
Yes, madam.
Okay.
Yes, madam.
My question to you is, what are you usually practicing for traumatic brain cases to prevent tight brain syndrome? What are your usual practice to prevent it?
We are giving proper analgesic, and we are also using mannitol and hyperventilation.
And what are the usual monitoring you are having?
We are using just routine monitors, madam. NIBP, ECG, pulse oximetry, and like that. We are not using special monitors like ICP or.
I'm thankful to ISS City branch, my own Gujarat state branch, for inviting me as a chairperson. And I'm thankful to all the 4 speakers. And especially, I'm thankful to Dr. Kiran. It was a wonderful presentation on brain and heart. Heart affects brain and brain affects heart. We know it. Then to whom we should give more marks? To the heart or the brain? Okay. Thank you very much. Any questions from the audience? Okay. Dr. Rasik bhai? Okay. Okay. Unmute karo ne Rasik bhai ne. તમે unmute karo. He wants to ask. Unmute karo Rasik bhai ne. Huh? તમે જ છો? Oh.
She will have to unmute.
Okay. Madam, do you want to say anything? Any concluding remark? No?
Not able to. About, I would like to. Hello, can you hear me? Everybody is muted, I think.
Yes, madam, I can hear you.
When you ask that question about how would you like to manage the tight brain?
How I like to manage tight brain.
Yeah. I would like to just add to this when you said all your things you mentioned, but I think when we are having tight brain and use of propofol infusion nowadays really is very helpful, because I have seen this intraoperatively.
Yes,
so using usual techniques, but addition of propofol by syringe pump really helps. And if you have a traumatic brain getting operated, we normally ventilate these patients post-operatively, and a very good sedation that is available now for next say less than 24 hours is continue the propofol infusion in this patient. It really helps patients really come out well. And
Okay,
by
ma'am.
the next afternoon, I think the neurosurgeons can really make out the neurological status of the patient very well. Because, as soon as you discontinue propofol, the patient are not in that typical sedated state. So for controlling traumatic, tight brain intraoperatively and then continuing the propofol in post-operative period, it's a very helpful.
Okay, thank you, madam. Thank you for sharing this experience, madam.
Yes, and now you are getting 2% propofol also. So lipid overload is also reduced.
Okay.
Okay, that's what I wanted to tell them. Thank you. Very nice presentations by everybody.
Thank you, madam.
And Dr. Hemangini is really covered aneurysm so briefly and covered almost everything. Everybody's done a very good job.
Thank you, Dr. Sujat.
Thank you, madam.
Thank you all. Thank you all.
Thank you all. Now,
thank you, madam.
Now let us go for the inauguration function. It is due at 7 p.m. right now. I welcome you all. It will be physical as well as virtual. Thank you very much. Thank you all.
Thank you, everybody.